I'll be discussing key important points about how to write an exam in terms of marks distribution that you have when you approach a 3 marks question, when you approach a 5 marks question, or when you approach a 10 marks question, right? So we'll try to understand that when an examiner is correcting a paper, what is the expected component in each individual of this, right? So we'll create, sir, I mean answers from Bailey. Beta, you will get answers from Bailey only, so don't worry about it. We will give you the top-notch information and that too in the best form as well. Okay, so don't worry about it. Now, there is a standard performer in which we would expect an answer. So we'll talk about the performer in which I would ask a particular, whenever we're talking about any discussion or any topic, how to approach an answer. Now, the first thing in the performer that I would expect is going to be a definition. It is going to define a particular component or start with simple definition. So first is the definition. Second, once you have defined it, if there is a pathophysiology, a quick line on the pathophysiology of the disease. If you have no pathophysiology, then you will move on to the third point, that is going to be the clinical features. Once you have done the clinical features, based upon the clinical features, if there are any differential diagnosis, you will mention a differential diagnosis. Then it is about investigation. And if there are any findings on investigation, then you can. After investigation, it is going to be management. Now, if the management is surgical, always mention about the post-operative complications. The expected post-operative complications and the management of it, right? So whenever you will write any answer, right? Any answer, this is the performer that you're going to follow, but this performer is going to hold for a 10 marks question. So when you are approaching a 10 marks question, you will define whatever, let's say you're talking about wound or an ulcer, you will say what is an ulcer? It is breach in the continuity of the epithelium or the mucosal membrane due to microscopic death of tissue as well as tissue necrosis. That is what an ulcer is defined as. So first is definition. Then the pathophysiology. In the pathophysiology, if the pathophysiology is not there, then you can talk about the causes of that particular disease. If these causes are not there, you can talk about a risk factor. Now, for example, if there's a question on breast cancer, they would want you to tell the risk factors of breast cancer. In the risk factors of breast cancer, you should know what are the modifiable risk factors, what are non-modifiable risk factors. Just quickly write 4 points or the 4 risk factors that are present. Once you're done with the risk factors, how the patient presents to you and what are the differential diagnoses based upon, see, whatever the clinical features that you have written, and the same, like for example, patient presents to you with a huge lump rapidly growing in size and then it is infiltrating the skin as well. There's an ulceration. So you have 2 components. Either it could be a phylloids or it could be a breast cancer, right? Now phylloids, again, age of presentation, if it is under 40, more likely to be phylloids, more than 40, more likely to be malignancy. That is how you're going to describe it. Then we'll go into the investigation. After the investigation, we'll talk about the management. In the management, always mention if it is the first, for example, we're talking about inflammatory bowel disease. In an IBD or an inflammatory bowel disease, the first line of management is always a medical management. Refractory IBDs. For Crohn's disease, if the patient presents with obstruction, you go with intervention. In ulcerative colitis, if it is a fulminant or ulcerative colitis, then you will go ahead and then move on to surgical. That is a total proctal colectomy with IOL anastomosis with J-pouch, right? All these are going to be there in the management and the post-operative complication. Now, in a 10 marks question, where would we expect a diagram? Usually, whenever we talk about the management, this is where the diagram is going to be helpful. If you're talking about the pathophysiology, in the pathophysiology, I would expect a diagram, right? Nowhere else that I'll be keen on diagrams, so you need to be precise wherever possible. Whenever you are talking about differential diagnosis, if possible, give a table. Now, table is going to be comparison between the 2 differentials or 3 differentials I'm talking about, and how do you differentiate that in a quick succession. If you follow this performer, no, if it is a 3 marks question, the 3 marks question usually holds 1 or 2 points, right? Now, if they say about fibroadenoma, you define pathophysiology, clinical features, and management. So if the first 3 is to be there, it is for 3 marks. For a 5 marks, I will go ahead with each individual point, but only write until the management, that is a 5 marks, and the entire set has to be followed. This is going to be a 10 marks question. Simple, right? So you now know that what to write for 3 marks, what to write for 5 marks, what is to write for 10 marks question. If you follow this performer in your exam, every single examiner is going to just love the representation and they'll go through it. You need to understand the examiner's mindset also, because they have to correct a lot of question papers. See, the key is going to be handwriting. You have to make sure if your handwriting is not good, but write neatly. Underline whatever is the important points. Highlight, you just need to underline. For example, you're writing a topic, clinical features, underline it. Then put points, because when you write in points, they know that you're not cooking up story. When you start writing in paragraphs, that is when they know it is going to be a story representation, right? So this is the key components that I wanted to tell you about how to write an answer, especially in a surgery paper. So let's dig into your previous exam questions and then we'll try to discuss each one of them. So today I'll be discussing the various questions. The first question is going to be about the wounds. So I'm just going to summarize all the questions that we found on wounds and I'll tell you how to write about it, right? Now, the question was define different kinds of wounds or ulcer, right? Then they're asked about the wound healing, that is the phases of wound healing. Phases of wound healing was an exam question. Phases of wound healing. There's a question that is factors affecting wound healing, or as in delaying wound healing. Factors delaying wound healing. So you have phases of wound healing, factors that delays the wound healing, ulcer and management, ulcer and its management. They've asked you specifically about the pressure ulcer. They've asked you specifically about the pressure ulcer. Classification of surgical wounds. Classification of surgical wounds. And the last question on wounds that they asked you is surgical site infection. SSI stands for surgical site infection. So whenever a question is being asked, that we have gone through all the university questions that are present. So these are the usual questions that they ask you from the wound, right? Now, if you look at each individual one, no, your phase of wound healing is a 3-mark question. Factors delaying wound healing is a 3 marks question. Ulcer management is 3 marks. Pressure ulcer its management is 5 marks. Classification of surgical wound is going to be 5 marks. Surgical site infection is going to be 5 marks. And if they add 2-3 components, it will become 10 marks, right? So this is the marks distribution that you have for each individual topic per se. So let's say you're attempting this question, how would you like to write about it? So we'll talk about the phases of wound healing. How are you going to present it? I'm going to keep it very crisp so that you understand and how to write about your answer. So the answer to this question, the first one is going to be the phases of wound healing. So before we start the phases of wound healing, in the phases of wound healing, if the question is determined in this particular form, right? In the phases of wound healing, the first thing you will determine that it is going to be an acute or chronic wound. So we're talking about all the phases that we're talking about. It is about the acute phases of the wound healing. So we'll divide. So when you're writing the answer, divide them into 3 components. The phases of wound healing, that is the acute wound healing, can be divided into 3 subphases. They can be divided into 3 subphases and mention all these 3 subphases. What are the 3 subphases of the wound healing? I hope everybody knows it. You have an early phase, you have an intermediate phase, you have an early phase, the intermediate phase, and the late phase of wound healing, right? Now they'll ask you what are the components that present to you as an early phase of the wound healing. In an early phase, the first phase of the wound healing is going to be hemostasis. And the second phase is going to be inflammation. The second phase is going to be inflammation. Now, in the intermediate phase, you will have fibroblast migration. You have the fibroblast migration. Then you have angiogenesis. Fibroblast migration, angiogenesis, and epithelialization. And the epithelialization, right? These are your intermediate. What are the late phases? The late phase would be your collagen synthesis. Your collagen synthesis. Your wound contraction. And the last phase of the wound healing is going to be scar formation and remodeling. It is the scar formation and remodeling. It is the scar formation and remodeling, right? Where types of ulcer we're going to discuss, no, where the ulcer and its management, will talk about all the different types of ulcers. We'll cover everything. Okay. Now, whenever they ask you about the phase of wound healing, first write this. The minute you write this, the examiner knows that you know there are 3 different phases of wound healing. That is going to be an early, intermediate, and late phase, right? Now, they also want to know whether you know that what are the timelines of the wound healing. Now, the timelines of the wound healing. So the next side heading that you will see is the timeline of wound healing. Now, in the timeline of the wound healing, you should know that which of the following starts at what point and ends at what point. That means hemostasis starts when, inflammation is going to start when, stop when, all that are important, right? So in the timeline of the wound healing, I'm just going to take the entire subset of the wound healing into one linear progression, right? So let's say this is the timeline of the wound healing. Just draw a single line. The start point is what we call it as the day the wound was created. So this is going to be your day 0. This is going to be day 0, the day patient had a wound being created or the wound was formed. And the last one is going to be at the end of the 6th week. So the acute phase of the wound healing starts from day 0 to 6th week, right? Now what you're going to do is you're going to divide this entire wound component into day 1. That is the day 1. This is day 2. This is day 3. This is day 4. This is day 5. This is day 6. And let's say this is day 7. After that, this will be your 2nd week. This is going to be your 3rd week. This is going to be your 4th week. This is your 5th week. And at the end, you have the 6th week, right? So these are the phases of the wound healing starting from day 0 all the way to day 6. Now, in the timelines of wound healing, you will write everything that is going to start above this. So this is the start point. And this is going to be the end point, right? Now, on day 0, what is going to start? Remember, on day 0, there are 2 events that are going to start. Number 1, there will be hemostasis. And number 2, there is a phase of inflammation. The hemostasis and the phase of inflammation starts on day 0. What ends on day 0? Again, it is the hemostasis. It is the hemostasis that ends on day 0 as well. So what starts on day 0? It is the hemostasis inflammation. What ends? It is going to be hemostasis. When does the inflammation end? Remember, the inflammation is going to end on day 4. So inflammation starts on day 0, but it is going to end on day 4, right? The first day is going to be a holiday. There is nothing which is going to happen on day 1. On day 2, you will notice there will be fibroblast migration would start. So on day 2, what is the event that you are looking at? It is the fibroblast migration. Now the fibroblast migration starts on day 2, but the fibroblast migration, it is going to end on day 4. Starts on day 2, ends on day 4, right? So what is going to happen on day 3? Remember, day 3 is the day when the collagen synthesis would start. Now, very important thing is the collagen synthesis starts on day 3, but the synthesis is going to be very, very little until the 2nd week. Now, once it hits the 2nd week, from the 2nd week, it is going to shoot up. So there is a sudden increase in collagen synthesis called as the acceleration phase. And then it peaks onto the 4th week, and then it starts declining. And by the end of the 6th week, it plateaus off, right? So in the collagen synthesis, you need to tell that the peak of the collagen synthesis, is going to be at the 4th week. From the 2nd week, it is going to be accelerating phase. This is going to be the accelerating phase. And after the 4th week, it decelerates. And by the 6th week, it plateaus off. That is in terms of collagen synthesis. On day 4, what is going to start? In day 4, you will see the wound contraction. It is the wound contraction that starts on day 4. And this is going to end anywhere between 2nd to 3rd week, usually by the 3rd week. So the wound contraction ends. Now, one thing that you need to know that is scar remodeling will take 15 to 18 months or almost approximately 2 years. So the one point that you can add at the end in the entire discussion, that you can say the scar remodeling is going to last for approximately 2 years. So it continues to go ahead with remodeling for 2 years, right? Now, if they ask you the phases of wound healing, in the phase of wound healing, if they have asked you for a 3 marks question, this is what is expected from you, right? If you write this much, you will never, like, no examiner is going to take anything out of your pocket. In fact, they will give you 3. 3 out of 3 is bound to be there in your exam paper, right? So that the early phases, the intermediate phase, and the late phase of the wound healing, right? Now, once you've written this, next comes is going to be, so we have first part, phases of wound healing, we have already determined. Next is going to be about your factors that delay the wound healing, right? So factors delaying wound healing. Factors delaying wound healing. So factors that delay wound healing is your second question, right? So when I talk about factors that delay the wound healing, I'm going to write them into 3 contexts. That is going to be your intrinsic and the extrinsic factors. So you immediately make them into 2 separate tables. We say the intrinsic and the extrinsic factors. The intrinsic and the extrinsic factors. So what do you mean by this intrinsic and extrinsic factor? Just for the easy way to remember it, when we say an intrinsic factor, the factors are localized to the wound site. Extrinsic factors, they're not localized to wound site, but they're present in the body at a systemic cause, right? Now, when you look at the intrinsic factors, what are the examples of the intrinsic factor? Presence of foreign body in the wound. Presence of foreign body inside the wound. Presence of a necrotic tissue within the wound site. Recurrent trauma to the wound site. Recurrent trauma to the wound site. If the wound is associated with hypoxia or ischemia. If the wound is associated with hypoxia as well as ischemia, if it is secondary to venous insufficiency. The best example of a wound that is created by a venous insufficiency is going to be a varicose vein. Along with that, presence of an active infection. Presence of an active infection, and if a wound is due to a radiation exposure, or it's a wound that is created due to radiation status. Extrinsic factors, which are going to be systemic factors, not the local factors. So rather than saying intrinsic, you can also use local factors. We can name them as the local factors. Extrinsic factor is what we call it as systemic factors. We can call this as systemic factors. Now look at the extrinsic or the systemic factors. Best example is going to be your diabetic patient. It's a diabetic mellitus. The diabetic patients. Diabetic mellitus. Then you have smokers. Smoking causes poor collagen synthesis, and poor collagen will result in poor wound healing. So there's diabetes, there is smoking, usage of steroids, patient who already have a collagen vascular disease, patient with a collagen vascular disease. If it is secondary to a malignancy, patient who is going to have jaundice. So jaundice, which is usually associated with chronic liver disease. Example like cirrhosis. Along with jaundice, if it is going to be uremia, uremia is associated with chronic kidney disease. Uremia is associated with that of the chronic kidney disease, right? So these are the factors that are going to cause delayed wound healing. Now you've divided them into two components, the intrinsic and the extrinsic factors, and this is your 3 marks question, right? So if they ask you for 3 marks, these are the various factors that you have to write. And obviously, whenever you're writing an answer, always start with the definition and then go ahead with these ones. So that just gives you more add-on points, right? Now, so these are the factors that delay the wound healing, right? So we have completed the first one, that is going to be the phases of wound healing, factors that delay the wound healing, right? The third question is going to be your ulcer and its management, right? So we'll talk about the types of ulcer and the ulcers management. So we'll talk about the various types of ulcer. So when it comes down to ulcer, now the basic classification of an ulcer, first is the definition itself. So define ulcer. Ulcer is a breach in continuity of epithelium, an epithelium or a mucous membrane, due to microscopic death of tissue associated with necrosis. It is associated with necrosis is what we call it as ulcer, right? That's the first point you write. Then when you're going to classify ulcer, so the second point will be your ulcer classification. Now, whenever we classify ulcer, the ulcers are classified predominantly into 3 varieties. They are going to be healing ulcers, spreading ulcers, and callus. So we divide them into 3 subcategories. We have the healing ulcer, we have the spreading ulcer, and then you have callus. Now, what is a callus? Callus ulcer is basically chronic non-healing ulcer. It is a chronic non-healing ulcer. Now, please do not make a mistake as writing non-healing ulcer as a type. It does not exist, right? Either the ulcer is healing or it is spreading or callus. Callus is a variety of a non-healing ulcer where you have because of chronic inflammation, right? So chronic non-healing ulcer is what we call it as the callus ulcers. The minute you say these, then they would expect the parts of the ulcer. So the next point that you will immediately write is going to be the parts of ulcer. Now, if this is where you have to come up with a diagram. So in a parts of the ulcer, this is the normal skin surface. This is going to be the ulcer. This is where it is going to rest upon, right? So let's say if this is the wound bed that you're talking about, and this is where it is going to rest upon, right? The ulcer is sitting on top of here, and this is the skin surface, and let's say this is the ulcer that is breached. Remember, you need to learn how to draw stick diagrams, which is going to be very important and handy in the exam as well. Because if you draw neatly and if you draw well, all your explanation is going to be covered there and then itself, right? Now, what are the parts of the ulcer? Now, when you look at this, this is the normal skin. This is the normal skin that you have, and this portion that you're seeing is in the ulcer. Now, the junction between the normal skin and the ulcer, it is what we call it as the margin. So when you write like this, always mention margin is the junction. It is the junction between the normal skin and ulcer. Then you see this area which is touching, the area that is resting on the lower part, which you see here, this is what we call it as the floor of the ulcer, right? Now, on which what is resting, this is what we call it as the base of the ulcer. Now, floor is the most dependent part of the ulcer. This is the most dependent. This is the most dependent part of the ulcer. The base of the ulcer, is basically on which it is going to rest on. So it is the resting surface of the ulcer. It is the resting surface of the ulcer. Next, you can see this area. So the area that is going to be present, between the edge, right, between the margin and the floor, this is what we call it as the edge of the ulcer. This is what we call it as the edge of the ulcer. So between the margin and the floor, you will see, right, it is going to be between the margin and the floor, you will see the edge of the ulcer, right? So edge of the ulcer is that part of the ulcer, it is between the margin and the floor of the ulcer. And the floor of the ulcer. Now, if you want to impress your examiners, you can add another point in the edge. Metabolically, the most active site of the ulcer. As a note point, you can write here, you can say metabolically most active site. Metabolically, the most active site of the ulcer is the edge. That is why whenever you're suspecting any malignant ulcer, you'll always take an edge biopsy. You'll always say an edge biopsy, right? So these are the various parts of the ulcer and their significance. I have given it to you. The same diagram you have to replicate in your exam. It's a sticks line diagram. Anybody can draw it. Just make sure you practice once and you know exact positions, right? So you should mark it down where exactly you have the margin, where exactly is the floor, and where exactly you can see the edge of the ulcer. Remember, edge is the metabolically most active site. Edge happens to be metabolically the most active site of the ulcer. It is metabolically the most active site of the ulcer. Okay? Now, once you've done the parts of the ulcer, then you talk about, based upon the edge, you can classify ulcers, right? So talk about the various ulcers based upon the edge. So ulcer based upon the edge that you can classify. Now look at the edges. There are different kinds of edges that you have. The first one that you will see is what we call it as a sloping edge. So you just draw a small line diagram, make the ulcer slope in, and like this. This is what we call it as a sloping edge. It is called as a sloping edge because imagine that if you're sitting at the edge of the ulcer, you will just simply slide into the ulcer. So hence it is called as a sloping edge. Right? Now, the first type is going to be the sloping edge ulcer. This is going to be a sloping edge of the ulcer. This is going to be a sloping edge of the ulcer. So where do you see the sloping edge? The first condition that you will see, it is going to be present in all healing ulcers. The second one that you will see, it is going to be on the venous ulcers. It is going to be the venous ulcers. Now, as we all know, venous ulcers are seen in varicose veins. Okay? So when you talk about it, there we'll talk about the characteristics of venous ulcer also. But for now, you remember the sloping edge is seen in your healing ulcers and the venous ulcer. The second one that you will see is going to be an edge which is going to dig in, and that is going to be your undermined edge. This is what we call it as an undermined edge. Why it is called as an undermined edge? If you are here, if you are standing here, you can go under the ulcer. You can travel deep into the ulcer. So it is called as an undermined edge, right? This is what we call it as an undermined edge. This is what we call it as an undermined edge. Undermined edges are seen in your tubercular ulcer. That is because of TB. It is seen in the tubercular ulcer and the necrotizing fasciitis. And the necrotizing fasciitis. And the necrotizing fasciitis, right? This is about your undermined edge. Now the third edge that you will see, it is going to be a punched out edge. So you will see this is the surface of the skin. You will see this is the ulcer depth, but you will see the ulcer is going to elevate above the surface of the skin. So if you see this is the ulcer's border, you will see the ulcer will be like this, right? So if the ulcer's edge elevates above the margin, this is what we call it as the punched out edge. So this is what we call it as the punched. This is what we call it as the punched out edge. Now, where do you see a punched out edge? It is seen in your syphilitic ulcer. It is seen in the syphilitic ulcer and also in your diabetic foot, that is your trophic ulcer. So it is the punched out edge, or also called as the syphilitic ulcer or is in trophic ulcer. Another variety of the ulcer edge that you will see, it is going to be raised and everted. So again, you take this as the representation of the skin. This happens to be the ulcer. And when you see the ulcer's edge, so this is the ulcer that is present. You see it is going to go up and it is going to present like this. So the edge is growing over the normal skin. So if the edge protrudes and then grows over the normal skin, and you can dig between these two areas, this is what we call it as raised and everted. It is going to be your raised and everted edge. This is your raised and everted. So in a raised and everted edge is a characteristic feature of squamous cell carcinoma of the skin. This is seen in the squamous cell cancer of the skin, or it is also seen in Marjolin's ulcer. See, remember, Marjolin's ulcer is nothing but a squamous cell cancer, but Marjolin's, if you want to be more precise, this is what we call it as a low grade squamous cell cancer of the skin, usually seen post burns. This is usually seen post burns. So this is what we call as post burn ulcer, right? It is going to be seen in post burn ulcers. See, it is not somebody saying undermined edges are seen in all granulomatous diseases. Okay, wherever you have active proliferation of a disease, there you can have an undermined one, right? Example like necrotizing fasciitis, tubercular ulcers. If you talk about, there are certain ulcers which are secondary to an ischemic status, right? But not the diabetic foot ones. That is because of microangiopathy, right? There's a difference. So the last one that you have, the last one is going to be your raised and beaded. So again, you determine this is the ulcer. This time you see this is the ulcer's edge, base and all. And then you see the ulcer at the tip looks like this. So it's not going over the skin, but you see that bluntness and raising above it. the bluntness of the ulcer, and it raises above the skin surface. So this is what we call it as. This is what we call it as raised and beaded. Now these beads are because of keratin pearls. They look like shiny keratin pearls. Right? Now this raised and beaded is seen in the basal cell carcinoma. It is seen in the basal cell carcinoma of the skin. It is in basal cell carcinoma of the skin. Right? So when we talk about the skin malignancies, we'll quickly discuss those as a smaller topics as well. But this is what is going to be asked in an exam. You are expected to draw all these in a quick succession, give at least 2 examples of each. And the last one you have to give one example so that you precisely are able to answer the question as it is asked, right? So these are about the various edges of the ulcer and its presentation, right? Now, once you talk about ulcer, once you're done with the ulcer, you always talk about the management of the ulcer. Now, ulcer management. Now, in the ulcers management, it is a stepwise approach. What is the first thing? Whenever a patient comes down to ulcer, you have to make sure the ulcer's base and the floor and the edge is clean, right? So the first one is going to be cleaning and debridement. It is a cleaning and debridement of the ulcer. There will be cleaning and debridement of ulcer. Second thing, you have to start the patient on antibiotic coverage. Start the patient on antibiotics. After that, if there is any factors, right? So, okay, whenever you talk about cleaning and debridement, it will take care of local factors. Then always address the comorbidities. So manage comorbidity. Now, when we talk about management of the comorbidity, you have to manage diabetes. You have to manage if the patient is having CKD, if the patient is having jaundice, all that has to be managed. Otherwise, these wounds will not heal, right? So, cleaning and debridement, antibiotic coverage, and manage comorbidities are the important steps in the ulcer management, right? Along with that, if there is ulcers because some specific cause, the fourth one is going to be to treat the underlying cause. To treat the underlying cause. To treat the underlying cause, right? So this is how you are going to go with ulcers management, right? So we finished 4 questions which are being asked in our exam, right? So we spoke about the phases of wound healing, factors delaying the wound healing, ulcer management. Now we'll discuss about the pressure ulcers, right? Again, pressure ulcer is usually a 5 marks question, so they will expect you to give a little bit of details. Here and there you should have to speak about it, and then we'll talk about the components as well. So the next topic that we'll talk about in this is going to be pressure ulcer. Now the question can come to you as a pressure ulcer. They can give you another synonym, that is your Decubitus ulcer. This is also called as the Decubitus ulcer. This is also called as bed sore. It is also called as the pressure sore. So all these are the synonyms that you remember. So it is a pressure ulcer, or you can say Decubitus ulcer, a bed sore, or a pressure sore. Now, what are the different things that are determined here? The first one is the definition of a pressure ulcer. It is an ulcer formed. It is an ulcer formed due to persistent pressure. Due to a persistent pressure over an area exceeding capillary occlusive pressure, exceeding capillary occlusive pressure for significant time. For a significant time is what we call it as the pathophysiology, right? So this is the pathophysiology. Just mention it as P. It is the definition as well as the pathophysiology of a pressure ulcer. It is the ulcer formed due to a persistent pressure over an area exceeding the capillary occlusive pressure for a significant period of time. Now, what is this capillary occlusive pressure? Remember, the capillary occlusive pressure is at 30 millimeters of mercury pressure. Now, if a pressure is more than 30 millimeters and it is for a longer duration of time, it will cause hypoxia and ischemia. It is going to be hypoxia as well as ischemia. Somebody is saying कि voice गूंज रही है. Beta, I don't. Anybody else having any issue with the audio? किसी और को लग रहा है कि आवाज गूंज रही है? ऐसा लग रहा है कि बज रहा है क्या? कान बज रहे हैं? नहीं ना? ठीक है. हाँ, तो जब हम प्रेशर अल्सर्स और डिक्यूबिटस अल्सर्स की बात कर रहे हैं, बेटा क्लासिफिकेशन ऑफ वुंड्स इज गोइंग टू बी द नेक्स्ट क्वेश्चन. और सब लिखा हुआ बेटा. देखो, क्लासिफिकेशन ऑफ सर्जिकल वुंड्स आर देयर, सर्जिकल साइट इंफेक्शन इज देयर, अल्सर इज देयर, सब बात करेंगे, कोई टेंशन नहीं है. ठीक है, चलो. हाँ, तो वी आर टॉकिंग अबाउट द प्रेशर अल्सर, डिक्यूबिटस अल्सर्स, बेड सोर्स और प्रेशर सोर्स. प्रेशर अल्सर का जो पैथोफिजियोलॉजी है, दैट इज व्हेनेवर द प्रेशर एक्सर्टेड ओवर अ पर्टिकुलर साइट ऑफ अ बॉडी इज मोर देन दैट ऑफ अ कैपिलरी ओक्लूसिव प्रेशर, इज व्हाट वी कॉल इट एज द पैथोफिजियोलॉजी ऑफ योर बेड सोर और प्रेशर सोर. इसका मतलब क्या है? नाउ व्हेन यू एक्सर्ट प्रेशर, लेट्स से यू कैन सी माय palm here, when I exert pressure and when I release it, see I'm exerting pressure and I release it, that area is becoming white and slowly it becomes pink again. Now when I exert pressure, what am I doing? I am occluding the capillaries to this particular site. अब जब मैं capillaries को दबा रहा हूं तो blood flow to this area is reducing. ठीक है, नॉर्मली मैंने तो 2 सेकंड के लिए दबाया, फिर निकाल दिया. इमेजिन करो कि यही प्रेशर कुछ घंटों तक बना रहा. ठीक है, 6 घंटे 8 घंटे. अब 6 से 8 घंटे तक अगर ऐसे ही प्रेशर रहेगा तो कैपिलरीज टू दिस एरियाज विल नॉट बी एबल टू प्रोवाइड ब्लड टू दैट पर्टिकुलर साइट. अगर ब्लड यहां पहुंचेगा ही नहीं तो हाइपोक्सिया हो जाएगा. हाइपोक्सिया की वजह से इश्कीमिया, इश्कीमिया विल कॉज टिश्यू नेक्रोसिस, टिश्यू नेक्रोसिस विल रिजल्ट इन अल्सरेशन. सो प्रेशर अल्सर की जो पैथोफिजियोलॉजी है, इसका पैथोफिजियोलॉजी का एक चार्ट बनाना पड़ेगा आपको, दैट इज ओक्लूजन ऑफ कैपिलरी प्रेशर ऑफ कैपिलरीज. It is the occlusion of capillaries resulting in poor perfusion over an area. Poor perfusion over an area where the pressure is exerted on the pressure site. Now, because of this poor perfusion over an area or a pressure site will result in hypoxia. This hypoxia will result in ischemia to that particular site, and this ischemia will result in tissue necrosis, and this tissue necrosis will result in ulceration. This tissue necrosis is going to result in ulceration. ठीक है, if you put this chart on, ये चार्ट अगर आप बना दोगे तो आपका एग्जामिनर ना पागल हो जाएगा, बोला यार ये बंदा पढ़ के आया. ठीक है, सो द मिनट यू पुट दिस चार्ट, ही मतलब बाकी का आंसर वो पढ़ेगा ही नहीं. उसके बाद आप जो मर्जी लिख दो, अगर इतना लिख दिया ना तो बोलेगा कि भाई मतलब दिस गाई इज अ टॉपर. ठीक है, बस इस छोटा सा फ्लो चार्ट जहां पे आपने बता दिया कि जहां से देखो कैपिलरी प्रेशर पे ऑक्लूड हो गया, आपने लिख दिया कि कैपिलरी ओक्लूसिव प्रेशर 30 है, तो वो और पागल हो गया कि कैपिलरी ओक्लूसिव प्रेशर को पता है द मिनिमम प्रेशर रिक्वायर्ड टू ऑक्लूड द कैपिलरीज इज गोइंग टू बी मोर देन और इक्वल टू 30. सो 30 मिलीमीटर ऑफ मर्करी इज गोइंग टू बी योर कैपिलरी ओक्लूसिव प्रेशर. अब कैपिलरी ओक्लूजन की वजह से परफ्यूजन कम हो गया, परफ्यूजन की वजह से हाइपोक्सिया हो गया, हाइपोक्सिया की वजह से इश्कीमिया, इश्कीमिया से टिश्यू नेक्रोसिस और नेक्रोसिस से अल्सरेशन. तो आपने तो इसको बता ही दिया कि प्रेशर अल्सर बनता कैसे. अच्छा, फिर ये पूछ लेगा व्हाट आर द साइट्स फॉर द प्रेशर अल्सर, व्हाट आर द प्रोन साइट्स. सो द सेकंड थिंग दैट यू हैव टू डू इज द साइट्स फॉर प्रेशर अल्सर. अगेन प्रेशर अल्सर के साइट्स ना आप या तो मेमोराइज कर लो या तो सिंपली समझ के याद रख लो. ठीक है, सो आई प्रेफर द सेकंड मेथड. अब आप मान लो कि ये बेड है जहां पे हमारा पेशेंट लेटा हुआ है, ही इज अ बेड रिडन पेशेंट, सो ही इज गोइंग टू हैव दिस. ठीक है, so in a bedridden patient, this is how the patient is going to lie down. ये इसका occiput है, ये इसकी body है. You will see these are the sites which will be present like this. ठीक है, अगर patient लेटा हुआ है, whichever site is in contact with the bed, यहाँ पे पूरी बॉडी का भार गिरेगा, और जैसे भार गिरेगा तो यहाँ पे प्रेशर ज्यादा होगा, जहां पे प्रेशर ज्यादा होगा वहां पे आपकी कैपिलरीज ओक्लूड हो जाएंगे, और जहां पे कैपिलरीज ओक्लूड हो जाएंगी वहां पे लो प्रेशर सिस्टम आ जाएगा। अगर लो प्रेशर हो जाएगा तो अभी तो बताया था हाइपोक्सिया, इस्कीमिया, अल्सरेशन, तो यही साइट्स है। तो साइट्स फॉर द प्रेशर अल्सर में अगर आपसे एग्जाम में पूछता है, आप देखो एक ये आपका सर है जो आपके पिलो, अगर पिलो है तो पिलो के बिना तो इट इज गोइंग टू एक्सर्ट मोर प्रेशर, इट इज गोइंग टू बी द ऑक्सीपुट। फिर आप देखोगे यूजुअली ना स्कैपुलर एरिया पे थोड़ा स्पेस आउट होता है तो उतना प्रेशर नहीं गिरता, लेकिन व्हेन यू कम डाउन टू हियर, यहां पे आपको 3 जगह मिलेंगी। इट इज गोइंग टू बी द इस्कियम, इट इज गोइंग टू बी द ग्रेटर ट्रोकैंटर, इस्कियम, ग्रेटर ट्रोकैंटर, और इसी रीजन में एक और मिल जाएगा आपको सेक्रम। So there are the 3 sites where you will see the ulcers or the pressure more. Ischium is the overall most common site. ये आपका NEET PG का सवाल या फिर your competitive exam का question भी है. Along with that you have the sacrum as well as the greater trochanter. It is going to be your greater trochanter as well, right? उसके बाद अगर आप देखोगे ये heel है. So heel is going to be in a constant touch. So heel is the another site for the pressure ulcer. Now when the patient is bedridden तो क्या होगा, जब लेटेगा तो उसके पैर laterally fold होंगे, जब वो laterally गिरेंगे तो कौन सा एरिया इज अंडर द surface touch? It is the lateral malleus, ठीक है। तो एक और यहाँ पे याद रख लेना, it is the lateral malleus which is more commonly affected when compared to medial malleus. It is going to be the lateral malleus which is more commonly involved when compared to the medial malleus, ठीक है। So I'm just going to add here, lateral malleus is more commonly affected. Lateral malleus is more commonly affected when compared to medial malleus or the medialus, ठीक है। So this is far more common, that is lateral malleus is far more common when compared to medial malleus, ठीक है। So these are the various sites where a patient would develop pressure ulcer. Then they'll ask you what are the risk factors for development of these pressure ulcers. The risk factors are quite simple. It is understandable also कि any patient who is going to be bedridden, any patient who is going to be bedridden, any patient who is a wheelchair bound status, it is going to be a wheelchair bound status, or if the patient is having prolonged immobilization. It is a prolonged immobilization. Now this prolonged immobilization is usually seen in this obese patients. I still remember I saw a case, that kid was I think around 17, 18 years old, and that kid was not very obese, but yeah, he was quite hefty, and he had a habit of playing video games, right? So he was into that, you know, online gaming and all, and the history that he guys, he was in his hostel room. He did not get up from his position for 3 days. He was eating, sleeping in the same place and he's playing at the same time. He hardly got up for his business also, right? So वो पूरा दिन बैठा रहा, ठीक है, 3 दिन तक कंटिन्यूसली बैठा। 3 दिन के बाद obviously this that area started to discolor and he came down to us. I mean, luckily it was grade 2 only, so उसमें ज़्यादा problem नहीं हुआ, otherwise it would have become much more difficult. So these are the important risk factors associated with that of the pressure ulcer, ठीक है। Now when we talk about what are the stages or the different grades of the pressure ulcer, so there are stages of pressure ulcer. जब भी आप ऐसा कुछ स्टेज लिखोगे ना, उसके लिए एक टेबल बनाना, stages of pressure ulcer. So when you're going to address this, when you're going to address the stages of the pressure ulcer, what we are going to do is we are going to write on one side the stage, on the other side you will write description, and then at the end management. So now the examiner knows कि आपको पता है कि pressure ulcer grade या stage wise manage होते हैं, ठीक है। So you have stage 1 pressure ulcer. Stage 1 में description है, there will be presence of non-blanching, there is non-blanching erythema. Now this non-blanching erythema, this redness, you try to exert pressure, that does not change or blanch away, that is because of subcutaneous ecchymosis. Here it is going to be conservative management. It is going to be a conservative management. Then you have grade 2 pressure ulcer, where you have partial thickness skin loss. Where you have a partial thickness skin loss. So when there is a partial thickness skin loss, again the management here is going to be conservative management. So grade 2 mein you will see there is only skin excoriation. Then you have grade 3. In grade 3 you have full thickness skin loss. So your examiner would also want to know that how do you know it's a partial or a full thickness skin loss. In a full thickness skin loss, subcutaneous fat is exposed. If you are able to see a subcutaneous fat being exposed, it is grade 3 or stage 3. Otherwise, it is going to be stage 2. So here you will require an active management. So we'll talk about it. What is an active management? Then you have stage 4. Stage 4, there is involvement. There is an involvement of underlying structures. There's an involvement of an underlying structure. Now, when you talk about the underlying structure, what underlying structure are we talking about? It could be a muscle, a vessel, a tendon, a nerve, anything, right? So when you talk about underlying structures, we're talking about whether it could be a muscle, it could be a vessel, it could be a tendon, or it could be a nerve. Or in fact, it can be a bone as well. Anything. If there is any underlying structure is being involved, it will directly become stage 4. For stage 4 also, we will go with active management. So here also we'll go with active management. Latest addition to the pressure source that you have is what we call it as unstageable. Now what is this unstageable? If an ulcer is covered, if the ulcer is covered with necrosis or slough, presence of necrosis or slough over an ulcer will directly make it as unstageable. Reason क्या है? अगर necrosis और slough present है तो ulcer का depth कैसे पता चलेगा? ऐसे थोड़ा पता चलेगा कि वो अभी भी superficial है, कि इसने dermis breach किया है, subcutaneous fat exposed है, या फिर underlying bone या vessel involved है. कैसे पता चलेगा? अगर पूरा slough से भरा हुआ है तो आप SS नहीं कर पाओगे. आप क्योंकि SS नहीं कर पाओगे तो मैं stage नहीं दे पाऊंगा. तो stage नहीं दे पाऊंगा तो क्या करोगे? Again you have to go here with active management. So active management is going to be an intervention. Active management is what we're talking about, an intervention. It is an intervention, right? This is about intervention. So these are the different stages of the pressure ulcer, and you have to remember all these one, and you have to write it. If you put this in a tabular form, your examiner is going to go gigas on you. बोलेगा यार ये बंदा तो सही में topper है, topper. ठीक है? तो small things, nothing descriptive about it. थोड़ा सा effort लगेगा, लेकिन अगर एक बार effort डाल दोगे तो you know that you are not going to miss out on the score. तो ये बड़ा important description है, right? So do not goof up on this. This is quite important from the exam perspective. So whenever you're writing it, make sure you put it in a tabular form or a tabular state so that it looks quite presentable as well, right? So this is about the stages of the pressure ulcer, right? Now, फिर बारी आती है management की. We described it, no? कि now we're talking about active management and the conservative management, right? So what is your conservative management? What is your active management, right? So we're talking about the management of the pressure ulcer. In the management of pressure ulcer, in the management of the pressure ulcer, as we said, we have two components. One is going to be the conservative management, another one is going to be active management. One is going to be the conservative management, another one is going to be the active management. Now, in the conservative management, the first advice that I will give is to provide a patient with a water or an air bed. Now, when you give a patient with water or an air bed, what is going to happen? The pressure exerted over that area will become less, because rigid beds, patient sits on them or patient sleeps on them, it'll have more density and more pressure. No, but if you give a water bed or an air bed, the pressure, that is counter pressure exerted by the bed, will decrease, जिसकी वजह से जी capillary occlusive pressure नहीं gain होगा. ठीक है. अच्छा, the second one is going to be a frequent change in position. There will be a frequent change in position. There's going to be a frequent change in position. Now सवाल ये है कि कितना frequent. Now if a patient is bedridden, for a bedridden patient, it should be every second hourly. And if a patient is wheelchair bound, it is every 10 minutes. The patient should change the position, right? So if it is a bedridden patient, every second hourly. If the patient is wheelchair bound, every 10 minutes, there should be change in position. It is going to be change in position. Now, the third one, it is going to be skin care. If a patient is bedridden, that is a chronic bedridden patient, you have to make sure that all the diapers are changed clearly, the skin is being dusted well, it is kept dry. You have to use an antifungal powder that you have, so that it does not, have that inhalations as well. So you have to make sure all that is taken care of. That is a proper skin care is important. So reducing the pressure by water and air bed, frequent change in position, and skin care are the sets of conservative management. In an active management, because the ulcer is already formed, the first one is going to be the cleaning and debridement. It is the cleaning and debridement. The problem with cleaning and debridement of the ulcer, it creates a big wound, right? So how do you allow that wound to heal properly and at a faster rate? So you have to go ahead with something called as vacuum assisted closure. A vacuum assisted closure is basically a dressing material where you put it and you seal that wound and you connect it to a vacuum pipe. And what happens? It sucks all that secretions and all that component across, and then keeps the wound dry and allow the wound to heal at a rapid rate. Currently, vacuum assisted closure is a wrong word. We do not use it. So vacuum assisted closure is commonly called as VAC. It is an obsolete term now. We don't use the word vac because you cannot achieve vacuum. You can only create a negative pressure. So it is now called as the negative pressure. It is now called as the negative pressure wound closure system. It is called as the negative pressure wound closure system. If you want to impress your examiners, you can write the pressure that is kept in your vac is going to be minus 125 millimeters of mercury. It is set at an intermittent pressure. It is set at an intermittent pressure, and you need to change the vac dressing every 3 to 5 days. So unlike your traditional dressing, जो आपको daily change करना पड़ेगा, वैक का dressing एक बार लगा 3 से 5 दिन के बाद आपको change करने की जरूरत है, right? So the pressure is going to be at minus 125. Intermittent pressure आपको रखना है. You can change the vac in once in every 3 to 5 days. Unlike your traditional dressing, जो आपको daily change करना पड़ेगा. Now, once you are done with this, then you will add conservative management protocol. You have to add it conservative management protocol, जो अभी आपने discuss किया था. What is this conservative management protocol? Whatever we have discussed it here, this is your point number 3. Now the point number 4, it might require skin grafting if it is superficial, or it might require a flap reconstruction if it is deep. If the pressure wound is superficial but a larger area has been involved, you have to go ahead with skin grafting. But if it is going to be more deeper, skin graft alone will not be able to help it. तो अगर ज़्यादा गहरा wound है, सिर्फ skin लगा हुआ तो नहीं चलेगा. You have to take some amount of fat, sometimes muscle also, and that is what we call it as flap reconstruction. ठीक है? So these are the management of the pressure ulcer. ठीक? So if it comes down to the exam में ये आपके लिए usually 5 mark का question है. So starting all the way from the pathophysiology of your pressure ulcer to the sites, to the risk factors, stages of pressure ulcer and the management. ठीक है? इसी sequence में आपको लिखना है. If you are able to write the answer in this sequence, your examiner is going to be super impressed, right? So we completed another question which was asked in our exam, and that was your pressure ulcer. Now going to the classification of surgical wounds. ये जो सवाल है बहुत बार आया और बार बार पूछ रहे हैं, ठीक है. सो वी आर टॉकिंग अबाउट द क्लासिफिकेशन ऑफ द सर्जिकल वुंड्स. चले. So the next question that you have is the classification of the surgical wounds. So talk about the classification. It is a classification of the surgical wounds, right? Again, it's a 5-mark question. So classification may, rather than trying to remember it as one go, right? Trying to remember it as one go, we'll try to give it as a tabular column so that you don't forget it across. Okay? Now, when you talk about the classification of the surgical wound, I'll create a small table. One is going to be your wound class. We'll define it. The definition of that particular wound class. We'll talk about the example of that particular wound class and the percentage of surgical site infection in that particular wound class. Okay? So this is what you have to determine. So when writing the answer, this is what you're going to consider it. So the wound class on one end, so the wound class on one end, definition on the other, that is description or definition, example and the surgical site infection. Example and the surgical site infection, right? Now, when it comes down to the wound class, the first one is going to be clean wound. We call this as a clean wound. So which surgical wound will be considered as clean wound? So what is the criteria, right? Number one, it should be a non-traumatic wound. It should be a non-traumatic wound. It's a wound that should be created due to an elective surgery. It should not be an emergency surgery. It should be an elective surgery. There should be no entry. There is no entry into natural cavity. There should be no entry into the natural cavity. When I say natural cavity, you're talking about abdomen, you're talking about thorax, you're talking about, the ureters or the urogenital system. No, there's no entry into any natural cavity. It should be a non-traumatic wound. It should be due to an elective surgery, and there should be no entry into a natural cavity. If you satisfy all this, this will be called as class 1 or the clean wounds. Now, the examples of the clean wound is going to be thyroidectomy. It is the thyroidectomy, parotidectomy, mastectomy, your lipoma excision, all your hernia repairs, we're talking about the open repairs. Because when you talk about TAP, that is transabdominal preperitoneal repair, you go into the abdominal cavity, there it becomes clean contaminated, right? So these are the examples. The probability of the surgical site infection in these patients are less than 2%. That is why we tell you that a single shot of preoperative antibiotic is enough to cater to these patients. You don't need to extend the antibiotics after the surgery. That's the concept about your clean wounds, right? Now, once you have defined the class 1, that is your clean wound, we'll go to class 2. So this is our class 1 wound. Next, going to our class 2 wounds. So second is going to be, class 2 is going to be clean contaminated. We're talking about a clean contaminated wounds, right? So what is the definition or what is the criteria that fits into a clean contaminated wound? Clean contaminated wound kaun sa hai? Now again, clean contaminated mein, this should also be a non-traumatic. This should also be a non-traumatic wound. This should also be due to an, or it should be created secondary to an elective surgery. It should be an elective surgery. Here you can enter natural cavity. Enter natural cavity under controlled environment. Under the controlled environment. There is no spillage or something like that. No, it will become a clean contaminated wound. Okay? Now, in a clean contaminated wound, what are the examples that you're looking at? Right? Now, the examples that you're looking at are clean contaminated wounds. Examples like hysterectomy. You have uncomplicated appendicectomy. You have an appendicectomy which is uncomplicated. Uncomplicated cholecystectomy. Uncomplicated cholecystectomy. All your elective bowel surgeries. Example like gastrectomy. Elective bowel surgeries, example like gastrectomy. Okay. So all these are considered to be as clean contaminated wounds. So clean contaminated wound का criteria क्या है? It should be non-traumatic. Trauma की वजह से नहीं होना चाहिए. Elective surgery होनी चाहिए. आप नेचुरल कैविटी एब्डोमेन थोरैक्स में जा सकते हो, बट अगेन अ कंट्रोल्ड कंपोनेंट. देखो एग्जांपल्स ऑफ योर क्लीन वुंड. नो, आई जस्ट ऐड अनदर पॉइंट हियर. योर ब्रेन एंड जॉइंट सर्जरीज. योर ब्रेन एंड joint surgeries which are non-traumatic also are the criteria for clean wound. ठीक है? All your brain surgeries, all your joint, for example, knee replacements, hip replacements and all that, all these elective joint surgeries are also going to be considered to be as your clean wounds. ठीक है? तो ये आपको होगा clean contaminated का, right? From here we're going to talk about the next class, that is your class 3. So we have other classes of the wound. I am so sorry, but I have an obsession with line. अगर मेरी लाइन सीधी नहीं है तो मेरा दिमाग टेढ़ा हो जाता है. ठीक है? तो भैया जब लाइन मार रहे हो तो सीधी मारना सीखो. ठीक है? अदरवाइज लाइन मारो ही मत. चलो. So this is about clean contaminated wounds, right? Now the third class of wound that you have is your contaminated wounds. It is going to be your contaminated wounds. ठीक है? So it's going to be contaminated. तो contaminated wounds का criteria क्या? It is acute trauma. So acute traumatic wounds. All your fresh trauma, your acute traumatic wounds. Your emergency bowel surgeries. All your emergency bowel surgery, all your traumatic wounds are considered to be as contaminated. Another one is any wound that requires re-exploration. Any wound that requires re-exploration, that is, you have done an laparotomy, but due to some reason you have to do again. If you have done a sternostomy, due to some reason you're doing it again. So any re-exploration of any surgical wound will be considered to be as contaminated wounds, right? Now, what are the examples which will classify as a contaminated wound? Remember your hollow viscous perforations. Is going to be hollow viscous, like perforation, that is gastric perforation and duodenal perforation. You have the gastric perforation as well as duodenal perforation repair. Your ruptured appendicitis. Your ruptured appendicitis. All your emergency bowel surgery where the bowel is unprepared. So it is your perforations, your ruptured appendicitis, all your trauma debridement. All these will be considered as contaminated wounds. Remember the probability of a surgical site infection. Now, in a clean wound, it is usually less than 10%. And in a contaminated wound, it is approximately 20%. So it is almost double this probability of surgical site infection when you go from your clean contaminated to contaminated. So last criteria that you will see in a surgical wounds. The last criteria that you'll see in a surgical wound is going to be dirty wounds, right? It is the class 4, and the class 4 is what we call it as the dirty wounds. Now, dirty wounds are infected wounds. All your infected wounds. Anywhere in the body, if there is presence of abscess, it classifies as dirty wounds. If there is traumatic bowel perforation, if there is a traumatic bowel perforation. So if there's an infected wound, if there is an abscess, if there is a traumatic bowel perforation, all these are considered to be as dirty wounds. Examples, as I've already given you, let's say any abscess example like breast abscess, if there is pelvic abscess, if there is presence of fecal peritonitis, if there is presence of fecal peritonitis, if there is any fistulas per se. It could be a bowel fistula or a perineal fistula, any fistulas, all these are considered to be as dirty wounds. The rate of surgical site infection is going to be 30 to 70%. The rate of the surgical site infection here is going to be 30 to 70%, right? So these are the classification of surgical wounds, and this you have to remember it. This table, if you put this table, your answer is sorted. Nobody is going to ask you anything beyond it. This is the table that you have to put for classification of surgical wounds, right? So we have completed another question from our previous exam. That is the classification of surgical wounds. So we're talking about the last topic in the wound, that is going to be your surgical site infection. So take up the next topic, and the next topic is going to be surgical site infection. Now, surgical site infections. Surgical site infections are quite important from the exam perspective also. So by definition, it is the infection. So this is the signs and symptoms. The signs and symptoms of infection. The signs and symptoms of infections after a surgery localized to surgical wound. Because if it is systemic, then we'll call it a sepsis. Okay. Signs and symptoms of infection after a surgery localized to a surgical wound is what we call it as surgical site infection. This is what we call it as the surgical site infection. Now, when you talk about the surgical site infections, so there is something quite intriguing that you should know, that is what results in post-op fever. Just give me 1 second, guys. Hold on for a second. Right, guys. Now, as we say, surgical site infection, it is signs and symptoms of infection after a surgery localized to surgical wound, but within how many days, right? So this wound infection is within 30 days of surgery. It is within 30 days of surgery. There's one exception if you're talking about any implants, especially in ortho implants, those within 1 year. So if it is going to be post-implant surgery or post-implant, any infection within 1 year. Any infection within 1 year of implant placement. Within 1 year of implant placement, will be defined as surgical site infection. These are like standard definitions that you have to write it. So the surgical site infection is the signs and symptoms of infection after surgery localized to a surgical wound. It should be within 30 days of surgery, or there should, if it is an implant, it should be within 1 year of implant placement. That is the first component that you have. Now, all surgical site infections, when you talk about the clinical features, they will present to you because they're infections, they're going to be associated with inflammation. Every inflammation will have rubor, calor, dollar, tumor. So here you will see what are the signs and symptoms of the surgical site infection. The first one, the patient is going to develop fever, and this is what we call it as a post-operative fever or a post-op fever. Now, after fever, there will be presence of erythema. Over the wound site. There will be presence of erythema over the wound site. So this is your rubor, right? Now there's fever, there is erythema. Along with that, there could be discharge from the wound site. Now this discharge from the wound site, can be serous. This discharge from the wound site can be serous, or it can also be purulent, that is pus. So initially it starts as serous. If it is left unattended, it is going to become into purulent discharges, right? So patient, say same, rubor, calor, dollar, tumor. So patient is going to have fever, there will be presence of erythema, there will be presence of discharge from the wound site. All these are going to account for the surgical site infection. They're going to aside for surgical site infection. Now, as we have mentioned, the patient is going to present you with post-op fever. So again, here you have to write it for the causes of post-operative fever, because every post-operative fever will not be because of, it is not going to be because of surgical site infection. So we are going to classify the post-operative fever based upon the day it is going to present to us, right? So when you talk about the post-operative fever, if a patient presents to you with the day 1, that is the first day. So day 1, if there is a post-operative fever, the most common cause is air. Air is what? Lungs. Lungs is what? It is going to be atelectasis. So it is due to, that's the most common, it is, I'd say, it is due to atelectasis of the lung. It is because of atelectasis of a lung where the lung is collapsed, right? Especially the lower lobe of both the sides, because the diaphragm remains rested, the lungs cannot expand enough, it gets accumulated, and all the accumulation will result in post-operative fever, right? So the day 1, it is because of your lung atelectasis. Now, if the fever is present anywhere between day 2 or day 3, now it is usually because the cannulas that you have put, and those cannulas start to inflame and cause fever. So that is because of superficial thrombophlebitis. It is going to be superficial thrombophlebitis. It is because of superficial thrombophlebitis. It can also be because of UTI, that is hospital acquired UTI. In fact, if you all remember, the most common nosocomial infection that you can pick up is going to be UTI, that is secondary to E. coli. Okay? Now, so the first one is going to be atelectasis. Day 2, day 3, it is going to be because of thrombophlebitis and UTI. Then you have day 4, day 5. If the fever is seen between day 4 and day 5, it is usually because of surgical site infection. It is because of surgical site infection, or it is because of prolonged immobilization, that is caused DVT. It is due to immobilization. So if a patient starts developing fever on day 4, day 5, always look for the wound site. If the wound site is healthy, always look for limbs, because that is going to be because of deep vein thrombosis, that is DVT. Now, if the patient develops fever on day 6, especially in the abdomen, it is because of the burst abdomen. Now, burst abdomen is where the abdominal wound has given away. It is called as the wound dehiscence has occurred, and that wound dehiscence is going to result in fever. And whenever there's a burst abdomen, there's a very characteristic fluid that is going to come from the wound site. So there will be presence of salmon colored fluid discharge. There's a salmon colored fluid discharge from the wound site. From the wound site. This is a salmon colored fluid discharge from the wound site that is going to be on day 6. And anything that is going to be beyond the first week, that is more than or equal to day 7, it is going to be usually some collection associated with the wound site or intracavity. Usually talking about the abdominal surgery, so it is an intra-abdominal collection. It is due to an intra-abdominal collection. It is an intra-abdominal collection, or I can say abscess. Same thing validates for your intrathoracic collection. It is your intrathoracic collection, where again there is abscess that is formed within the thoracic cavity, right? Now this is going to be quite important for us, because when you are going to cater it down, okay, I hope everybody is okay. If you have any questions, you can ask, guys. It's okay, right? So these are the important components of the post-operative fever. So we say the first day it is because of air. The second day it is because of water. Third day it is going to be because of immobilization. So it is stagnant state. Then it is going to be your burst abdomen and the intra-abdominal abscess, right? So the first one is air, then is water. Water is UTI, that is nothing but urine. Then your stagnant state is going to be DVT as well as surgical site infection. Then it is burst abdomen, and the last one is going to be intra-abdominal collections, right? Now, whenever you have a patient with surgical site infections, we would want you to know two important scoring systems which are going to be asked in the exam as well. Number one, I would want you to know something called as the asepsis wound score. We have an asepsis wound score. Another criteria that I would want you to know is going to be a Southampton wound grading system. There is not a Southampton wound grading system. So we have two components that are going to be present. One is going to be your asepsis wound score. Another one is going to be a Southampton wound grading system. Asepsis, the mnemonic itself is going to be asepsis. So what does it stand for? Now in asepsis, A stands for additional treatment. It is the additional treatment required for wound healing. It is the additional treatment required for wound healing. S stands for serous discharge from the wound site. It is the serous discharge from the wound site. E stands for presence of redness, that is presence of erythema. Erythema over the wound surface. Erythema over the wound surface. P stands for purulent discharge. It is going to be the purulent discharge. Another S stands for separation of deep tissue. That is, if infection has gone deeper, it is called a separation of deep tissue. I stands for isolation of organism. It is going to be the isolation of organism, that we have sent it for culture. In the culture, it is positive for bacterial growth. In the culture, it is going to be positive for that of the bacterial growth, right? So you have additional treatment required for wound healing, serous discharge, erythema over the wound surface, purulent discharge, separation of deep tissue, isolation of organism, and if there is stay in hospital, if the stay in hospital is for more than 14 days due to wound infection, then it will be positive for asepsis wound score. We'll talk about the Southampton wound grading system. Again, in the Southampton wound grading system, we have the grading system, or we are going to follow as a grade system. So we have on one end, you have grade, another one we're going to talk about the description. So talk about the grade of the wound and the wound description. Now, let's say you're talking about grade 0. Now, grade 0 is a normal healing wound. It is going to be a normal healing wound. Then you have grade 1. Here, you will have a normal healing wound. There's no problem with the wound healing, but there will be presence of mild erythema. So, normal healing wound with mild erythema. There is presence of mild erythema. We'll call it as grade 1. Now, grade 2, there will be erythema with other signs of inflammation. So, there will be redness around the wound. So, पूरा wound red होगा. उसके साथ साथ there will be other signs of inflammation. So, when I say other signs of inflammation, I'm talking about there will be pain, there will be fever, there will be some amount of serous discharge also, but not very prominent. Okay? So, it's a grade 2. Then you have grade 3. Rather than discharge, I'll say the skin is becoming edematous, right? So in stage 3 or grade 3, there will be clear serous discharge. The clear serous discharge from the wound site. There's a clear serous discharge from the wound site. That is the stage grade 3. Then you talk about grade 4, there will be purulent discharge. There will be presence of purulent discharge. And the last one that you have is grade 5, where you have severe wound infection with or without tissue loss. The severe wound infection. The severe wound infection with or without tissue loss. That is with or without tissue loss. Right? So this is the various components of the scoring system. So there are two important scoring systems which are present. Okay. Right, guys, if you don't like it, it's not a force, ना. अगर आपको नहीं पसंद है, it's okay. Find someone else. कोई प्रॉब्लम नहीं, ठीक है. देखो भाई, मुझे जैसे पढ़ाना आता है मैं पढ़ा रहा हूँ. अगर आपको अच्छा लग रहा है तो ठीक है, नहीं अच्छा लग रहा है तो भी ठीक है, ठीक है. So I'm trying to give you concise time में कितना important data in the presentable form में दे सकता हूँ मैं दे रहा हूँ. बाकी आपकी मर्जी है, ठीक है, कोई टेंशन नहीं. Now you have the wounds, two criteria that we have already discussed. दोनों criteria exam के लिए important है. एक आपका asepsis wound score है, which is going to be absolutely important. Another one is Southampton wound grading system. दोनों surgical site infections के लिए हैं. This is what you have to write when they ask you a question on surgical site infection. ठीक है. Surgical site infection का management protocol same वही है. That is going to be what we have discussed before also. So management of surgical site infection. So management of surgical site infection. Now it's a stepwise approach that you have. Every surgical site infection, step 1, it is to drain the collection. Drain the collection. Step 2, start antibiotics. Start antibiotics, right? Chalo. So drain the, guys, you don't need to fight on the chat box, it's okay, ठीक है. We are at a phase right now जहाँ पे all of you are quite matured, ठीक है. हर कोई डॉक्टर है, तो I hope everybody knows what it likes to be. And especially talking about me, I mean, I am quite leveled up, so I don't need anybody's validation. मुझे कोई चैट बॉक्स में नहीं बताएगा कि क्या है क्या नहीं है. जहाँ मैं खड़ा हूँ मुझे पता है मैं कैसे आया हूँ, ठीक है. मुझे पता है मैं कहाँ पे हूँ. मेरे तक पहुँचने के लिए जो क्रिटिसाइज कर रहा है, इट विल टेक अ लाइफ टाइम जर्नी, ठीक है. जिस दिन पहुँच जाओ उस दिन बात कर लेंगे, कोई टेंशन नहीं, ठीक है. चल, सो हाउ डू यू मैनेज अ सर्जिकल साइट इन्फेक्शन? जो भी कलेक्शन है, यू हैव टू ड्रेन इट. सेकंड, स्टार्ट द पेशेंट ऑन एंटीबायोटिक्स. give adequate analgesia, give adequate analgesia, give anti-inflammatory drugs, give an anti-inflammatory drugs. So adequate analgesia, anti-inflammatory drugs, drain the collection, start the patient on antibiotics. This is the first line management. Remember, most of the surgical site infection, after you have drained it, they will create into post-drain wound. So whenever they develop into a post-drain wound, all these post-drainage wound, they must be managed with vacuum assisted or negative pressure system, right? We have just learned pressure ulcers में पढ़ा था कि vac लगाना पड़ेगा. In the same context, post drainage wounds का जो management protocol है, उसमें आपको करना है, the patient has to be managed on negative pressure. They have to be managed on negative pressure wound closure system. ठीक है? So this is what you have to do. So whenever they ask you what is the management for a surgical site infection, these are the principles that you're going to follow for your surgical site management. ठीक है? So this concludes जितने भी आपकी आज तक के सवाल आए थे wounds और ulcer में से, we have covered all of them. ठीक है? तो आज हमने क्या क्या टॉपिक्स कवर किए wound में we have completed everything. Phase of wound healing, factors delaying, ulcer management, types of ulcer, pressure ulcers, classification of surgical wound, as well as surgical site infections. ठीक है? यहां तक ठीक है guys? So far so good? कोई सवाल, कोई क्वेश्चन, कोई शक? Can we continue? ठीक है? So this is about all the important questions that is to be on the today's part. ठीक है? So I hope we have covered good amount of topic list. ठीक है? So these are the various components from your wound. ठीक है? Because we have a little bit of time left, I will take another session. एक और topic list ले लेते हैं, which we'll discuss. ठीक है? तो ये पूरा आपका wounds का है. Then the question that are usually asked is going to be a small topic that we'll cover it off. That is going to be burns. ठीक है? तो आपके लिए जो क्वेश्चन है burns पे, first is about the Wallace rule पे सवाल है. Management of burns wound. The question was there on the topical agents of burns. Topical agents used in burn wound. Okay. Specifically, they ask you the fluid management in burns. Fluid management in burns. They've asked you burn management per se. Right? So all these were our previous exam question. ठीक है? तो Wallace rule आपसे पहले भी पूछा हुआ है. This was asked for 5 marks question. Management of burn wound was 5 marks. Topical agent and fluid management were 3 marks. And the entire burn management was of 10 mark question. ठीक है? So we'll try to address all of them in the same scenario. So quickly talking about the various components of burns that are present. ठीक है? तो सवाल वही है कि again कैसे manage करोगे, कैसे typically use करोगे, तो how would an examiner look for your answers? ठीक है? So when you talk about the answers in terms of, we start with the burn management. So I'll cover everything in this burn management. The burn is also called as thermal injury. It is also called as the thermal injury. So any patient who has come to you with the burn management, or a burn, how would you like to go and address it? So it's again a stepwise approach. So burn management में the step 1, it is going to be your primary assessment. Tomorrow when we talk about trauma, we'll talk about primary assessment in detail. Now primary assessment follows the same protocol as anywhere else. It is going to be same as ABCDE. So here also, but in burns you will add F, right? So this is what you have to follow in the burn wound management resuscitation protocol. So what does A stands for? Now A is going to be airway with cervical spine stabilization. Airway with cervical spine stabilization. B stands for breathing and ventilation. B stands for breathing and ventilation. C stands for circulation with hemorrhage control. Circulation with hemorrhage control. D stands for disability limitation. It is your disability limitation. E stands for expose and examine. And the F stands for fluid management or the fluid resuscitation. F stands for fluid resuscitation. F stands for fluid resuscitation, right? So burn wound management, step number 1 is the primary assessment. That is going to be in the same context that we've written. It is going to be an ABCDEF protocol, right? Now, once you have done, the step number 2 is the assessment status, right? So step 2 is after the primary assessment. So in step 2, what are you going to do? We have started the patient on primary assessment. So if there is any life-threatening injuries during the primary assessment, you have to address then and there itself, right? Especially in the inhalational injuries, no, there will be airway associated injuries. So you have to secure the airway at the context. Okay? So you've done the primary assessment. Now, once you've done the primary assessment or the primary survey, remember to oxygenate the patient well. So give 100% oxygen. Now, the reason for giving 100% oxygen, everybody knows, in every patient who has underwent burn, if it is a hot water or scald burn, you don't need to worry it. But if there's an inhalational injury or a fire injury, due to inhalational heat, there's some amount of laryngeal or the oral cavity injury also, which will cause congestion or edema, will not allow adequate air to go in, so causing hypoperfusion. In those patients, as a precautionary measure, always start with 100% oxygen, right? Now, as you're doing this, secure 2 large IV cannula. So when I say 2 large IV cannula, preferably it is a 16 gauge cannula. If it is not available, you can go to 18 gauge, but not less than 18 gauge needle. That is your second thing in your assessment protocol. Now, once you've done this, always give injections of tetanus toxoid. That is 0.5 milligrams. It is going to be given intramuscular and it has to be given single dose, that is stat. Right? Every patient, you usually forget to give injection of tetanus toxoid, but then that is going to be an important precautionary measure. So once the primary assessment is done, right? After the primary assessment is done, if nothing is there, you should always look for any warning signs for intubation. Is there any warning signs for intubation? Is there any warning sign for intubation? So when we say warning sign for intubation, what are the warning signs of intubation that you're looking at? Number 1, if there is presence of inspiratory stridor. If there is presence of inspiratory stridor. If there is hoarseness of voice. Post burns, if there is hoarseness of voice, if there is an inspiratory stridor, if there is any evidence of facial burns, if there is any evidence of facial burns, and if there is severe wheezing. if there is severe wheezing. If any one of the following is present, it is better to go and intubate it. These are the warning signs for intubation. Now, if there are no warning signs for intubation, the last thing that you have to do or take up next is going to be the secondary survey. Take the patient for secondary survey. Take the patient for secondary survey. Now, in the secondary survey, I hope everybody understands, this is where you are going to look for the percentage of body surface area burnt. So this is going to be the assessment. This is going to be the assessment for total body surface area burnt. This is going to be an assessment for the total body surface area that is going to be burnt. Now, when you're talking about this assessment, there are two things that you remember in the assessment. The best is going to be a rule. If you're talking about which is the best method, it is going to be the Lund and the Broders chart. It is going to be the Lund and the Broders chart. But if they ask you which is the most commonly used, which is fast, which is easy and understandable, that is your Wallace rule. The Lund and the Broders chart, no, it's an extensive chart. It is difficult to remember the entire chart. So we'll be following something called as the Wallace rule. Now, the Wallace rule is something what we call it as the rule of 9. So we'll be talking about what is your Wallace rule, which was your exam question. Right? So the Wallace rule is what we call it as the rule of 9. Wallace rule is popularly referred to as the rule of 9. Right? So when you talk about the Wallace rule, you should know that you have to picture two components. So the Wallace rule for adult and child is going to be different. I mean, not very different, but slightly different. So we'll talk about the adult component of the Wallace rule. And there is a child component of the Wallace rule. There's an adult component and there is going to be a child component. Sir, I'm reading Robbins but finds its language difficult. Yield is quite less as compared to Indian books. Aniket, यार Robbins is something which is a symphony. ठीक है, जब आप पढ़ना शुरू करोगे तो इनिशियली मजा नहीं आएगा, थोड़ा लैंग्वेज का भी इशू रहेगा. 2 बार पढ़ोगे you will get gist of it. तीसरी बार पढ़ोगे you will try to understand. जो भी बाकी बुक्स है ना, they all summarize. तो रॉबिन्स में जो बॉक्सेस बने हैं ना, वही बॉक्सेस आपको बाकी टेक्स्ट बुक्स में मिल जाएंगे. राइट? रॉबिन्स इज समथिंग दैट यू हैव टू गिव अ लिटिल बिट ऑफ टाइम. देखो, अगर प्यार करना है तो थोड़ा टाइम देना पड़ेगा. ठीक है? विदाउट इन्वेस्टिंग राइट अमाउंट ऑफ टाइम यू कैन नॉट हैव राइट लव. ठीक है? तो जितना प्यार चाहिए उतना टाइम देना पड़ेगा. रॉबिन्स, हाँ मानता हूँ थोड़ा डिफिकल्ट अभी पढ़ना सेकेंड ईयर में, लेकिन थोड़ा एफर्ट डालोगे, इट विल बी नाइस. ठीक है? नाउ कमिंग बैक टू आवर Wallace rule और द रूल ऑफ 9. ठीक है? सो in the adult, let's say this is the head, this happens to be the neck, this is going to be the trunk is going to be the chest as well as abdomen, this is going to be the lower limb, this is going to be the lower limb here, this is going to be the upper limb. Okay. So this is going to be your upper limb. Right. In the child, same thing. This is the head. This is the neck. This happens to be the trunk. This is the upper limb. And this happens to be the lower limb. Now, in adult, we will also consider this area. This area is what we call it as the perineum, right? Now, when you look at the Wallace rule, in the adult, the head and the neck together, one that I'm shading in green, the head and neck together, it is going to be 9%. So if I just mark it down, the head and neck together, both. It is a combination of head and neck put together. It will account for 9%. The head and neck will account for 9%. Okay? Then comes the upper limb. That is, the upper limb is going to be from the fingertips to that of the entire shoulder. This is the upper limb. The upper limb is going to account for 9%. The upper limb is going to account for 9%. See, if you look at the palm alone, the palm alone is going to account for 1%, right? That does not mean the entire upper limb is 9 and then you have one more is going to be 10. So this is going to be, palm is going to be 1%. Mohammad Yunus, beta BLS, we will continue. We are not going to stop BLS until we finish the entire Bailey. There is no exception to this. But yes, this week has been a slightly busy. So that is why we did not continue the Bailey and Love series. Next Monday, that is from coming Monday onwards, you will see BLS every evening, Monday, Tuesday, Wednesday, 9 to 10. There is no if and but in that. Okay? Bailey karna hai yaar, Bailey ke bina nahi hoga. Now, when it comes down to the trunk, I divided trunk into the anterior trunk and the posterior trunk. Right? So let's say this is the anterior trunk, this is the posterior trunk. Anterior is aage, posterior is piche. Trunk is chest and abdomen together. Remember, the anterior trunk, the anterior trunk accounts for 18% and your posterior trunk, also accounts for 18%. Then it is your perineum which is present here. So this area which I'm shading in red, this is the perineum. The perineum is going to account for 1%. And then you have the lower limb. The lower limb is going to account for 18% each. The lower limb is going to account for 18% each. Right? So this is your standard rule of 9, or also called as the Wallace rule. Okay? So in this, you see the entire percentage of the body surface area burned. The head and neck is going to be 9%, the upper limb is going to be 9%, anterior trunk is 18, posterior trunk is 18, the perineum is going to be 1%, the lower limb is going to be your 18%. When it comes down to child, what is the difference that you're going to see? The first difference, when you're calculating the percentage of total body surface burnt in a child, the head and neck here, the head and neck in a child is going to account for 18%. It is going to account for 18%. The trunk remains the same as adult. This is the anterior trunk, this is the posterior trunk. The upper limb also remains same as adult only, that is going to be 9%, right? So when you go with the upper limb, the upper limb is going to be 9%. The anterior trunk, and the posterior trunk. The anterior trunk is going to account for 18%. The posterior trunk is also going to account for 18%. The lower limb is going to be different from that of the adult. The lower limb in a child will be accounted for 14% each. In a child, it is going to be accounted for 14% each. Okay? So this is what we call it as our Wallace rule, or the rule of 9. So in adult, it is going to be all the way in this context. In child, this is there. What is the difference? Remember the head and neck. In adult, 9%. Child, it is going to be, in a child, it is going to be 18%. Limb in the child is 14%. In adult, it is going to be 18%. There is no perineum in child. In adult, the perineum accounts for 1%. Draw this diagram, put the same percentage. Your examiners are going to give you 100% complete marks. Now, once you're done with this, just to get that extra points, no, you can tell your examiner that I also know the definition of something called as significant burn. Now, when do you call a patient is having a significant burn? Now, the patient is known to have a significant burn. Patient is known to have a significant burn if you calculate, if the patient is, let's say, age less than 10 years, age between 10 to 50 years, and age above 50 years, right? So when you talk about the significant burn, I should be knowing that it is age less than 10, age 10 to 50, or age above 50 years. Now, if it is age less than 10 years, if it is more than or equal to 10% of the total body surface area burnt, it is significant. For age between 10 to 50 years, it is more than or equal to 20% of the total body surface area burnt. It is significant. More than 50 years, it is more than or equal to 10% of the total body surface area burnt. If more than or equal to 10% of the total body surface area burnt, this will be called a significant burn, right? Remember, every patient of significant burn must be addressed with fluid resuscitation protocol. It should be assessed with fluid resuscitation protocol. Now, once you have dealt with significant burns, also quickly mention on zones of burn. So zones of burn में क्या लिखना है? Again, there is a small diagrammatic representation to tell that you understand the extent of the injury in a burn wound. So there are three distinctive zones which are going to be present. Now the zone which is going to have a maximum damage, that is going to be right in the center. Then there will be a zone surrounding this damaged area, and there will be a peripheral zone which is going to be at the end, right? The three distinctive zones that are present. The first one is what we call it as the zone of coagulation. Now the zone of coagulation, it is where there is a maximum injury. There will be maximum injury, and this is associated with tissue necrosis. This is associated tissue necrosis, and this is irreversible. This is irreversible. That is your zone of, this is your zone of coagulation. Now, after the zone of coagulation, the second zone that you see here, this is what we call it as the zone of stasis. This is the zone of stasis. Now, this zone of stasis is basically zone with low tissue perfusion. This is a site, this is a zone with low tissue perfusion. Now, because there is a lesser tissue perfusion here, this is going to be associated with increased risk for necrosis. There's an increased risk for tissue necrosis. It is not necrosed yet, but again, this has got a higher chance of getting into tissue necrosis. Okay? And the last one that you have is the peripheral zone. The peripheral zone is what we call it as the zone of hyperemia. The zone of hyperemia. Somebody saying, Nisha, Kaushik, MBBS is tough than NEET. तो इसीलिए ना बेटा NEET is the entry point, no. तभी तो अगर वो क्रैक करोगे तभी ना आगे पहुंचोगे. ठीक है? It's not that tough as such. ऐसा भी नहीं है. हाँ, थोड़ा ज़्यादा बोल सकते हो, tough नहीं बोलेंगे. चलो. Zone of hyperemia, it is associated with vasodilation. It is associated with vasodilation. It usually consists of viable tissue. This usually consists of viable tissue, and this is associated, or this zone is associated with least risk for necrosis. This is associated with the least risk for necrosis. Okay? So this is what you are going to write in burns, that is the significant burn, and then you have the secondary component, that is a Wallace rule. Okay? Now it is, how do you do a burn fluid resuscitation? So we will follow the burn fluid resuscitation. So when you talk about the burn fluid resuscitation, now burn fluid resuscitation is calculated according to the depth of the burn as well as the percentage of the body surface area that is burned. Okay? So burn fluid resuscitation may, remember, the preferred fluid of choice or the fluid of choice for resuscitation. The fluid of choice for resuscitation. The fluid of choice for resuscitation is going to be your ringer lactate. It is going to be your ringer lactate. Now, in order to know that, how would you look at this? There is something called as the depth of the burn wound classification. So, based upon the burn depth, this is how we're going to classify. So, quickly look at the burn depth. Now, in order to classify the burn depth is classified into first degree burn. You have second degree superficial, second degree deep. This second degree superficial, there is second degree deep. There is a third degree burn and there is a fourth degree burn, right? So, based upon this, we are going to classify our burn wound. So, the first degree burn, the secondary superficial, secondary deep, the third degree burn and the fourth degree burn, right? So, these are the various depth that we are going to analyze right now. So, what is the criteria on which you're going to look across, right? So, the first one that you're going to look is the structure that is burned. First degree, it is only epidermis. Second degree superficial, it is the papillary dermis that is burnt. Secondary deep, it is your reticular dermis that is involved. Third degree is going to be full thickness of the skin. There is the full thickness of skin, and the fourth degree is the involvement of underlying structure. If the underlying structure is also burnt, it is called as the fourth degree burn. It is called as the fourth degree burn, right? Now, when you look at the color of each of these burns, there will be presence of erythema in first degree. Second degree superficial is going to be bright red. The wound will be bright red in color. Secondary deep is going to be mottled pink, or you can also have waxy white. Either you can have a mottled pink appearance or a waxy white appearance, that is your secondary deep. Third degree is going to be your leathery in appearance, and the fourth degree, it is going to be charred like a charcoal, so like a charred appearance. Okay? That is the color. Next comes the component of pain. Wherever you have skin, there is more pain. First degree will have extreme pain. Second degree will also have a lot of pain. Secondary deep will not have any pain, but there is something called as presence of pin prick sensation. So there will be presence of pin prick sensation alone. Third degree, fourth degree, no skin, no pain at all. There is no pain at all. Then it is blister. First degree will have, may or may not have blister. Secondary superficial will have blister. Secondary deep may or may not have blister. Third degree and fourth degree, no skin, no blister. Right? Now, which of the following is likely to heal? The first degree, secondary superficial, secondary deep will heal. The third and the fourth degree will not heal. It will require your intervention. It will require your intervention. Okay? So this is based upon the burn depth. Now, once you have classified the burn depth, how do you calculate the burn fluid? Right? So, burn fluid calculation. Now, for burn fluid calculation, we will follow something called as the ATLS formula. That is, the ATLS, Advanced Trauma Life Support. Okay? Now, according to the ATLS, how do you calculate the burn fluid? Now, according to ATLS, if there is a first degree burn, provide the patient with oral fluids. Provide the patient oral fluids. If it is a second degree or a third degree burn, and if it is a significant burn, second degree or third degree, and it is a significant burn, and if the patient is an adult, how do you calculate? it is going to be 2 ml per kg per percentage of total body surface area burnt. But if it is a child, then it is going to be 3 ml per kg per percentage of total body surface area burnt. If it is a neonate is going to be 3 ml per kg per percentage of total body surface area burnt. Along with that, I will also add the maintenance fluid. I will always add the maintenance fluid to this patient, right? If it is second or third degree burn. If it is a fourth degree burn or an electric burn, it does not matter if it is an adult or a child. In both these patients, I will use 4 ml per kg per percentage of total body surface area burnt, right? So if it is a child or an adult, if it is a fourth or an electric burn, you have to follow your 4 ml per kg per percentage of body surface area burnt. But if it is a second degree or third degree burn, if it is an adult, it is 2 ml, child 3 ml, neonate, it has to be 3 ml with maintenance fluid that you have to give, right? Now, whatever you have calculated, no, this is what we call it as the burn fluid, and this burn fluid is purely for crystalloids. It is going to be crystalloids, right? Now, how would you calculate for colloids? If the colloid resuscitation is required, for colloid resuscitation, we follow something called as the Muir and Barclay formula. Now, how do you calculate Muir and Barclay formula for the colloids? It is going to be 0.5 into weight in kilograms into percentage of total body surface area. Whatever you get, this is how you are going to calculate the fluid, right? So the burn fluid is calculated. For crystalloids, we are going to use ATLS formula. For colloids, we are going to use Muir and Barclay formula, right? Now, here's an important thing. Earlier, there was a formula called as Parkland formula that is obsolete. 4 ml percentage of body surface area burnt. This is how originally the Parkland started, right? So there was another formula which is called as the Parkland formula. The Parkland formula was 4 ml per kg per percentage of total body surface area burnt, but then now Parkland is obsolete. We only follow the ATLS protocol. Now, what is the protocol for fluid administration? Protocol for fluid administration. So, when we talk about the protocol for the fluid administration, remember, first 24 hours, it is going to be crystalloids. If the fluid requirement is there, after 24 hours, you can give colloids, right? So colloids are usually given after the 24 hours or the first 24 hours, right? Now, how do you administer this? I can take a small example to explain you this. Now, example is, let's say I have a 4th degree burn patient who weighs 70 kilograms with 30% of the total body surface area burnt, and the patient is an adult. I can say he's a 30 years old male, right? If you have a question which is like this and they're asking you to calculate the burn fluid for this, now according to whatever we have learned, no, this is 4th degree burn, so it is going to be 4 ml per kg, weight is going to be 70 kilograms into percentage of total body surface area burn, that is 30. So this is going to be 8,400 ml of ringer lactate. So this is the 8,400 ml of ringer lactate must be given within 24 hours, right? So whatever fluid that you have calculated, this is what we call it as burn fluid. And whatever burn fluid that you have calculated, it should be given, or it must be given within 24 hours. within 24 hours, right? So how would you give so? So what we have calculated is, for this patient, the fluid requirement that we have gotten, for this patient, the fluid requirement that you have calculated is going to be an 8,400 ml of ringer lactate. It is going to be an 8,400 ml of ringer lactate. Now, how would you like to administer this fluid? Now, this fluid has to be distributed in 2 equal halves. So 2 equal halves is going to be 4,200 ml as the first half and the 4,200 ml as the second half. Now, this 4,200 ml, which is the first half of the ringer lactate, the first half, and this is the second half. Right, you have calculated the first half as well as the second half of the ringer lactate. Now, whatever fluid that you have calculated, the first half has to be given as fast IV and this has to be given as slow IV. So this has to be given as the fast IV and this has to be given as slow IV. So, but you have to complete the entire fluid resuscitation within the first 24 hours, right? It has to be completed within the first 24 hours, right? Now, just give me 1 second, guys. I'm just getting a phone call from the hospital. Just give me a second. Right, guys, sorry. Right, so as I was saying, fluid administration, the first half is going to be fast IV, the second half is going to be the slow IV. The fast IV means you have to give within 8 hours. And the second half has to be given within the next 16 hours. So within 24 hours, you're going to administer the entire fluid, and that is what we call it as the burnt fluid administration, right? So there is a protocol for burn fluid administration. So when you come to our previous exam questions, what all did we cover? Did we cover the Wallace rule? Yes, we did. Did we cover the management of the burn wounds? We are going to, we have not covered it yet. We will cover it. Topical agents has to be covered. Fluid management and the burn management we have covered. Okay? So let's talk about the topical agents for the burn wound management. So what are the different topical agents that you have? The topical agents for the burn wound management. Number 1 is going to be your silver sulfadiazine. Silver sulfadiazine. Then you have the silver nitrate. Then you have the mefenide acetate. Mefenide acetate. Silver sulfadiazine, silver nitrate, mefenide acetate, and then you have the silver sulfadiazine. Silver sulfadiazine with cerium nitrate. Now, whenever you're using any topical agents, the criteria for using the topical agent, you will see whether it is effective against Pseudomonas. Is it effective against the gram-negative bacteria? Can it penetrate an eschar? It's a fibrotic scar that is formed over the burn. And is there any specific side effect, right? So these are the components that are usually looking at whenever you're deciding for any topical agent, right? So we'll see whether a topical agent is effective in these components or not, right? So these are the parameters that you're going to look into these. So we are going to see, sorry. Is it effective in each one of the following or not? Now, when you talk about the silver sulfadiazine, it is extremely effective against Pseudomonas, extremely effective against gram negative. It cannot penetrate eschar. There are no side effects, right? On the other hand, silver nitrate has a good effect against Pseudomonas, decent effect against gram negative, cannot penetrate eschar. It is going to result in blackening of skin. It is going to result in blackening of skin, right? Mefenide acetate, on the other hand, has got a very little action against Pseudomonas and gram negative, but it can penetrate eschar. Problem with mefenide acetate, it causes metabolic acidosis. And once you apply the mefenide acetate, it is going to increase the pain on the burnt area. Now, the best agent that you have is silver sulfadiazine, effective against Pseudomonas, effective against gram negative, penetrates eschar, and there is no particular side effect. So, the best topical agent is going to be your silver sulfadiazine with your cerium nitrate, right? So this concludes your entire discussion on burns as well, and that's our first lecture for Farre. So I will start with the thyroid first, and then we'll basically based on this. So the question that was asked on thyroid from a surgery standpoint, they've asked you to write what is a solitary thyroid nodule. They asked you about the solitary thyroid nodule, about thyrotoxicosis, about the thyrotoxicosis. They've asked you about goiter as well as the retrosternal goiter. So these were the questions which were asked in our previous exam. In one of the exams, like if you look at the previous section, solitary thyroid nodule was a 5 marks question, thyrotoxicosis was a 5 marks question, goiter they've asked you 3 marks, retrosternal goiter they've asked you about 5 marks question. And then they've asked you these three put together, solitary thyroid nodule, thyrotoxicosis and goiter put together as a 10 marks question, right? So there are different questions and different topics that are asked you. We try to club it together as one so that we understand better. So we'll start with the first topic, that is going to be our retrosternal goiter. That is going to be our retrosternal goiter. Okay. Right. So let's start, or we'll start with solitary thyroid nodule. Okay. So the first topic is going to be to write a short note on a solitary thyroid nodule. So we'll write a short note on a solitary thyroid nodule per se. So this is going to be our answer, and this is about the solitary thyroid nodule. Right. So when you write this answer, first of all, you should know that what is a solitary thyroid nodule and what is its components. So the first thing is, whenever you talk about the thyroid swelling, just write a small classification of the thyroid swelling. Now, in the thyroid swelling, you have a diffuse and a localized thyroid swellings. So divide them into two. They have a diffuse and discrete, which is called as localized thyroid swelling. Diffuse thyroid swelling, the answer or the examples are going to be like goiter. It is going to be goiter. In localized thyroid swellings, when I talk about the localized thyroid swellings, the localized thyroid swellings are divided into two categories. One, it is what we call it as the solitary thyroid nodule. It is the solitary thyroid nodule. Another one is going to be a dominant thyroid nodule. Another one is your dominant thyroid nodule, right? So you have two components. One is going to be a diffuse thyroid swelling. Another one is going to be a localized thyroid swelling. Diffuse, the example is going to be goiter. Localized, it is divided into two categories, solitary thyroid nodule and the dominant thyroid nodule. Now they'll ask you, what exactly do you mean by diffuse thyroid swelling, that is goiter? Goiter is described as a generalized, this is described as a generalized enlargement. There's a generalized enlargement of the thyroid gland. So you will see the entire gland is going to get enlarged. If there is a generalized enlargement of the thyroid gland, that is what we call it as goiter. Now, what is a solitary thyroid nodule? Solitary thyroid nodule is actually an isolated single nodule that is going to be present. So how do you look at it? Solitary thyroid nodule, for the best description, you will say that in the solitary thyroid nodule, if you take this as the representation of the thyroid gland, on the either side you have lobes. If a nodule arises from one of the particular site, and this is what we call it as solitary thyroid nodule. Now, what is a dominant thyroid nodule? In a dominant thyroid nodule, it is like a multinodular status, but here one nodule is going to be quite large. So this is a very big nodule that you will see, and there are multiple smaller nodules also. Now, but these small nodules are not as large or evident as the other one. So hence, the one which is going to be quite big is given the name as a dominant thyroid nodule. This is what we call it as a dominant thyroid nodule. So to be very honest, dominant thyroid nodule is actually a multinodular status, and this is what we call it as an ST, and that is a solitary thyroid nodule presentation, or a solitary thyroid nodule. Remember, of your localized thyroid swellings, 70% of them is going to be a solitary thyroid nodule, and 30% of them is going to be a dominant thyroid nodule, right? So you have a 70% is going to be of a solitary variant, and 30% of them is going to be a dominant thyroid variant, right? Now, again, when you go into the clinical features, you should be able to differentiate the clinical features of the solitary thyroid nodules as well as goiter. So talk about the clinical features of solitary thyroid nodule. Clinical features of the solitary thyroid nodule. Now, when you talk about the clinical features of the solitary thyroid nodule, let's put them into perspective. Number one, you will always start with the age of presentation. STNs are usually seen in the third decade of life. It is usually more common in females. It is more common in females when compared to males. This will be more common in females when compared to males, right? Now, how would they present to you, and what are the presenting feature? Now, the presenting complaint is going to be present to you as a localized, it is going to be associated localized thyroid swelling. Now, majority of these localized thyroid swellings, they are going to be painless. They're going to be painless, and they gradually increase in size. They gradually increase in size, right? Now, if there is a rapid increase in size, it can be presented as malignancy. If they're gradually increasing in size, it indicates probably it is a benign lesion. If there is rapidly increasing in size, a solitary thyroid nodule which is having a rapidly increasing in size, then it could be a malignant lesion. So patient is going to have a localized thyroid swelling which is going to remain painless and gradually increases in size. Now, obviously, this is the presenting symptoms. Now, any patient who comes to you with the thyroid swelling, obviously you will take for examination. So next heading is going to be on examination. So majority of the times, based upon the findings, you will be able to draw some conclusion. Number one, you will notice that this swelling is going to move upwards with deglutination. This is going to move upwards with deglutination. As we all know, every single thyroid swelling is going to move upwards with deglutination because it is attachment of its Berry's ligament. That is, the thyroid gland pulse is attached to the pretracheal fascia with the Berry's ligament. Every time the patient swallows, the trachea moves upwards, the Berry's ligament pulls upwards. Pulling of the Berry's ligament will also cause pulling of this nodule up. So this is going to move upwards with deglutination. Now, along with that, when you're going to palpate it, you will usually be addressed with surface. So when you look at the surface of the thyroid nodule, it can be smooth or it could be nodular. It could be smooth or it could be nodular. Smooth probably indicates a benign lesion. Nodular probably indicates it is going to be a malignant lesion. It is going to be a malignant lesion, right? Now, along with the surface, you look for other components. It is going to move upwards with deglutination. The surface is going to be either smooth or nodular, and it is usually not fixed. It is usually not fixed, right? Now, if you say what are the other features that you can talk about? So, other features that you will encounter here. Now, the patient of solitary thyroid nodule. So, we call it as the solid features associated with ST, and that is a solitary thyroid nodule. It could be associated with that of hypothyroidism. It could be associated with hypothyroidism. It could be associated with euthyroid status, or it could be a hyperthyroid status. So patient can have signs and symptoms of hyperthyroidism also. If it is a hypothyroid associated component, if it is a hypothyroid or else euthyroid associated component, in these conditions, I can say it is probably a benign lesion. It is probably a benign lesion, right? Or it could also be associated with a malignant lesion, because the malignant lesions are usually euthyroid. But if it is a hyperthyroid state, it is what we call it as solitary thyroid nodule causing toxicosis. So it is called, it could be probably toxic adenoma. It could be probably toxic adenoma. So in thyrotoxicosis, again, I'll discuss in detail. So when you talk about if a patient is having features of hyperthyroidism, this is toxic adenoma, right? So this you have to mention in other features so that your examiner knows that you also know the differential diagnosis for this. So any patient who is present with solitary thyroid nodule-like presentation, I would like to evaluate it. So the next one is going to be investigation. Now, here is an important thing that whenever you're talking about any patient who has a thyroid swelling, the list of investigation or the sequence is going to be quite simple to remember. Every patient should undergo a thyroid function test. Now, in the TFT, I'm going to measure the T3 level, the T4 level, as well as the TSH level. Now, because based upon this, I know whether I'm dealing with hypo, U, or hyperthyroid. Remember, a hyperthyroid swelling can never be malignant. So there is no role of FNAC if the patient is having a hyperthyroid status. So first one is going to be thyroid function test. Second one is going to be ultrasound to see whether it is nodular or smooth. And third one, to determine, you have to go with cytology, which is going to be FNAC. You have to follow these three protocols. Get a thyroid function test, get an ultrasound of the thyroid gland, as well as the FNAC of the STN that is present, right? Now, you should always mention that once you have FNAC as a note point, you have to write it. Should be done. It should be done if swelling is associated with euthyroid status or hypothyroid status. Euthyroid status or the hypothyroid status. Remember, there is no role of FNAC if the patient is having hyperthyroid. Why? Because normally the tumor that is going to be formed, that a malignant tumor or a malignancy that is going to develop in the thyroid gland, is usually not associated with functional status of the gland, so it cannot secrete the hormone. So normally we say malignant swellings are likely to be U or hypothyroid. They are not going to produce functional cells. Because they don't produce functional cells, they cannot increase the hormone secretion, so they will never be hyperthyroid. Okay? Now to get into the component, how would you like to manage? So it all depends upon what report did you get on FNAC. So the management of solitary thyroid nodule. So this is going to be the management of the solitary thyroid nodule. It is based on the FNAC finding. It is based on FNAC finding. So what finding are we going to get on FNAC? Based on this, we are going to decide that what is going to be the management protocol like, right? Now, So any patient, I'll just write an algorithm. Remember, any patient who has gotten a solitary thyroid nodule, you will take the patient for FNAC, stands for fine needle aspiration cytology. This is also expected for you in the exam to write the full form. It is your fine needle. It is going to be the fine needle aspiration cytology. FNAC stands for fine needle aspiration cytology. That is the basic that is expected out of it, right? Now, whenever you do an FNAC, based upon the FNAC, you will encounter certain findings, right? So let's look at those findings and try to evaluate them, right? So you will get an FNAC done. Based upon the FNAC, what are the findings? And based upon those findings, you are going to tailor your management also. Now, this starts with the first possibility that you can have. Now, let's say you have done an FNAC and you got a non-diagnostic aspirate. You got a non-diagnostic aspirate. That means FNAC was done, the report was inconclusive. What are you going to do? Remember, management for such conditions, it is going to be repeat. It is going to be repeat FNAC under USG guidance. Repeat FNAC under USG guidance. Now, when you do an FNAC under USG guidance, you will get a better yield for the report. Now, on the other hand, what is the second possibility that you can have? The second possibility is you can get a benign lesion. So the FNAC confirms that it is a benign lesion. In a benign lesion, I have to see whether we are talking about a cystic or a solid nodule. Whether it is a cystic nodule or whether it is a solid nodule. Now, if it is a cystic nodule, the current recommendation is going to be USG guided aspiration. It is going to be USG guided aspiration. If it is a benign or solid nodule, then it is only going to be observation. I am not going to do any active intervention. I am not going to do any active intervention if it is a solid nodule. Now, the third possibility that you can see here, it is going to be something called as AUS. AUS stands for atypia of unknown significance. It stands for atypia of unknown significance. It stands for atypia of unknown significance. Whenever you have atypia of unknown significance, here the answer for the management, it is to repeat FNAC. This is to repeat fine needle. निशा कौशिक, कुछ समझ नहीं आ रहा बेटा, आज का टॉपिक है, हम बात कर रहे हैं सॉलिटरी थायराइड नोड्यूल पे। अगर सवाल आएगा तो जब भी सॉलिटरी थायराइड नोड्यूल पे सवाल आएगा तो सबसे पहले आपको बताना है कि थायराइड स्वेलिंग जो है ना, वो क्लासिफाई कर सकते हो इनटू टू कैटेगरीज। दो डिफरेंट टाइप्स के आपके स्वेलिंग्स होते हैं थायराइड के। एक आप बोलते हो कि डिफ्यूज थायराइड स्वेलिंग है, दूसरा बोलते हैं लोकलाइज थायराइड स्वेलिंग है। डिफ्यूज का मतलब क्या है कि जहां पूरा ग्लैंड एनलार्ज हो जाता है। कहने का मतलब ये है कि मान लीजिए ये आपका नॉर्मल साइज ऑफ द थायराइड ग्लैंड है। डिफ्यूज में आप देखोगे कि पूरा ग्लैंड ही एनलार्ज हो जाएगा, ठीक है, पूरा ग्लैंड ही एनलार्ज हो जाएगा। इसको आप बोलते हो डिफ्यूज थायराइड स्वेलिंग, और इसका जो क्लासिकल एग्जाम्पल है वो गॉइटर है। फिर आप बोलोगे कि लोकलाइज, लोकलाइज का मतलब किसी एक जगह पे पूरा ग्लैंड एनलार्ज नहीं होता। लोकलाइज को हम डिवाइड करते हैं दो डिफरेंट कैटेगरी में, एक को आप सॉलिटरी बोलोगे, दूसरे को डोमिनेंट बोलोगे। सॉलिटरी का मतलब है कि आप देखोगे कहीं एक जगह पे ग्लैंड पे एक नोड्यूल बना हुआ है, उसको आप बोलते हो सॉलिटरी, का मतलब सिंगल थायराइड नोड्यूल बना हुआ है। फिर एक और है डोमिनेंट थायराइड नोड्यूल। डोमिनेंट का मतलब क्या, ये भी लोकलाइज्ड है, एक ही जगह पे, पूरे ग्लैंड में नहीं, एक ही जगह पे। बट आपको यहाँ क्या देखने को मिल रहा है कि आप देख रहे हो कि एक जो नोड्यूल है वो बहुत बड़ा है व्हेन कंपेयर टू रेस्ट ऑफ देम, इसलिए इसका नाम पड़ा डोमिनेंट। मेजॉरिटी ऑफ द टाइम्स व्हेन यू सी दिस, आपको देखोगे कि सॉलिटरी हमारा बहुत कॉमन होता है। 70% जो आपके लोकलाइज थायराइड स्वेलिंग्स होते हैं वो आपके सॉलिटरी होते हैं, 30% डोमिनेंट होते हैं। तो ये आपका पहला पार्ट हो गया। फिर आप बोलोगे कोई भी पेशेंट अगर सॉलिटरी थायराइड नोड्यूल मतलब एक लोकलाइज थायराइड स्वेलिंग के साथ है, वो प्रेजेंट कैसे करेगा, उसकी प्रेजेंटेशन क्या है। नॉर्मली ये आपको देखने को मिलेगा 30 से 40 में, दैट इज 30 to 40 ईयर्स। फिर आप बोलोगे ये ज्यादा फीमेल्स में देखने को मिलता है। प्रेजेंटेशन क्या है, एक नोड्यूल मिलेगा, स्वेलिंग है,
यूजुअली उसमें कोई दर्द होता नहीं है, पेनलेस होता है, वो धीरे धीरे बढ़ता है, तो अगर वो बिनाइन हो जाएगा, अगर वो जल्दी बढ़ने रैपिडली इंक्रीज होगा तो आप बोलोगे प्रॉब्लली मैलिग्नेंट स्वेलिंग है। फिर आप बोलोगे हम इस पेशेंट को एग्जामिन करेंगे। एग्जामिनेशन की फाइंडिंग्स क्या है, पहले देखोगे ये जो स्वेलिंग है ये ऊपर चलेगा बाय डिग्लूटिनेशन। कार्डिनल फीचर ऑफ थायराइड और थायराइड एसोसिएटेड स्वेलिंग क्या है, द स्वेलिंग मूव्स अपवर्ड्स विद डीग्लूटिनेशन। इफ अ स्वेलिंग मूव्स अपवर्ड्स विद डीग्लूटिनेशन, उसका मतलब ये है कि वो थायराइड बेस्ड स्वेलिंग है, पहली बात, ठीक है। अच्छा, दूसरा आप बोलोगे कि सरफेस कैसा है। जब आप सरफेस छू के देखोगे, अगर वो स्मूथ और यूनिफॉर्म है तो बिनाइन होगा, अगर नॉडुलैरिटी है तो प्रॉबेबली मैलिग्नेंट है। तो आपको ये दिमाग में रखना, आपको बताना है एग्जामिनर को, मुझे पता है कि एग्जामिन भी करना है। फिर आप बोलोगे कि कोई भी पेशेंट अगर सॉलिड थायराइड नॉड्यूल का आता है, कोई भी थायराइड स्वेलिंग्स में हमेशा आपको पता होना चाहिए कि पेशेंट यू थायराइड है। यू का मतलब थायराइड का लेवल नॉर्मल है, हाइपो का मतलब लेस कम सेक्रेशन हो रहा है, हाइपर का मतलब ज्यादा सेक्रेट हो रहा है। तो ये आप कैसे पता करोगे, वो आप टीएफटी के थ्रू करोगे, वो हम आगे बता रहे हैं, ठीक है। तो सॉलिटरी थायराइड नॉड्यूल में आपके 3 स्टेटस हैं, या तो हाइपो, यू, हाइपर हो सकता है। जब भी पेशेंट हाइपो और यू होगा वो प्रॉबेबली बिनाइन या मैलिग्नेंट की वजह से होगा। बिनाइन मतलब नॉर्मल लीजन, मैलिग्नेंट मतलब कैंसर। लेकिन अगर वो हाइपर थायराइडिज्म की वजह से वो उसका एक कंडीशन होता है टॉक्सिक एडिनोमा, आगे चल के बात करेंगे, एक और क्वेश्चन है, ठीक है। तो आपने इसको डिफरेंशियल बता दिया। आप बोलोगे कि इसको इन्वेस्टिगेट कैसे करोगे। कोई भी पेशेंट थायराइड स्वेलिंग के साथ आता है, 3 चीजें करनी है, टीएफटी थायराइड फंक्शन टेस्ट करना है, अल्ट्रासाउंड करना है, एफएनएसी करना है। हम एफएनएसी कौन से थायराइड स्वेलिंग्स में नहीं करेंगे, जहां पे वो हाइपर होगा, ठीक है। सो शुड बी डन, देखो एफएनएसी आप तभी करोगे जब वो यू या हाइपो होगा। हाइपर में एफएनएसी का कोई रोल है ही नहीं, क्यों, बिकॉज हाइपर थायराइड स्टेटस में जो स्वेलिंग्स होते हैं वो यूजुअली मैलिग्नेंट होते ही नहीं है, तो यू कैन बी लेस अबाउट इट। अब बारी है इसको मैनेज कैसे करोगे। डायग्नोस तो कर लिया, ठीक है, आपने अल्ट्रासाउंड किया, अल्ट्रासाउंड करने के बाद आपको पता चला आइसोलेटेड नॉड्यूल है, थायराइड फंक्शन टेस्ट में आपको रिपोर्ट आई कि यू या हाइपोथायराइड है, आपने एफएनएससी की। तो एफएनएससी में आपके पैथोलॉजिस्ट क्या रिपोर्ट देंगे, वो आपको बोलेंगे नॉन डायग्नोस्टिक। मतलब जो आप एफएनएससी कैसे करते हैं, यू टेक अ सिरिंज, यू टेक अ नीडल, यूजुअली 10 cc सिरिंज लेते हैं, 840 आई मीन यू कैन टेक एन 22 और 26 गेज नीडल लेते हैं आप, जहां पे स्वेलिंग है उसके अंदर डालोगे, उसको एस्पिरेट करोगे, एस्पिरेट करके ग्लास स्लाइड में डालोगे, पैथोलॉजिस्ट को दोगे, पैथोलॉजिस्ट देख के बताएगा। अब मान लो कि आपने सही जगह से एफएनएससी ली नहीं है, तो आपको मिल जाएगा नॉन डायग्नोस्टिक एस्पिरेट, तो आपका पैथोलॉजिस्ट बोलेगा भाई रिपीट करा ले, ठीक है। उसी का आप बोलेगा रिपीट अंडर, तो अल्ट्रासाउंड के थ्रू करेगा, तो मतलब यू डू मोर टारगेट ओरिएंटेड। फिर आती है बारी बिनाइन लीजन है। बिनाइन का मतलब कैंसर है ही नहीं, तो बिनाइन में क्या है, सिस्ट का मतलब क्या होता है, फ्लूइड फिल्ड। सॉलिड का मतलब क्या होता है, इट इज एक्टिव प्रोलिफरेशन ऑफ सेल्स। अगर सिस्टिक है तो यूएसजी गाइडेड एस्पिरेशन, आप अल्ट्रासाउंड लोगे, नीडल डालोगे सिस्ट में, उससे फ्लूइड खींच लोगे, स्वेलिंग डिसअपीयर हो जाएगा। दूसरा है अगर सॉलिड है तो छोड़ दो, बिनाइन की है ना, कोई डरने की बात है ही नहीं, उसको बोलना आराम से ऑब्जर्व, हर साल एक बार आके अल्ट्रासाउंड करा लेना, ऑब्जर्वेशन। फिर एक और फाइंडिंग होती है एयूएस। एयूएस का मतलब होता है एटिपिया ऑफ अननोन सिग्निफिकेंस। इसका मतलब क्या है, पैथोलॉजिस्ट बोल रहा है सर देखो कुछ तो लोचा है, लेकिन वो सिग्निफिकेंट है कि नॉन सिग्निफिकेंट है, मतलब इज इट पॉइंटिंग टुवर्ड्स मैलिग्नेंस, इज इट पॉइंटिंग टुवर्ड्स बिनाइन, मुझे समझ में नहीं आ रहा। तो आप बोलोगे देखो अगर समझ में नहीं आ रहा, मैं एक और बार आपको एफएनएससी करके दे देता हूँ, इस बार आप बेटर समझ लो, ठीक है। तो उसको बोलते हैं रिपीट एफएनएससी। यहां तक क्लियर है। फिर बारी आती है कि पेशेंट को हो सकता है रिपोर्ट आ जाए फॉलिकुलर नियोप्लाज्म। अभी जो फॉलिकुलर नियोप्लाज्म है ना, द वर्ड नियोप्लाज्म का मतलब होता है न्यू ग्रोथ। द वर्ड नियोप्लाज्म का मतलब होता है न्यू ग्रोथ, फॉलिकल से न्यू ग्रोथ आ रहा है। अब ये बिनाइन है मैलिग्नेंट है, ये कैसे पता चलेगा। एक हमारे पास प्रॉब्लम है, रिमेंबर एफएनएससी जो है, एफएनएससी कैन नॉट डिफरेंशिएट, it cannot differentiate between a benign condition that is called as follicular adenoma and follicular carcinoma। तो जब भी आपका पैथोलॉजिस्ट रिपोर्ट देगा कि फॉलिकुलर नियोप्लाज्म है, वो आपको बताने की कोशिश कर रहा है कि मुझे समझ में नहीं आ रहा कि ये बिनाइन है, इज इट एन एडिनोमा और इज इट अ कार्सिनोमा। तो उसके लिए क्या करोगे, ऐसे पेशेंट में you will take the patient for surgery and I am going to do something called as lobectomy। उसको आप फ्रोजन सेक्शन के लिए भेजोगे। नाउ ये फ्रोजन सेक्शन ये कॉन्सेप्ट है ना, क्या है, लोबेक्टमी में आप जिस लोब में ट्यूमर है वो पूरा लोब ऑफ द थायरॉइड ग्लैंड निकालोगे, आप पैथोलॉजिस्ट को बोलोगे कि देन एंड देयर इटसेल्फ वो आपके स्लाइड्स बनाएगा और इवैल्यूएट करके बता देगा कि बिनाइन है मैलिग्नेंट, एज सिंपल एज दैट। तो मतलब ये ड्यूरिंग द सर्जरी विद इन दी ओटी होता है, ताकि यू कैन टेक क्विक डिसीजंस, ठीक है। अगर बिनाइंग होगा तो बंद करके आ जाएंगे, मैलिग्नेंट होगा तो पूरा थायराइड ग्लैंड निकाल देंगे, एज सिंपल एज दैट। दिस इज अबाउट योर फॉलिकुलर नियोप्लाज्म, दैट इज अबाउट योर फॉलिकुलर नियोप्लाज्म। फिर पॉसिबिलिटी आती है कि आपका पैथोलॉजिस्ट बोलेगा सर इट इज सस्पिशियस ऑफ मैलिग्नेंसी, it is suspicious of malignancy. Now if it is suspicious of malignancy तो क्या करोगे, इसमें भी यही करोगे। सस्पेक्ट कर रहे हो ना, तो कंफर्म कैसे करोगे? कंफर्म आप करोगे लोबेक्टमी विद फ्रोजन सेक्शन। और लास्ट एंड मोस्ट इंपॉर्टेंट वन, अगर रिपोर्ट आती है कि दिस इज अ मैलिग्नेंट लीजन, अगर वो मैलिग्नेंट लीजन है तो स्टेज वाइज मैनेजमेंट करेंगे, खत्म बात। ओके if it is a malignant lesion, then here it has to be stage wise management. This is going to be stage wise management. Clear है? तो जब भी आपके पास क्वेश्चन आएगा सॉलिटरी थायराइड नोड्यूल को मैनेज कैसे करना है, ये टेबल आपको डालना है। अगर आपको थोड़े पॉइंट्स एक्स्ट्रा कमाने, आपको अगर यू हैव टू इम्प्रेस योर एग्जामिनर, इसको बोलते हैं बेथसिडा क्लासिफिकेशन। जो भी हमने सीखा पूरा मैनेजमेंट प्रोटोकॉल नो, इसको बेथसिडा क्लासिफिकेशन बोलते हैं। तो थोड़ा इसमें अगर मिर्ची डालनी है कि दैट यू आर ट्राइंग टू इम्प्रेस योर एग्जामिनर कि क्या है, तो आप बोलोगे ये बेथसिडा क्लासिफिकेशन है, एज सिंपल एज दैट, ठीक है। सो आज का हमारा पहला टॉपिक था सॉलिटरी थायराइड नोड्यूल पे अगर नोट डालना है तो दिस इज व्हाट यू हैव टू राइट फॉर 5 मार्क्स, ठीक है। तो इतना डाल दोगे, इट इज मोर देन इनफ। एग्जामिनर इज क्वाइट इम्प्रेस्ड कि यार इस बच्चे को सब कुछ आता है। क्लियर है? ठीक है। ठीक है, कैन यू मूव ऑन? ग्रेट। तो अभी हमारा सेकंड क्वेश्चन क्या है? सेकंड क्वेश्चन अगेन इंपॉर्टेंट वन, हम बात करेंगे थायरोटॉक्सिकोसिस की, ठीक है। तो बात करते हैं थायरोटॉक्सिकोसिस। So the second question that you have is of thyrotoxicosis. ठीक है। So thyrotoxicosis is basically a thyroid swelling associated with hyperthyroid status. ठीक है। So thyrotoxicosis is hyperthyroidism associated with thyroid swelling. So हमारी ओपनिंग लाइन हो जाएगी कि थायरोटॉक्सिकोसिस बेसिकली डिफाइंस एज hyperthyroidism associated with thyroid swellings is what we called as thyrotoxicosis. This is what we called as the thyrotoxicosis. ठीक। तो आप बोलोगे thyrotoxicosis ना can be divided into two varieties. This is what we called as the primary thyrotoxicosis. Another one is a secondary thyrotoxicosis. So दो differential points में बात करेंगे. Number one is going to be the primary thyrotoxicosis and the secondary thyrotoxicosis. The primary thyrotoxicosis and the secondary thyrotoxicosis. So the primary thyrotoxicosis and the secondary thyrotoxicosis, right? What is the definition behind this? A primary thyrotoxicosis, in a primary thyrotoxicosis, there are signs and symptoms. The signs and symptoms of hyperthyroidism. Signs and symptoms of hyperthyroidism arise first and then followed by development of thyroid swelling, then followed by the development of thyroid swelling. It is then followed by the development of the thyroid swelling. This is called as primary thyrotoxicosis. Sir, will there always be a swelling associated with thyrotoxicosis? But usually if you're saying swelling with hyperthyroidism, then it is thyrotoxicosis. Otherwise, it will be called as hyperthyroidism. Okay? So that is why, when the word thyrotoxicosis, that means toxic status itself indicates hyperthyroidism. So why it is happening? It is secondary to a swelling that is arising into the thyroid gland. So you're interpreting that swelling to cause the thyrotoxicosis, right? So it is a non-componentary form of hyperthyroidism. That means the primary condition is within the thyroid gland. So that is why we call it as thyrotoxicosis. In secondary thyrotoxicosis, it will be thyroid swelling. Here the thyroid swelling arises first. It arises first, then followed by signs and symptoms. Then followed by the signs and symptoms of hyperthyroidism. Signs and symptoms of hyperthyroidism. This is what we call it as सेकेंडरी थायरोटॉक्सिकोसिस. ठीक है, तो प्राइमरी और सेकेंडरी में फर्क क्या है? प्राइमरी में थायरोटॉक्सिकोसिस हाइपरथायराइड के फीचर्स पहले आएंगे, स्वेलिंग बाद में आएगा. लेकिन वही अगर आप देखोगे सेकेंडरी थायरोटॉक्सिकोसिस में क्या है कि पहले थायराइड स्वेलिंग आएगा, उसके बाद सिम्टम्स आएंगे टॉक्सिकोसिस के. अगर टॉक्सिकोसिस पहले है, स्वेलिंग बाद में, तो प्राइमरी है. अगर स्वेलिंग पहले है, सिम्टम्स ऑफ टॉक्सिकोसिस बाद में, तो सेकेंडरी. इतना सिंपल है. तो सिम्टम्स स्वेलिंग प्राइमरी, स्वेलिंग देन सिम्टम्स देन इज सेकेंडरी. सिंपल है. ठीक है, ये आप नहीं भूलना. दिस इज द मोस्ट इंपॉर्टेंट थिंग. सो द फर्स्ट थिंग, तो आपके एग्जामिनर को क्लियर कट आइडिया है कि इस बच्चे को पता है कि प्राइमरी और सेकेंडरी थायरोटॉक्सिकोसिस में फर्क क्या होता है. नाउ यही थायरोटॉक्सिकोसिस के व्हाट आर द कॉजेस. सो वी टॉक अबाउट द कॉजेस ऑफ थायरोटॉक्सिकोसिस. द कॉजेस ऑफ thyrotoxicosis. When you look at the causes of the thyrotoxicosis, we can divide them into three major causes that we can talk about it. Number one, it can be because of the Graves' disease. Number two, it can be because of the Plummers' disease. And number three, it is because of autonomous. It is because of an autonomous adenoma. It is because of autonomous adenoma, right? So usually you should be able to answer these three findings that are present. ठीक है. So again, हमारा यही है कि सारे आंसर्स आप टेबल या कंपैरेटिव स्केल में दोगे ताकि आपका एग्जामिनर इम्प्रेस्ड रहे. ठीक है. सो विल टॉक अबाउट ग्रेव्स डिजीज, वी टॉक अबाउट द प्लमर्स डिजीज, एंड वी टॉक अबाउट द टॉक्सिक एडिनोमा. ठीक है, चलो. सो ग्रेव्स डिजीज इज ऑल्सो रेफर्ड टू एज, इसके ऑल्टरनेट नेम्स देख लेते हैं. ग्रेव्स डिजीज ऑल्सो नोन एज, this will be also known as diffuse toxic goiter. This is what we call as diffuse toxic goiter. This is what we call it as a toxic multinodular goiter. This is your toxic multinodular goiter, and this is what we call it as toxic adenoma. Right? Graves is an example of, it is an example of primary thyrotoxicosis. It is an example of primary thyrotoxicosis. Toxic multinodular goiter, it is an example of secondary thyrotoxicosis. It is an example of secondary thyrotoxicosis. ठीक है. So when you look at this, sorry. Now, Graves is what we call it as the primary thyrotoxicosis. Plummers is what we call it as the secondary thyrotoxicosis. ठीक है? Now, इनके specific causes क्या है? So when you look at the Graves disease, Graves is an autoimmune disorder. Right? Plummers disease, it is because of long standing. It is because of long standing untreated goiter. This is your Plummers disease. Autonomous adenoma क्या है? इसका रीजन मुझे भी नहीं पता है, किसी को भी नहीं पता. It is idiopathic. It is going to be idiopathic. Just give me a second, guys. I'm getting a repeated call. Just hold on for a second. Okay, guys. So the causes for Graves, it is going to be autoimmune. Plummers, it is going to be your long-standing untreated goiter. For toxic adenoma, it is going to be idiopathic. Okay. Now let's talk about the pathophysiology. Now, Graves, because it is an autoimmune disorder, it will be associated with an antibody. Now, remember the antibody that is going to be formed in Graves disease goes by the name as LATS. Now, what is LATS stands for? LATS is your long-acting. It is going to be long-acting thyroid stimulating antibody. There's going to be a long-acting thyroid stimulating antibody, right? Now, what is the pathophysiology of Plummers disease? It is not understood, so it is unknown pathophysiology. But it has been noticed that 30% of multinodular goiter, they present as secondary thyrotoxicosis. They present as secondary thyrotoxicosis. Autonomous adenoma ka pathophysiology is again unknown because the cause is idiopathic. It is unknown. But what you can say in autonomous adenoma is, we call it as autonomous because it is independent. It is independent of TSH. It is an independent of TSH. That means, see, for every follicle to release a T3, T4 hormone into the circulation, you require a thyroid stimulating hormone to come and attach to that of the thyroid follicular cell so that it it releases it. Whereas in a toxic adenoma, it is not reliant on, or it is not basically waiting. It is not currently, it is not waiting for a TSH to come, stimulate it, and then produce it out. Okay. Okay. Clear, guys, right? Elevate, thank you so much. Chalo. The app is updating. Can't help it. Give me 1 second. ठीक है. Clear. Now this is with respect to Graves, Plummers disease as well as autonomous adenoma. ये इसके pathophysiologies हैं. Now if you dig a little bit deep into the pathophysiology, let's understand कि how does it happen so. Now, how does it happen? Okay. So you'll write about the components, the causes, the pathophysiology, and all this you have already mentioned. Okay. Now we'll talk about the clinical features of each one of them. So in clinical features, what do you see in the Graves disease? Now, Graves is a primary thyrotoxicosis. Primary का मतलब क्या है? First, there will be signs and symptoms of hyperthyroidism. So, there will be presence of signs and symptoms. There are signs and symptoms of hyperthyroidism. The signs and symptoms of hyperthyroidism. Second, it is going to present to you as goiter-like swelling. Now, इससे पहले I've just explained you कि goiter का मतलब क्या है? There's a generalized enlargement of the thyroid gland. So there'll be signs and symptoms of hyperthyroidism, and it is going to present to as goiter-like swelling, right? So there will be, if you talk about what is goiter-like swelling, a quick word on goiter you can say. It will present to you as midline neck swelling. It will present to you as a midline neck swelling. This midline neck swelling is going to remain painless. It is going to gradually increase in size. This is going to gradually increase in size. Along with increase in size, it is also going to, when you talk about it in terms of enlarged gland, because it's a goiterous gland, no, it is going to enlarge. Now, once it is going to enlarge, so there's a midline neck swelling, there's going to remain painless. It gradually increases in size. Now, as it increases in size, it can also, cause a little bit of compressive component also. So it will be associated, can also result in pressure symptoms. Now, what are pressure symptoms is, whenever a thyroid gland enlarges, no, because it's present right in the center, it is going to exert pressure onto the trachea. Trachea compress हो जाएगा तो सांस लेने में दिक्कत होगी, तो इसको डिस्निया बोलते हैं. ट्रेकिया के पीछे आपका ईसोफेगस है, ईसोफेगस कंप्रेस हो जाएगा तो स्वॉलो करने में डिफिकल्टी हो जाएगा, जिसको डिस्फेजिया बोलते हैं. अब ट्रेकिया और ईसोफेगस के बीच में ना रेकरेंट लैरिंजियल नर्व होती है, अगर वो कंप्रेस होगी, रेकरेंट लैरिंजियल नर्व के कंप्रेशन की वजह से होर्सनेस ऑफ वॉइस देखने को मिलेगा. और ये सिम्टम्स अगर प्रेजेंट है तो आप इसको प्रेशर सिम्टम्स बोलते हो, राइट. सो इट इज गोइंग टू हैव गोइटर लाइक प्रेजेंटेशन. गोइटर लाइक में इसमें मिडलाइन नेक स्वेलिंग हो गया, पेनलेस हो गया, ग्रेजुअली इंक्रीजिंग इन साइज, प्रेशर सिम्टम्स देखने को मिलेंगे. दैट इज गोइंग टू बी इन योर ग्रेव्स डिजीज. जब ग्रेव्स डिजीज का पेशेंट एग्जामिन करोगे, यू विल नोटिस इट इज गोइंग टू हैव स्मूथ सरफेस. इट इज गोइंग टू हैव अ स्मूथ सरफेस. और वन मोर इंपॉर्टेंट थिंग, बिकॉज द वास्कुलरिटी ऑफ द ग्लैंड. अब ग्रेव्स में क्या है, बिकॉज ऑल दीज लैच नो लॉन्ग एक्टिंग थायराइड स्टिमुलेटिंग एंटीबॉडीज, बिकॉज ओवर स्टिमुलेशन विच इज कॉज एक्सेसिव ग्रोथ और एक्सेसिव प्रोलिफरेशन ऑफ द फॉलिकुलर सेल्स, तो नियोवास्कुलराइजेशन होता है, ज्यादा ब्लड वेसल्स आते हैं. बिकॉज ऑफ इंक्रीज वास्कुलरिटी ऑफ द ग्लैंड्स इन द ग्रेव्स डिजीज, ब्लड इज रिस्पॉन्सिबल फॉर कैलोरीजेनेसिस, नो. सो यू विल सी प्रेजेंस ऑफ वार्म सरफेस ऑल्सो, इट इज गोइंग टू बी वार्म सरफेस. तो यहाँ पे टेम्परेचर भी एलिवेटेड देखने को मिलेगा, राइट. सो इट इज गोइंग टू बी स्मूथ एंड इट इज ऑल्सो गोइंग टू बी वार्म सरफेस. ठीक है. When it comes down to your Plummers disease, that is secondary thyrotoxicosis, patient is going to present to you with multinodular goiter-like presentation. So in a multinodular goiter-like swelling, what is going to happen? Everything will remain same, right? It will also present to you as midline neck swelling. This is also going to be as a midline neck swelling. This will also remain painless. This will also gradually increase in size. This will also gradually increase in size. This will also be associated with same pressure symptoms. This will also be associated with same pressure symptoms. On examination, this is where you will have nodular surface. There is no altered temperature. There is no altered skin temperature. That means, like in Graves, no, it feels warm. Here it is nothing. And this is going to move upwards. This swelling is going to move upwards with deglutination. This is going to move upwards with deglutination. Obviously, your Graves disease is also going to move upward with deglutination. This is also going to move upwards with deglutination. Okay? So these are the differentiating factors between each of them. टॉक्सिक एडिनोमा में क्या लिखोगे? टॉक्सिक एडिनोमा में obviously another finding in your Plummers disease there will be presence of signs and symptoms. The signs and symptoms of hyperthyroidism. There is signs and symptoms of hyperthyroidism. ठीक है, तो इसका कहने का मतलब क्या है? प्राइमरी में आपने बताया, देखो अगर आप प्राइमरी देखोगे ना, पहले सिम्टम्स ऑफ हाइपरथायराइडिज्म फिर स्वेलिंग आया, सेकेंडरी में क्या है, पहले स्वेलिंग आया फिर सिम्टम आया। ये जब लिखोगे आपका एग्जामिनर ऑलरेडी इंप्रेस्ड है, मतलब वो तो बोलेगा कितना ऑसम है ना, और वो फिर पूरे मार्क्स दे देगा। टॉक्सिक एडिनोमा में क्या है? टॉक्सिक एडिनोमा में पेशेंट विल प्रेजेंट यू विथ सॉलिटरी थायराइड नोड्यूल लाइक प्रेजेंटेशन। It will present to you as solitary thyroid nodule-like swelling. Now, ये जो solitary thyroid nodule-like swelling होगी, this will also be present in the midline of the neck. This will also present as midline neck swelling. This will also remain painless. इसका जो growth pattern होगा वो भी same. This is going to be gradually increasing in size. It will be gradually increasing in size. There are no pressure symptoms. बट यहां पे आप देखोगे that usually it will be associated with a smooth surface. Usually it is associated with smooth surface, and there will be signs and symptoms. There will be signs and symptoms. There will be signs and symptoms of hyperthyroidism. There will be signs and symptoms of hyperthyroidism. ठीक है, so these are all in favor of 3 distinctive presentation. ठीक है, अब Graves में ना, when you look at the differentiating findings as well, अब क्या differentiate करोगे? In Graves we'll talk about the age of presentation, which is the most likely sex to be involved, other findings that we're going to talk about it. ठीक है, तो फिर आप यहाँ पे now we'll say what is the age of presentation of each of them, right? So when you talk about Graves, it is an autoimmune disorder. Graves वाला जो patient है, it is usually seen between the 2nd to 3rd decade of life, so usually between 20 to 30 years. Plummers disease is usually seen in 4th to 5th decade of life, that is between 40 to 50 years, right? 40 to 50 years. Toxic adenoma can be seen at any age group. It can be seen at any age group. So when you talk about which is the more likely sex to be involved, remember in all these disorders, it is female which are more likely to be involved when compared to males. You will say it is the female that is more likely to be involved when compared to males, as simple as that. Now, something really interesting and important that you should know, it is going to be the extra thyroid manifestation. So when you talk about the extra thyroid features rather than saying manifestations, we talk about extra thyroid features. Now, the most common disease among all these 3 which has extra thyroid manifestations is the Graves disease. So Graves में ना, when you look at it, the extra thyroid manifestation, number 1, it is associated with Graves ophthalmopathy. Now this Graves ophthalmopathy basically means what? The Graves ophthalmopathy is nothing but exophthalmos. If your examiner asks why is there an exophthalmos that is going to occur? Now the basic concept for development of an exophthalmos is, if you take this as a representation of the orbit of the eye. अब ये जो orbit है ना eye का, it is a bony cavity और it is a very limited space. It only have 30 cc, मतलब इतना ही space है. इसी orbit के अंदर you will find that the human eye is present. So this is a representation of the human eye. अब eye जो है इसी orbit के अंदर fit है. अब along with the eye being inside this orbit, जितने भी आपके ocular muscles हैं. Now we talk about the ocular muscles. You have the superior oblique, you have the superior rectus, inferior rectus, you have the medial rectus as well as the lateral rectus, the superior oblique and the inferior oblique, right? So superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, inferior oblique, these are the 6 rectus muscles that are present. The problem is all these antibodies which are present, as we have discussed it, the antibodies that are developed here, these are what we call it as the long-acting thyroid stimulating antibodies. Now these LATs antibodies, they sometimes they get misdirected and they go attack the ocular muscles. Now they perceive the ocular muscles as a foreign, so वो जाके ocular muscles को attack करते हैं. When they attack the ocular muscles में what is going to happen? It is going to result in inflammation. ठीक है? That injured ocular muscle will result in development of retroorbital edema. ये जो inflammation हुआ ना, इस inflammation की वजह से this antibodies which have attacked the ocular muscles, there will be a lot of fluid that is going to get deposited that is causing retroorbital edema. अब ये retroorbital edema की वजह से क्या हो रहा है? It is now pushing the eyeball forward. So जितना भी fluid accumulated है, it is going to push the eyeball forward. Now as the eyeball has been pushed forward, it is going to protrude out of the eyeball or the orbit. Now as the eyeball protrudes out of the orbit, this protrusive eyeball is what we call it as exophthalmos. So exophthalmos in Graves' disease is because of the cross-reacting antibodies injuring or attacking the ocular muscles. So ये आपका पहला हो गया, that is Graves' ophthalmopathy. इसके साथ साथ you will see presence of Graves' dermopathy. So skin differentiation होगा, that is Graves' dermopathy is there. Then there will be development of thyroid acropathy. Now this thyroid acropathy is basically formation of new bones in the metacarpals. It is basically the formation, there is formation of new bones in metacarpal. There is formation of new bones in the metacarpal, that is because of excessive calcium deposits. ठीक है? So Graves' ophthalmopathy होगा, Graves' dermopathy, thyroid acropathy. It is also associated with gynecomastia. It is also associated with gynecomastia. ठीक है? So these are the important extra thyroid manifestations that you have. There are no specific extra thyroid manifestations that you will see in these two. So extra thyroid manifestations, usually they are seen in Graves' disease, right? Now, when you talk about the hyperthyroidism, which system is involved in hyperthyroid features? Okay? So when you talk about the most common system involved in each of these diseases, that is also an important question to be analyzed. So the most common system that is going to be evaluated on, ठीक है? Most common system कौन सा है? The most common system, when you look at the component here, the most common system involved which is going to be involved, remember for Graves' disease, it is going to be CNS. This is going to be cardiovascular system. Here, not any one particular system is usually involved. ठीक है? So you will have more of CNS features in Graves. CNS features क्या यार? Hyperthyroid के features है ना? Irritability, anxiety, insomnia, all that is more common in your Graves disease. CVS के क्या? Palpitation, tachycardia. The patient is going to have high perfusion. Sympathetic overdrive. No, so there's excessive perfusion. So patient is going to be sweating a lot. All these are more common in your Plummers disease. Now, जब भी आपके पेशेंट आते हैं with thyrotoxicosis, सारे फीचर्स थायराइड स्वेलिंग के साथ है, तो इसमें आप इन्वेस्टिगेशन क्या करोगे? The second next thing that we are going to talk about, the patient is presented with all these symptoms. What is going to be our investigation? Now, investigation for all thyroid swelling, चाहे आप कोई भी thyroid swelling उठा के देख लो, investigation का जो protocol है, that is going to be quite standard. सबसे पहले आप, the first thing that I'm going to do is going to be thyroid function test. So in sub में आप thyroid function test. In all these, the first test that I'm going to do is going to be thyroid function test. ठीक है? जब आप देखोगे thyroid function test में क्या measure कर रहे हो, you are looking at the T3 level, you are looking at the T4 level, you are looking at the TSH. Now Graves में there is an antibody, right? that antibody is causing overstimulation of the T3, I mean follicles. So there's one excessive release of T3, T4. जब excessive release of T3, T4 होगा, negative feedback की वजह से क्या होगा, the TSH is going to drop. So this is how the picture of your hyperthyroid status would look like. तो सेम यहाँ पे भी आप वही देखोगे, T3 आप देखोगे, you will measure the T4 and you will measure the TSH. Here also you're going to do the same thing. You're going to measure the T3 level, you're going to measure the T4 level, you're going to measure the TSH level. Now, what is going to happen in your secondary thyrotoxicosis? Now, in secondary thyrotoxicosis, this excessive release of T3, T4 from the nodular status itself. जब जैसे ये T3, T4 excess release करेगा, negative feedback से TSH drop करेगा. ऑटोनमस एडिनोमा में क्या है, दी एडिनोमा विच इज फॉर्म, वो अपने आप से ही हार्मोन बना रहा है और रिलीज किए जा रहा है, और जैसे जैसे रिलीज करेगा वैसे वैसे T3 T4 का लेवल इंक्रीज करेगा, TSH का ड्रॉप करेगा. तो बेस्ड अपॉन द TFT मैं थोड़ा डिफरेंशिएट कर सकता हूं कि ग्रेव्स डिजीज है और इट इज गोइंग टू बी अ प्लमर्स डिजीज और इट इज गोइंग टू बी टॉक्सिक एडिनोमा. तो अब नेक्स्ट क्या करोगे, द सेकंड इन्वेस्टिगेशन दैट आई एम गोइंग टू डू हियर, इट इज गोइंग टू बी अल्ट्रासाउंड. तो अल्ट्रासाउंड में फाइंडिंग क्या मिलेगी, ग्रेव्स में आपको स्मूथ सरफेस मिलेगा. यहां पे जब आप अल्ट्रासाउंड करोगे यू विल सी नॉड्यूलर सरफेस, सो यू विल सी लॉट ऑफ नॉड्यूल्स आर गोइंग टू बी प्रेजेंट. वेराज यहां पे जब आप अल्ट्रासाउंड करोगे टॉक्सिक एडिनोमा में, इट इज यूजुअली सॉलिटरी नॉड्यूल दैट इज गोइंग टू बी प्रेजेंट. दिस विल बी एसोसिएटेड सॉलिटरी नॉड्यूल. ग्रेव्स में जब अल्ट्रासाउंड करोगे एक और एडिशनल फाइंडिंग मिलेगी, देयर विल बी इंक्रीज्ड वास्कुलैरिटी ऑफ द ग्लैंड, देयर विल बी इंक्रीज्ड वास्कुलैरिटी ऑफ द ग्लैंड. ठीक है, whereas here there is no other component. In this you can also see presence of colloid rich nodules. You see colloid rich nodules. ठीक है, अब आपको पता है there is no role when you come to this, there is no role of FNAC क्योंकि ये टॉक्सिक स्वेलिंग्स है. जब टॉक्सिक स्वेलिंग्स में आप पता है कि मुझे यहाँ से डिटरमाइन हो गया ना, जैसे ही मैंने इसका TFT करा है मुझे पता है कि ये तीनों स्वेलिंग्स जो मेरे पास हैं ऑल ऑफ देम आर ऑफ हाइपरथायराइड, क्योंकि सब में देख रहे हो आप T3 T4 तो एलिवेटेड है, जहां जहां T3 T4 एलिवेटेड होगा वो थायराइड टॉक्सिक स्वेलिंग हो जाएगा. अब स्वेलिंग टॉक्सिक है तो आई नो इट कैन नॉट बी मैलिग्नेंट, तो FNAC करने की जरूरत है ही नहीं. अब बारी है कि तीसरा इन्वेस्टिगेशन क्या करोगे. The third investigation that I'm going to do is going to be a radioactive iodine scan, and the isotope that I'm going to use is iodine 123. तो इन सब में I am going to do a radioactive iodine scan with iodine 123. तो इतना याद कर लेना कि डायग्नोसिस में हम हमेशा iodine 123 यूज करते हैं. आयोडीन 123 का हाफ लाइफ 13 आवर्स होता है. आई डोंट थिंक इट इज इंपॉर्टेंट, लेकिन अगर आपको इंप्रेस करना है इतना लिखना, टी हाफ ऑफ आयोडीन 123 इज गोइंग टू बी 13 आवर्स एंड इट इज गोइंग टू एमिट बीटा रेडिएशन, सॉरी इट इज गोइंग टू एमिट गामा रेडिएशन, इट इज गोइंग टू एमिट गामा रेडिएशन. आयोडीन 131 बीटा और गामा दोनों रेडिएट करता है, लेकिन आयोडीन 123 ओनली एमिट्स दी गामा रेडिएशन. ठीक है, इतना क्लियर है. अब रेडियो एक्टिव आयोडीन में आपको कैसे पता चलेगा कि यू आर लुकिंग एट ग्रेव्स डिजीज और यू आर लुकिंग एट योर प्लमर्स डिजीज और टॉक्सिक एडिनोमा. बड़ा सिंपल और प्यारा सा कॉन्सेप्ट है. ठीक है, जस्ट 2 मिनट में एक्सप्लेन कर दूंगा, यू विल बी एबल टू अंडरस्टैंड इट बेटर. मान के चलिए ये इस्थमस है, ये आपका लेफ्ट लोब है, ये आपका राइट लोब है. दिस इज द राइट लोब ऑफ द थायराइड ग्लैंड, दिस इज द लेफ्ट लोब ऑफ द थायराइड ग्लैंड. ठीक है, वी ऑल नो कि थायराइड ग्लैंड के अंदर यू हैव दीज फॉलिकल्स विच आर प्रेजेंट. अब आप जो आयोडीन दोगे वो फॉलिकल के अंदर ही जाएगा. अब जब आप जो आयोडीन दे रहे हो या आप रेडियो एक्टिव आयोडीन दे रहे हो, तो यू कैन मेजर द अपटेक ऑफ आयोडीन बाय लुकिंग एट अ रेडियो स्कैनर, जिसको आप गामा कैमरा बोलते हो. तो अब क्या करोगे कि ग्रेव्स डिजीज में हुआ क्या, ग्रेव्स डिजीज में ये जो लॉन्ग एक्टिंग थायराइड स्टिमुलेटिंग एंटीबॉडीज हैं वो आके थायराइड फॉलिकल को स्टिमुलेट कर रहे हैं. ठीक है, नाउ व्हाट इज गोइंग टू हैपन इज, नाउ एज देखो अ वेरी वेरी ब्यूटीफुल कॉन्सेप्ट है TSH के ना, दैट इज थायराइड स्टिमुलेटिंग हार्मोन के 2 फंक्शंस हैं. एक फंक्शन ये है कि इट स्टिमुलेट्स द थायराइड फॉलिकल्स टू रिलीज T3 T4. सेकंड, जब भी TSH एक्सेस में होता है ना, इट प्रमोट्स ग्रोथ. अब ये जो एंटीबॉडी बनी है ना, लॉन्ग एक्टिंग थायराइड स्टिमुलेटिंग एंटीबॉडी, इट मिमिक्स लाइक TSH, वो दिखने में TSH की तरह होती है. तो जब फॉलिकल्स के पास आपका एंटीबॉडी और TSH दोनों गए, तो फॉलिकल को तो पता ही नहीं है कि कौन सा एंटीबॉडी है कौन सा TSH है, तो एंटीबॉडी जाके फॉलिकल को बाइंड कर जाता है. अब फॉलिकल को तो लगता है कि यार ये तो अपना TSH है. अब ये तो वही होगी ना चोर चाबी ठीक है, यू हैव टू डुप्लीकेट की से भी ताला खुलेगा, ओरिजिनल की से भी खुलेगा। अब ये एंटीबॉडी आके अटैच कर गई, जब अटैच कर गई वो जाके फॉलिकल को बोली कि रिलीज कर, T3T4 रिलीज करते हैं, तो एक्सेसिव रिलीज और T3T4 हो रहा है। अब ये जो TSH पड़ा हुआ है वो क्या करेगा, अब TSH जब, अब देखो T3T4 रिलीज होता रहा है क्योंकि एंटीबॉडीज बाइंड कर रहे हैं और बॉडी को लग रहा है कि ऑब्वियसली देयर इज एन एक्सेसिव स्टिमुलस, और जो बचा हुआ सर्कुलेटिंग TSH होता है ऐसे ही पड़ा हुआ है, एंड दैट TSH बिकॉज देयर इज एक्सेसिव स्टिमुलेशन ऑफ द फॉलिकल्स। अब फॉलिकल को लग रहा है कि अगर ये बार बार एंटीबॉडी आके स्टिमुलेट कर रहा है ना, फॉलिकल को थोड़ा पता है एंटीबॉडी है, फॉलिकल को लग रहा है कि ये तो TSH है, और एक्सेसिव TSH, जब TSH बोलेगा, अब देखो जब तक इसके अंदर हार्मोन है निकलता रहेगा, जब हार्मोन खत्म हो गया उसके बाद अगर फॉलिकल को स्टिमुलेट करेगा ना, तो फॉलिकल को लगेगा ये TSH पागल हो गया, इसको लग रहा है कि ना ज्यादा चाहिए। अब ज्यादा चाहिए तो फॉलिकल बोलता है अरे मेरे को ज्यादा T3T4 बनाना, क्या करें, फॉलिकल विल स्टार्ट प्रोलिफरेटिंग, फॉलिकुलर सेल्स विल स्टार्ट टू इंक्रीज। अब जब फॉलिकुलर सेल्स इंक्रीज करेंगे तो साइज तो इंक्रीज करेगा ना भाई, जब साइज इंक्रीज करेगा दिस इज गोइंग टू एनलार्ज, अब ये हो जाएगा एनलार्ज लाइक दिस, इसीलिए इसको बोलते हैं डिफ्यूज टॉक्सिक गोइटर। डिफ्यूज मतलब पूरा ग्लैंड एनलार्ज हो गया, राइट। नाउ बिकॉज ऑफ दिस यू विल सी ऑल दिस फॉलिकल्स हैव प्रोलिफरेटेड। अब क्योंकि सारे फॉलिकल्स प्रोलिफरेट हुए इसलिए तो ग्लैंड एनलार्ज हुआ है, एंड दिस इज व्हाट वी कॉल इट एज डिफ्यूज टॉक्सिक गोइटर। नाउ दिस इज व्हाट वी कॉल इट एज द डिफ्यूज टॉक्सिक, दिस इज व्हाट वी कॉल इट एज डिफ्यूज टॉक्सिक गोइटर। नाउ जब आप रेडियो एक्टिव आयोडीन दोगे ना, रेडियो एक्टिव आयोडीन इज गोइंग टू गो एंड गेट इनटू दीज फॉलिकल्स। तो नॉर्मली में अगर आप में और मेरे में रेडियो एक्टिव आयोडीन दोगे तो उसका अपटेक कुछ ऐसा होगा, ठीक है। सो दिस इज द नॉर्मल अपटेक ऑफ अ रेडियो एक्टिव आयोडीन फॉर यू एंड मी अगर ग्लैंड नॉर्मल है। लेकिन अगर वही ग्रेव्स डिजीज में इनलार्ज होगा, यू कैन सी देयर इज अ लॉट ऑफ प्रोलिफरेशन, यू विल नाउ नोटिस कि ये पूरा जो ग्लैंड है ना, इट इज नाउ गोइंग टू हैव a lot of radioactive iodine is been uptaken। तो आप देखोगे ग्लैंड में ना रेडियोएक्टिव आयोडीन का अपटेक और इसका कॉन्सेंट्रेशन बढ़ जाएगा, और ये जब गामा कैमरा में देखोगे उसकी इमेज कुछ ऐसे नजर आएगी, दिस अ डिफ्यूज एक्सेसिव अपटेक। तो डिस्क्राइब करते हैं आपके रेडियोलॉजिस्ट बोलते हैं कि ये डिफ्यूज अपटेक है, देयर इज एन एक्सेसिव अपटेक एंड देयर इज अ यूनिफॉर्म अपटेक, देयर इज अ यूनिफॉर्म अपटेक। अगर ऐसा कोई अपटेक आपको मिल रहा है जहां पे नॉर्मल से ज्यादा है और पूरे ग्लैंड में यूनिफॉर्मली एक तरह से अपटेक हो रहा है, देयर इज अ यूनिफॉर्म अपटेक थ्रू आउट द ग्लैंड, एंड इफ यू सी देयर इज एन हाइपर अपटेक, देयर इज ओनली वन डायग्नोसिस दैट इट गोज इन फेवर ऑफ, दैट इज गोइंग टू बी योर डिफ्यूज टॉक्सिक गोइटर। और ये जो डिफ्यूज टॉक्सिक गोइटर है इट इज नथिंग बट योर ग्रेव्स डिजीज, एंड ऑफ डिस्कशन। तो अगर आप सिर्फ ऑरेंज ऑरेंज देखो और कुछ मत देखो, यहाँ पे इतना कम ऑरेंज दिख रहा है, यहाँ पे भर भर के ऑरेंज दिख रहा है, अब दैट एक्सेसिव ऑरेंज दैट इज दिस इज टू डिपेक्ट यू कि रेडियोएक्टिव आयोडीन कितना ज्यादा अपटेक हो गया। सो इतना हाई अपटेक देखने को मिलेगा ना, दिस इज गोइंग टू बी योर ग्रेव्स डिजीज। अब बारी आती है हमारे टॉक्सिक मल्टीनोडुलर गोइटर में। अगर पैथोफिजियोलॉजी देखोगे ना टॉक्सिक मल्टीनोडुलर गोइटर की, उसमें कुछ ऐसा होगा, ग्लैंड विल हैव अ नोडुलर सरफेस, ग्रेव्स में तो यूनिफॉर्म स्मूथ है। अब ये नोडुलर क्यों है, देयर आर फ्यू साइट्स which are going to have a fibrosed follicles। तो यहाँ पे कुछ sites of the gland is having this fibrosis and these are called as fibrosed follicles। और there are some follicles which are going to have excessive proliferation and this is what we call it, wherever there is an excessive proliferation there will be excessive growth, and that excessive growth is what is resulting in nodularity, that is where it will be present as nodularity। Now, because obviously all these nodules are because of excessive proliferation, so when you give radioactive iodine here, so you will see there's a lot of radioactive iodine has been uptaken here। लेकिन if you compare that with the Graves disease, तो फर्क क्या देखने को मिल रहा है, आप देखोगे Graves disease में पूरे ग्लैंड में यूनिफॉर्मली अपटेक है, लेकिन Plummers disease में कुछ जगह पे बहुत ज्यादा अपटेक है और कुछ जगह पे बिल्कुल अपटेक है ही नहीं, there's no uptake here, there's no uptake here, there's no uptake here, there's no uptake, so there's a patchy uptake, है ज्यादा, जहां पे भी अपटेक है वहां पे है ज्यादा, लेकिन जहां पे अपटेक नहीं बिल्कुल नहीं है। सो दिस पैची अपटेक विद एक्सेसिव अपटेक इन फ्यू एरियाज इज एन इंडिकेशन ऑफ टॉक्सिक मल्टीनोडुलर गोइटर। ठीक है, बात खत्म। फिर बारी आती है अपने टॉक्सिक एडिनोमा की, ये सबसे आसान है हमको याद रखने में। सो यू विल सी ये आपका थायराइड ग्लैंड हो गया एंड दिस इज द नोड्यूल दैट इज बीन फॉर्म, दिस इज द नोड्यूल दैट इज बीन फॉर्म। ठीक है, ये नोड्यूल है, ये आपके बाकी के फॉलिकल्स हैं। ठीक है, so when you look at the uptake in rest of the follicles, you will see there's a minimal uptake or a normal uptake that is there. In this area, you will see a lot of uptake. So if there is one uptake, in fact, sometimes the nodule becomes so active that it won't let anywhere else for the gland to have an active uptake, सिर्फ आपको ऐसे दिखेगा। जब आप गामा कैमरा में आप इसको विजुअलाइज करोगे ना, तो इमेजिन ओनली ऑरेंज ऑरेंज अपटेक, तो यहाँ पे डिफ्यूज सब में दिखेगा, यहाँ पे पैची दिखेगा, यहाँ पे सिर्फ एक साइड पे अपटेक दिखेगा। एंड दिस इज हाउ यू नो ऑन अ रेडियो एक्टिव आयोडीन दैट इट इज गोइंग टू हैव द फॉलोइंग डायग्नोसिस। एंड ऑल दीज अपटेक्स नो, इन सबको क्या बोलते हैं? इनको बोलते हैं हॉट अपटेक, गरम गरम। हॉट का मतलब होता है एक्सेसिव अपटेक, सो ऑल दीज अपटेक्स आर कॉल्ड एज हॉट। तो रेडियो एक्टिव आयोडीन में ना 3 टाइप के अपटेक्स होते हैं, हॉट, कोल्ड एंड वार्म। हॉट का मतलब नॉर्मल से ज्यादा, वार्म का मतलब नॉर्मल के बराबर, कोल्ड का मतलब नॉर्मल से कम। कोल्ड अपटेक और कोल्ड नॉडुलर अपटेक इंडिकेट्स मैलिग्नेंसी, मतलब वो डिटरमाइन करे कि वो प्रोबेबली कैंसर की तरफ है, एज सिंपल एज दैट। ठीक है, तो ये आपका इन्वेस्टिगेशन स्टेटस हो गया इन टर्म्स ऑफ थायरोटॉक्सिकोसिस। मैनेजमेंट इज गोइंग टू बी वेरी वेरी इंपॉर्टेंट। ठीक है, आई होप एवरीबडी इज एबल टू अंडरस्टैंड नो, मतलब मैं बोल तो रहा हूं, मुझे रिस्पॉन्स समझ में नहीं आ रहा। ठीक है, बीच में अगर कुछ समझ में नहीं आना बेटा पूछ लेना, मुझे तो लग रहा है कि समझ में आना चाहिए। इफ यू हैव एनी क्वेश्चंस, एनी क्वायरीज, यू कैन आस्क इन बिटवीन ओनली, बीच में ही पूछ लेना, बट इन जनरल बता रहा हूँ कि आई फील कि आई एम मेकिंग सम सेंस। ठीक है, सो मैनेजमेंट के बारे में बात कर लेते हैं। So when you talk about the management, so we talk about the management of all these toxicoses, so it's going to be a stage-wise management. So what is the first line management? देखो, first line management for all these patients is to start the patient on anti-thyroid drugs. सो सब में सर्जरी पहले नहीं करेंगे, सबसे पहले आप एंटी थायराइड ड्रग्स स्टार्ट करोगे। सो इन ऑल दीज पेशेंट्स यू विल स्टार्ट द पेशेंट ऑन एंटी थायराइड ड्रग्स, राइट? सो द फर्स्ट थिंग वी आर गोइंग टू डू इज गोइंग टू हैव एन एंटी थायराइड ड्रग्स। नाउ आई होप एवरीबडी नोज द लिस्ट ऑफ एंटी थायराइड ड्रग्स दैट यू कैन गिव। नाउ अगर आपको अपने एग्जामिनर को सुपर इम्प्रेस करना है तो एंटी थायराइड ड्रग्स कौन कौन से हैं? सो यू से दिस इज द थायराइड फॉलिकुलर सेल, ठीक है, देन यू हैव दिस इज द ब्लड सर्कुलेशन, एंड लेट्स से दिस इज वेयर यू हैव द पेरिफेरल कन्वर्शन दैट इज गोइंग टू हैपन, दैट इज गोइंग टू बी द लिवर। ठीक है, नाउ लेट्स से, एंड दिस इज सोडियम आयोडीन सिम्पोर्टर, this is sodium iodine importer which is going to bring these ions। अंदर आपके पास एक एंजाइम मिलेगा, एंजाइम को बोलते हैं थायरोपेरोक्सिस, दैट इज TPO। सो लेट्स से दिस इज अ सोडियम आयोडीन importer। सो देयर इज अ सोडियम आयोडीन importer, अंदर एंजाइम मिलेगा थायरोपेरोक्सिस। यहां से यू विल सी दी T3 T4 is secreting into circulation, peripheral T4 gets converted into T3, यही है। ठीक है, now anti-thyroid drugs में remember the important ones that are going to be asked in exam। सोडियम आयोडीन सिम्पोर्टर का जो ब्लॉकर है इसको आप बोलते हो परक्लोरेट, it is perchlorate as well as thiocyanate। So two drugs which are going to stop the sodium iodine importer is perchlorate and as well as thiocyanate। फिर the drug that is going to inhibit the thyroperoxidase enzyme। Now drug that is going to stop, drug that is, see this has been your repeat, I mean like whenever they talk about it there's going to very important, the one that inhibit the thyroperoxidase enzyme is going to be carbimazole। Drug that inhibit the thyroperoxidase enzyme is carbimazole and propyl thiouracil, and the propyl thiouracil, ठीक है, which was PT। Clear? Drug that is going to inhibit, drugs that are going to inhibit the peripheral secretion, मतलब ये blood में जाने नहीं दे रहा है, right? One that is going to inhibit the peripheral secretion is going to be sodium iodide, potassium iodide as well as Lugol's iodine। It is going to be Lugol's iodine, ठीक है। And the last one, drug that inhibit the peripheral conversion, drug that inhibit the peripheral conversion सारे P से हैं। Number one, it is going to be propyl thiouracil। Number two, a beta blocker, that is propranolol, non-selective है। it is propranolol. A steroid, that is going to be prednisolone. Right? Propyl thiouracil, propranolol, and prednisolone. These are going to be the drugs that inhibit the peripheral conversion. Right? So remember two important things. Safe in pregnancy. Which antithyroid drug is safe in pregnancy? That is going to be propyl thiouracil. Which antithyroid gland reduces the vascularity of the gland? Reduces the vascularity of the gland is going to be sodium iodide, potassium iodide, as well as Lugol's iodine. Okay. So obviously in Graves' disease, no, I want these antithyroid drugs to be used. So normally when you give the antithyroid drugs in Graves' disease, it's a combination of propyl thiouracil with Lugol's iodine. Okay. So these are your antithyroid drugs, right? So these are the antithyroid drugs that has to be given. And remember, once you start the antithyroid drug, before the surgery, you have to make the patient euthyroid prior to surgery. Make the patient euthyroid prior to surgery. This is the most important prerequisite that you have. Now, same is going to be validated for the rest of them. ठीक है? अच्छा, ये आपका first line management हो गया. Now, once the patient is euthyroid, the second line management is going to be surgery. It is going to be surgery. So, Graves' disease में the surgery that is currently recommended is going to be total thyroidectomy. This is going to be total thyroidectomy. अगर यहाँ पे unilateral, if it is in multinodular goiter Plummers disease में single side is involved, then it is going to be, for a unilateral condition, it is going to be lobectomy. For a bilateral condition, it is going to be total thyroidectomy. It is going to be total thyroidectomy. Right? Whereas here, when you talk about toxic adenoma, it is usually lobectomy. ठीक है? बड़ा आंसर हो गया ना? तो whenever they ask you thyrotoxicosis, usually it's a 10-mark question. Okay? So thyrotoxicosis, they'll ask you define thyrotoxicosis, give the examples of thyrotoxicosis, explain Graves' disease, explain Plummers disease, explain toxic adenoma. ये पूरा 10 marks का है. ठीक है? So if you are able to answer this is how you're supposed to answer. So start all the way with the basic definition of thyrotoxicosis, causes of thyrotoxicosis, clinical features of thyrotoxicosis, presentation, extrathyroid manifestation, systems involved, investigation, as well as management. Clear है? ठीक है? कोई सवाल, कोई शक? Anything? ठीक है? So we have completed the entire thyroid swelling वाला part. ठीक है? Toxicosis भी हो गया, इसमें goiter भी complete कर लिया. ठीक है? Now another question that you have is about retrosternal goiter. ठीक है? तो let's understand what is this retrosternal goiter. तो retrosternal goiter 5 marks का question है, छोटा सा आंसर होगा, quickly देख लेते हैं. ठीक है? So we're talking about the next question, that is going to be your retrosternal goiter. So let's understand retrosternal goiter. Now, by definition, what is retrosternal goiter? Now, by definition itself, retrosternal goiter is defined as, we call it as retrosternal goiter. RSG is defined as, it is defined as more than 50% of the thyroid gland, is below the neck level. if more than 50% of the thyroid gland is below the neck level, this is what we call it as retrosternal goiter, right? Now, when you talk about the retrosternal goiter, what are the types of the retrosternal goiter? So the second thing that immediately you should resort to is the types of the retrosternal goiter. Now we divide them into two categories, that is a primary retrosternal goiter and a secondary retrosternal goiter. So दो varieties हैं. One we call it as the primary retrosternal goiter. Another one is what we call it as the secondary retrosternal goiter. So we have the primary retrosternal goiter and a secondary retrosternal goiter. Now, what do you mean by a primary retrosternal goiter and what do you mean by a secondary retrosternal goiter? Primary का मतलब क्या होता है, secondary का मतलब क्या होता है? Now, a primary retrosternal goiter, it is a retrosternal goiter. It is a retrosternal goiter arising from ectopic thyroid gland. Arising from an ectopic thyroid gland situated in retrosternal space. So an ectopic thyroid gland which is present in the retrosternal space, and from there if the goiter arises, it is called as a primary retrosternal goiter. Secondary is what is more common. You will see that it is a normal cervical thyroid gland enlarging to descend into retrosternal space, to descend into retrosternal space, occupying, or I can say a normal cervical thyroid enlarging to descend into retrosternal space where more than 50% of thyroid swelling, is below the neck level. It is below the neck level, and this is what we call it as a secondary retrosternal goiter. So the definition between a primary and a secondary retrosternal goiters are going to be important. So in a primary retrosternal goiter, these are the two different types, that is the primary and the secondary, that you have to remember. See? Now, the other varieties also in terms of their presentation, it's like one we call it as the plunging goiter and all that. We don't need to worry about it. Just remember the primary and the secondary retrosternal goiters which are present. Now, how does a patient of retrosternal goiter is going to present to you? So clinical features. So clinical features associated with retrosternal goiter, right? Now, what are you have to write it? I'm just going to tell you, but just for the sake of understanding, if you take this as a representation of the neck, this is the suprasternal notch, this happens to be sternum, and this continues into Ziphy sternum, right? When you talk about the retrosternal goiter, we're talking about this, the thyroid gland, and which is going to enlarge and then descend below the sternal space, and more than 50% of the thyroid gland is now going to be present below this. There's more than 50%. There's more than 50% of the thyroid gland is present below the level of neck. It is going to present below the level of neck. Now, what is the presenting findings that you're going to see? Now, usually in a retrosternal goiter, the usual age of presentation is same as any goiter, that is between 30 to 40 years. Again, it is more common in females when compared to male. It is more common in females when compared to males, right? So when they talk about the features, they'll present to you as a midline neck swelling. They present as midline neck swelling extending below the neck level. Extending below neck level. That is the first clinical finding that you'll see. So there's a midline neck swelling that is going to extend below the neck level, right? Now this again is usually going to be painless. This is going to be painless, and same as goiter, it is going to be gradually increasing in size. You will see that it is going to be gradually increasing in size, right? It is going to be gradually increasing in size. Clear? Chalo. Now, obviously I would like to examine it. So on examination, the first thing you will see, this is going to move upwards with deglutination. This is going to move upwards with deglutination. This is going to move upwards with deglutination. That is going to happen. Now, as it is going to move upwards with deglutination, what is the other thing that you will see? Remember, even it is moving with upward with deglutination, the lower border of thyroid is not visible. Not only visible, it is not palpable as well. It is not visible. At the same time, it is not palpable as well, right? So it moves upwards with deglutination. The lower border is neither visible nor palpable, right? Now, when you examine it, because the gland is enlarging, it is going to suppress or compress the thoracic inlet also, right? So all these head and neck veins, they drain into your thoracic cavity, so all these are going to get blocked. So there will be presence of distended. There is distended neck and chest veins. There distended neck and chest veins are going to be present. Now, another very interesting thing, there is something called as Pemberton sign positive. Now, what is this Pemberton sign positive? Now, you ask the patient to raise both the hands above the level of head. Now, as you raise both the hands above the level of head, what is going to happen? You are now further compressing this thoracic inlet. Now, as the thoracic inlet is getting compressed more, obviously, what is going to happen? The veins are going to go occlude more. If the veins are going to get occluded, all the blood that is flowing from the face will not be able to go. It starts pooling in the face. If the blood starts pooling in the face, there will be presence of congestion. So, what is Pemberton sign positive? Is presence of facial congestion. There's presence of facial congestion on elevating both the arms, above the level of head. It is the presence of facial congestion on elevating both the arms above the level of head is what we call it as Pemberton sign positive. And the last clinical feature that you will see. What is the last clinical feature? When you do percussion in thorax, you should have a resonant node. But now because the gland is occupying on the surface wherever the gland is present, it will have dull node. So presence of a dull node on percussion. It is dull node on percussion is formed. There is dull node of percussion is formed, that is on it. So on examination, it moves upwards. There's a lower border is neither visible nor palpable, distended in neck and the chest vein, Pemberton sign positive, and there's a dull node that is present. Now, when you talk about what are the investigations that you're supposed to do, in the investigation, I would number 1, get a thyroid function test. Number 2, get an ultrasound of the neck done. Next, you should always get a radioactive iodine scan done to know the extent, and obviously to know within the thorax, also get the CECT of neck and thorax. So when you get a CECT of the neck and thorax, you will be able to know the true extent of the thyroid swelling, which has gone into the intrathoracic space. So you know the thyroid function test, the ultrasound is done, the radioactive iodine and the CECT is done, right? Now, once you have concluded it, the management is going to be surgery, and here it is going to be total thyroidectomy. Remember, whenever you are taking any patient for total thyroidectomy, you remove the entire thyroid gland. So thyroid is going to be giving you a thyroid hormone. But if the gland is gone, how would you complement it? Now, for supplementation, here you have to also mention, whenever you write a total thyroidectomy, write lifelong thyroxine. Now, this thyroxine is basically a T4 supplement. So, total thyroidectomy with lifelong thyroxine is what is required. It is what is required for both. So total thyroidectomy with lifelong thyroxine is going to be the treatment for your retrosternal goitis, right? So this concludes our entire discussion on our thyroid gland, right? So discuss solid thyroid nodule, thyrotoxicosis, goiter as well as retrosternal goiter. ठीक है? Clear? इतना लिखो is more than enough. ठीक है? So far any questions in thyroid bias? Quick feedback. कोई सवाल, कोई शक? Clear है? Can we move on? चलो. So we're talking about the questions which are present in breast. So in the previous exam, what are the questions which are asked in breast? I'll just quickly mark it down. तो breast में हमसे पूछा हुआ है एंडी के बारे में. Write a short note on एंडी. We have a question on phylloids tumor. We have a question on fibroadenoma of the breast. Or the fibroadenoma of the breast. एंडी पे सवाल है, फाइलॉइड्स ट्यूमर पे है, एंड द फाइब्रोएडेनोमा ऑफ द ब्रेस्ट. There are 3 questions that are present. Sir, about the parathyroid gland. So exams on the April 7th, and this is helping a lot. Thanks to the entire team. Great, thank you. I mean, like, it's so satisfying to hear that, you know, the effort that we're putting in is actually making a little bit of difference in your preparation as well. After the thyroidectomy, parathyroid glands are also to be resected. No, beta. Whenever you're doing a thyroidectomy, parathyroid gland should always be preserved. Parathyroid gland तभी निकालोगे जब उसमें डिफेक्ट है. Otherwise, thyroidectomy करते वक्त I will dissect the parathyroid gland away from the thyroid gland and extract the thyroid gland. Parathyroid gland को कभी नहीं निकालना है. In fact, अगर गलती से निकल जाता है, accidental removal of parathyroid gland during a thyroid surgery must be reimplanted on the sternocleidomastoid muscle of the same side. अगर लेफ्ट पैराथायरॉइड निकला है तो लेफ्ट sternocleidomastoid muscle पे रीइम्प्लांट करोगे. ठीक है? सो डोंट फॉरगेट अबाउट इट. नहीं निकालना बेटा, पैराथायरॉइड क्यों निकालोगे? ठीक है. आफ्टर, अच्छा ये वी हैव ऑलरेडी आंसर्ड. व्हाट अबाउट द पैराथायरॉइड ग्लैंड? बेटा पैराथायरॉइड पे ना देयर इज वन क्वेश्चन ऑन हाइपरपैराथायरॉइडिज्म, बट दैट इज डेल्ट इन मेडिसिन. ना तो सर्जरी में तो मुझे कोई प्रीवियस क्वेश्चन पेपर में पैराथायरॉइड पे कोई सवाल नहीं मिला. ठीक है, चलो. कैन वी मूव ऑन टू द ब्रेस्ट? क्विक फीडबैक. आई होप एवरीबॉडी इज क्लियर ऑन दिस. क्विक फीडबैक. चलें? कैन वी मूव ऑन? कैन वी मूव ऑन? चलो. सो पहला है हमारा एंडी पे सवाल है. ठीक है. सो टॉक अबाउट व्हाट इज एन एंडी. So all these questions that you have, Andy has been your 3 marks question, phylloids has been your 5 marks question, fibroadenoma is a 3 marks question. तो usually breast से आपका छोटा छोटा टॉपिक्स ही आता है. ठीक है. सो एंडी का हम पहले देख लेते हैं. So the first one, the first answer that we are going to discuss about is going to be Andy. ठीक है. Andy का मतलब क्या? Andy stands for aberration. Andy stands for aberration in normal development, and involution of breast. It is a normal development and involution of breast. This is the definition or the full form of Andy. So whenever we talk about Andy per se, no, तो Andy के 2 classification है. एक clinical classification of Andy है, another one is what we call it as the histopathological classification of Andy. So the Andy can be classified into 2 variants. One, we have a clinical classification, another one is based upon the histopathology, right? So we'll be talking about both. We'll talk about the clinical classification of Andy. We have the clinical classification of the Andy and the histopathology. and we have the histopathology of the ANDI. So we have the clinical classification as well as the histopathology of the ANDI that is present. Okay? Achha. So in the clinical classification, what are we going to look at it? So in the clinical classification, the entire ANDI is classified based upon the age of presentation. So you have the age group and the disorders it is going to be associated with. So we have an age-wise disorder that is going to be present. So on one hand, you have the age group, and the other hand, you are going to have disorder. Okay? Now, what are these age groups and disorder? Now, whenever a breast disorder starts, it will only start once a patient has developed a breast. That is going to be thalarche. The normal age of thalarche is going to be 9 to 11 years old. So जो भी disorders होंगे वो 11 के बाद ही होंगे क्योंकि 11 से पहले तो breast है ही नहीं. अगर breast नहीं है तो disorders कहाँ से होंगे? Simple सा concept है. ठीक है? Now, could you please repeat? Okay, हम बात कर रहे हैं एंडी के बारे में. एंडी फुल फॉर्म स्टैंड्स फॉर एबरेशन इन नॉर्मल डेवलपमेंट एंड इवोल्यूशन ऑफ ब्रेस्ट. Aberration means which is not normal or which is going to be abnormal growth that is going to be present in the breast. I'm going to divide the two classifications of ANDI. One is called as a clinical classification, another one is called as a histopathological classification. Clinical it is divided on the basis of age group, and based on that age group we have disorder. As we all know that every single disorder of the breast will only be seen once the breast develops, or the normal age of development of the breast is what we call as thalarche, that is going to be 9 to 11 years. तो 11 साल से पहले तो breast है ही नहीं. अगर breast नहीं है तो disorder कहाँ से होगा? तो आपको disorder मिलेगा 11 के बाद. ठीक है? That means the usual age of presentation, the first subset that you will see is age group between 15 to 25 years. So age group between 15 to 25 years के बीच में ना, you will get disorders like fibroadenoma of the breast. Get the fibroadenoma of the breast. There will be presence of fibrocystic disease of the breast. Fibrocystic disease of the breast. Then you have breast cyst. So usually it is an uncomplicated. Okay? So that is between 15 to 25 years. Second set of age group is going to be 25 to 40 years. Or 25 to 40 years के बीच में you will get disorders like again same as fibrocystic disease. It is going to be the fibrocystic disease of the breast, fibroadenoma of the breast, fibroadenoma of the breast. You have the breast cyst, but there's one disorder which is going to be very important for us to remember. It is going to be the phylloid tumor. There's going to be phylloid tumor, that is 25 to 40. Now then you have age above 40 years. So in age above 40 years, the conditions that you will see is going to be the fibrocystic disease. It is going to be the fibrocystic disease and condition like duct ectasia. Condition like duct ectasia as well as duct papilloma. So these are disease, the disorder in association with that of its age of presentation that you're going to see. Okay? So if I just simply classify them, this is the first subset that you should know. Right. So this is in respect to that of the ANDI's first classification. Based upon the histopathology, the ANDI is divided into the following components. So you have hyperplastic disorder, that is because of hyperplasia. It is because of the fibrous component. It is because of the fibrous component. It is a cystic form of ANDI. It is papillomatosis. that is a papillary growth factor, and glandular component, that is a adenoma. So based upon the histology, the AND is divided into hyperplasia, fibrous, cystic, papillary, as well as adenomatous growth pattern. Okay. So these are the component of AND. Okay. So this is going to be a short note when it comes on AND. This is what you have to describe, that AND has classified the breast disorders into clinical as well as histopathological. Clinically, these are the disorders that are going to be oriented, and on a histopathology, this is what you're supposed to remember. Okay. So the first topic about a short note on AND is what you have to write. Second is going to be your fibroadenoma and phylloid tumor. So we'll quickly go through the fibroadenoma and then I'll run to the phylloid tumor. Okay. So the question number 2 is going to be on fibroadenoma. It is the fibroadenoma of breast. Now when it talks about the fibroadenoma of the breast, so fibroadenoma of the breast itself is saying it consists of two different components. It consists of two different components. That is going to be the fibrous component as well as adeno is glandular component. It is going to be a fibrous as well as a glandular component. So this is basically an example of a mixed tumor. This is going to be an example of a mixed tumor, right? Now, at what age do you see this? The usual age of fibroadenoma, we just learned, it is seen between 15 to 25 years. Now, what is the site of origin? So, what is the site of origin for the fibroadenoma of the breast? Now, for that, a quick recap on how does a breast basically looks at. This is the representation of the breast. You can see that this is the pectoralis fascia. This is the representation of the nipple. And when you look at the TDLE unit, this is going to be your terminal duct. This is going to be the ampulla. This is the major lactociferous duct. These are the minor or the branch lactociferous duct. This is going to be the lobule of the breast. This is going to be the lobule of the breast. Within the lobules, you have the glandular component, that is the alveoli of the breast. So the alveoli are present within the breast tissue, right? Now, a quick labeling so that you have the sound sense of it. This last portion is what we call it as the terminal duct. This is what we call it as the ampulla of the breast. This is what we call it as the major lactociferous duct. This is what we call it as the major lactociferous duct. These are what we call it as the minor, or also called as the branched lactociferous duct. Minor or the branched lactociferous duct. This is what we call it as the lobule of the breast. This is what we call it as the alveoli of the breast. And all these put together is what we call it as the lobe of the breast. Is what we call as the lobe of the breast, right? Right. Now, when you look at the fibroadenoma, it has two things. It has got the fibrous capsule, and because it is going to arise from the gland, it is going to have a glandular tumor, right? So the word fibro means fibrous, adeno means glandular, oma means tumor. So word fibro means it has got a fibrous component. Adeno means, the word adeno means glandular component, and the word oma stands for tumor. So this is going to be a benign tumor which is going to be involving the fibrous and the glandular component. Hence, it is called as a mixed tumor. Okay. Now, when you talk about the origin, it is going to origin. So you'll see the fibroadenoma of the breast. It is going to arise from the lobule of the breast, right? So the fibroadenoma is going to arise. So just I'm going to tell you, this is where the fibroadenoma of the breast is going to be present. This is where you will see there will be fibroadenoma of the breast, right? So the fibroadenoma of the breast is going to arise from the lobules of the breast. This is going to arise from the lobules of the breast, right? Now, how would this present to you as a clinical feature? So what are the clinical features? The clinical features of a breast lump. The clinical features of a breast lump, number one, you will see this is going to patient is going to present to you as lump in breast. Now this lump in breast, it is going to be incidentally found. So it's an incidentally found breast. So this is incidentally found. This remains painless. This remains painless. It is going to be gradually increasing in size. This is going to be gradually increasing in size. So normally when you say size, it is usually 2 to 3 centimeters. You do not have fibroadenoma more than 3, right? Okay. So it is going to be 2 to 3 centimeters. This lump in the breast, it is going to present as a painless lump and is going to gradually increase in size, nothing more than that. You would like to examine it. So on examination, what are the findings that you will see in the fibroadenoma of the breast? First one, you will say it is going to have a smooth surface. Second, when you palpate it, it feels like a tip of the nose, that it is going to be firm in consistency. This is going to be firm in consistency. And last, it is going to be hypermobile. Now, why call it as hypermobile? Because in order to palpate it, you want to fix the swelling. Now, every time you try to fix the swelling, it slips away. Now, as it slips away, it is called as hypermobile. And because it is hypermobile, this is also referred to as the breast mouse. This is given a nickname, and the nickname of this is what we call it as breast mouse, right? Now, how would you like to evaluate it? Now, in terms of investigation for fibroadenoma, for any breast lump, remember the investigation for any breast lump should follow a protocol. That is what we call it as the triple assessment. So in the triple assessment, what are we trying to do? So in the triple assessment, number one is going to be clinical examination. Number two, it is going to be your radiological assessment. Now, according to the radiological assessment, here I would like to do an ultrasound, right? Remember, any female age less than 40 years, ultrasound becomes the first investigation. More than 40 years, it is going to be mammography, right? Third investigation, or the third in triple assessment, is going to be the cytology. So in cytology, I would like to do an FNAC of the lesion, right? So when you do an ultrasound and you do an FNAC, now we have a confirmation that it is the fibroadenoma of the breast. Now remember, on an ultrasound, if the size of the fibroadenoma is more than 5 centimeters, this is what we call it as the giant fibroadenoma. This is what we call it as a giant fibroadenoma, right? Now, once you've diagnosed it as the fibroadenoma of the breast, what is the current management? Now, the current management, please do not write directly as surgery. You will say based upon the size, right? So, the management of the fibroadenoma of the breast, depends upon if it is less than 5 centimeters in size or is it more than 5 centimeters in size. If it is less than 5 centimeters in size, we will see whether on FNAC, if there is any atypia, that is any atypical finding on FNAC, no atypia, there is presence of atypia. If there is no atypia less than 5 centimeters, then you can go ahead with observation. More than 5 centimeters presence of atypia, you have to go with surgery, and the surgery here is going to be enucleation. Now, what is an enucleation is you open the capsule, you remove the tumor, you close the capsule, right? Remember, fibroadenoma is an encapsulated. So I can say fibroadenoma is an encapsulated lesion. If it is more than 5 centimeters, directly take the patient for enucleation, right? So size more than 5 centimeters, I'm directly going to take the patient for enucleation. Less than 5 centimeters, no atypia, observation. Less than 5 centimeters with atypia, do with surgery. That is going to be enucleation. That is how you're going to manage for fibroadenoma of the breast, right? So there's a short note on the fibroadenoma, and all these points that we have discussed is what you have to write. So far, any doubts, any questions, quick feedback? किसी को कोई सवाल, कोई शक, कोई कुछ पूछना चाहता है? Quick feedback. Clear? Can you move on? ठीक है, चलो, great. So the last topic that is going to be associated with breast is going to be phylloid tumor. So talk about the answer associated with the phylloid tumor. Now, phylloid tumor was initially known as cystosarcoma phylloids. It's also called as the cystosarcoma phylloids, or also called as the serocystic disease of Brodie's. Also defined as the serocystic disease of Brodie's. So either you call it as a phylloid tumor, or you call it as the serocystic disease of the Brodie's, or the cystosarcoma phylloids. Everything is basically the same. Now, what is there to understand is phylloids is predominantly a benign tumor, right? Now, because it is predominantly a benign tumor, giving it a malignant name is not justifiable. So hence the word sarcoma is not dropped. Okay, so now we don't use the word sarcoma. Now it is an old one. Atypia is a histopathological finding where you have atypical cells. They are not normal, but they are not malignant as well. There's some deformity or destructure that is present, but does not have any significance per se. And that is what we call as atypia. Few atypias point towards malignancies, and few of them point towards benign nature. So whenever you have atypia, that means you're doubtful. It is not normal, right? And that atypia always warrant any precaution, and that precaution is going to be surgery only. Okay? So in phylloid tumor, it is going to be a cystosarcoma phylloids. It is dropped the word sarcoma. Now it is also called as the serocystic disease of Brodie's per se, right? Now, so how does the patient of phylloid tumor is going to present to you? Now, when you talk about phylloid tumor in terms of characteristic feature, so we talk about the characteristic features of the phylloid tumor. Number one, it is a mixed tumor. That means it has got two different elements. Now, what are these made up of? It is made up of both epithelial as well as mesenchymal tissue. So it is going to be consistent of both epithelial as well as mesenchymal tissue. So hence is an example of mixed tumor. It is a rapidly increasing tumor. It is a rapidly increasing in size, right? This usually rapidly increases in size. It's an example of a mixed tumor. It is rapidly increasing in size, and it is going to take its origin. It is going to be involving from the duct as well as lobe. So it is going to have a mixed origin as well. Okay. Now, how does a patient of phylloid tumor present to us? The clinical presentation. So we'll talk about the clinical features. So we'll talk about the clinical features. The first one is the age of presentation. We just learned the age of presentation of phylloid tumor is going to be between 25 to 40 years. It is going to be 25 to 40 years. Now, age in breast disorders is very, very important. Now, how the patient present to you? The typical presentation, the patient will present to you as lump in breast. Now, this lump in breast is going to be rapidly increasing in size. This is going to be rapidly increasing This is going to be rapidly increasing in size. It remains painless. It remains painless. So lump in breast, rapidly increasing size and remains painless is the initial presentation that you will see in the phyllodes tumor. But I would like to examine it. So on examination, now this is where important findings will be there. So on examination, what do you find? So on examination, you will notice in the phyllodes tumor, usually the nipple is deviated away from the lump. Here nipple is deviated. It is deviated away from lump. It is deviated away from the lump. It is going to have a nodular, because it is going to multiple cysts are going to develop. And what happens in the phyllodes tumor? No, the small fibroadenoma like lesions, no, they obstruct the the duct itself, causing an accumulation of fluid also. So it is going to have both solid and the cystic component. Now because it is solid and cystic component, it is going to have variable consistency. Because it has got both solid and cystic component. It has got both solid as well as cystic component. So nipple is deviated away from the lump. It has got variable consistency. Nodular surface is what we call as bossulated surface. Now what is a bossulated surface is? In a bossulated surface you will notice. So normally this is how the breast contour would look like, and this is the nipple. In a bossulated surface, you will see the breast surface is going to become like this. The multiple nodules are formed, and that multinodular status is what we call as bossulated surface. So you have the nipple deviated away from the lump. It has got variable consistency. It is going to have a bossulated surface. It is going to have a bossulated surface. Now, as it enlarges more, it is going to compress the veins on the skin as well. So you will be presented with superficial dilated veins. There will be the presence of superficial dilated veins. Now, as it continues to enlarge, as the gland, because it is going to be the tumor or the lesion is going to enlarge rapidly, now it is going to exert pressure on the skin, and that is going to result in ulceration. So there will be presence of skin ulceration. The presence of skin ulceration. Now this skin ulceration, the skin ulceration is secondary to pressure-induced necrosis. It will be secondary to pressure-induced necrosis. So these are the examination findings that you have on a phyllodes tumor. Now, how would you like to investigate? So the investigation that we are going to follow on a phyllodes tumor. The investigation is in the same sense of protocol that we have followed the triple assessment. The first one is going to be the clinical examination, which we have already discussed all the findings of. Now, along with the clinical examination, now I have to do a radiology. Now, in the radiograph, I would like to do an ultrasound because the age is less than 40 years. Now, after radiology, then we will go ahead with cytology. Now, cytology here, it is going to be true cut biopsy. So, when you do a true cut biopsy on a histopathology, on the histopathology, you will see presence of leaf-like arrangement. There is this leaf-like arrangement of tumor cells. There is this leaf-like arrangement of tumor cells. Now, because there is leaf-like arrangement of tumor cells, the name phyllodes, the word phylloid is leaf, is arised from this, that is leaf-like arrangement of the tumor cells, and that is what you see in true cut biopsy. Now, how would you like to manage? So, what is the management? The management of the phyllodes tumor purely depends upon the histopathological finding, that is on the HP result. So what you do is, it depends on a HP, we'll see the mitosis count, right? So the management depends upon whether it is benign, borderline, or it is malignant. So based upon the HP, I'm going to look at the mitosis. So when you look at the mitosis count, I can differentiate them into the following varieties. When you look at the mitosis counts, you'll have less than 4 mitosis for 10 high power field. Then you have between 4 to 9 mitosis for 10 high power field. And the last one is going to be more than or equal to 10 mitosis for high power field. Now, why this is important is, if you have a mitosis which is less than 4, it is benign. If it is between 4 to 9, it is borderline. If it is more than 10, then it is a malignant phyllodes. That is a malignant phyllodes. Now, if it is a benign or a borderline phyllodes, here we will do a wide local excision. Here we do a wide local excision with 2 centimeter margin. With 2 centimeter margin. If it is a malignant one, remember when you're doing a breast conservative surgery, the margin is 1 centimeter, but phylloids, the margin safely is put to be as 2 centimeters. Now, if it is a malignant phylloids, you will go ahead and perform simple mastectomy. You'll do a simple mastectomy, and remember here, lymph nodes or lymph node dissection is not done. Lymph node dissection is not done due to so lymph node dissection is not done. Why it is not done is because usually in phylloid tumor lymph nodes are spared. So reason why it is not done in phylloid tumor, lymph nodes are usually spared. Because the lymph nodes are usually spared, right? So hence we are not going to do a radical or a modified radical mastectomy. We'll stick to simple mastectomy, right? So this is with respect to phylloid tumor, right? So these are all your important questions that is asked in your exam. So we covered anti-phylloids as well as fibroadenoma of the breast. So क्या questions थे which were asked from esophagus? So esophagus के chapter में जो सवाल आए थे, the question that they were asked was, number one, they've asked you about the tracheoesophageal fistula. They've asked you about the tracheoesophageal fistula. They've asked you about the GERD. They've asked you about Barrett's esophagus. They've asked you about the Barrett's esophagus. They've asked you about the esophageal varices. They've asked you about tips. They've asked you about the causes and the management of upper GI bleed. Upper GI bleed and management. So these are the important questions. Good evening, guys. So what they have asked you is about the tracheoesophageal fistula, GERD, Barrett's esophagus, esophageal varices, that is TIPS, that is a transnuclear intrahepatic porto-systemic shunt, upper GI bleed and its management. These were the questions that they have asked you in the exam. The tracheoesophageal fistula and its component that were asked. This was for 10 marks question. GRD was asked for 5 marks, Barrett's was asked for 5 marks, esophageal varices was 10 marks, TIPS was 5 marks, upper GI bleed and management was for 10 marks, right? So this is how the distribution went across. So we'll try to analyze each one of these questions, how to write it. We know the performer. देखो GIT में अगर आपने डायग्राम नहीं बनाया, इसका मतलब है कि आपने GIT अच्छे से नहीं पढ़ी है. As simple as that. Right. So the first one that we're going to talk about is going to be your tracheoesophageal fistula. तो पहला आंसर शुरू करते हैं. Just give me a second. Okay. So the first answer that we're going to talk about, it is going to be about the tracheoesophageal fistula. So we'll talk about all the important manifestations of the TOF that you have. This is not tetralogy of Fallet. This is going to be the tracheoesophageal fistula. Just give me a second, guys. Small issue with my pen. एक second. Okay. So TF stands for tracheoesophageal fistula. Right. Now, when we talk about the tracheoesophageal fistula, as we said, always start with the definition, then you talk about the pathophysiology, then the clinical presentation, all that. So, यहाँ पे दो definition आपको बताने होंगे. Number one, what is a fistula? So, define fistula. And then you also have to define something called as atresia, right? Now, fistula is defined as an abnormal communication. It is an abnormal communication between two lumens. Between two lumens, or a lumen and a cavity, or a lumen and a cavity is what we call it as the fistula. Now, what is an atresia? Atresia is defined as incomplete. It is defined as incomplete or improper channelization between two ends of a bowel. Between two ends of the bowel loop, right? So first of all, what is the definition? Fistula is an abnormal communication between two lumens and a lumen and a cavity. Atresia is an incomplete or improper channelization between two lumens, that is two end of the bowel loops. That's it. Okay. Now, this is your definitions about the fistula as well as atresia. Next, you have to write what is the pathophysiology. What is the pathophysiology? What is the pathophysiology of tracheoesophageal fistula? Now, a quick recap of the pathophysiology is, remember, the esophagus is developed from the foregut. So you can simply draw a small diagram saying that this is the representation of a primitive foregut. Now, from the foregut, as it continues to develop, you will see there's a development of a septa, and this septation will divide the foregut into two lumens. There is an anterior channel and there is a posterior channel. Now, this is the anterior channel of the foregut and this is the posterior channel of the foregut. And between these two, there is this septa that is formed. Usually, this septa is going to differentiate. This is the common channel, that is going to be the cricopharyngeal region. And from here, you will see that it is going to branch out into trachea. And posteriorly, it is going to continue into esophagus and then into the stomach. As we all know, the foregut is going to derive, or it is going to, the foregut develops all the way to the second part of the duodenum, including the esophagus as well as stomach. It continues to happen. So, and this is going to branch out into your respiratory bud, trachea and all that, right? So this is the division. The anterior division is going to develop into the respiratory. So this anterior division, this is also called as the respiratory bud. The anterior division is also what we call it as the respiratory. This is what we call it as the respiratory bud. The posterior one is what we call it as the esophageal bud. It is the esophageal bud, right? So this is the normal development of the respiratory bud and the component here. So the one that is present on the anterior, this is going to become the tracheal tree, that is tracheobronchial tree. This is going to be your tracheobronchial tree, and this happens to be the esophagus. This is going to be esophagus. So what is the pathophysiology? The pathophysiology comes down to this septa, right? So why does a tracheoesophageal fistula develop? So it develops due to incomplete. It is going to happen due to incomplete. It is due to an incomplete or improper septation. So this is because of incomplete or improper septation that is going to result in the development of tracheoesophageal fistula, right? Now, once you now know the different types of the tracheoesophageal fistula, you have to quickly write the types of tracheoesophageal fistula, right? So in the alphabetical order, you have type A variety, you have the type B variety, you have the type C variety, you have the type D variety. Now, in that context, and you have the H variety. Now, what do you mean by all these varieties that you have? Now, in a type A variety, you would notice that the trachea is going to be absolutely fine. There is no problem with the trachea. So trachea branches out exactly as it is anticipated. There is no problem to the trachea per se. Now the problem exists, that is going to be in the esophagus. You see, the esophagus fails to channelize. So there is the atresia between the two lumens of the esophagus, and the type A variety is what we call it as the pure atresial form, where there is only atresia. In type B variety, you will see the trachea is going to be absolutely fine, and it is going to branch out into the right and the left main bronchus. That we all know, these are the tracheal rings which are going to be present. So what is here? Now the first thing you would notice that the atresial segment of the esophagus is attached to this end, and the lower end remains in this way. So here there are two problems. One, the esophagus fails to channelize. Now as the esophagus is failing to channelize, what is that? There is atresia, and then you see the esophagus is communicating with the trachea, that is fistula. So here there is both fistula as well as atresia is present. In type C variety, you will see again everything remains the same. The trachea is at position in its own status. Right main bronchus, left main bronchus division is fine. These are all your tracheal rings which are organized in this form, and then you see esophagus is having atresia, but this time the fistula is formed. This time the fistula is formed from the lower end. This time the fistula is going to be formed from the lower end, and this is your type C variety. So in type A variety, there is only atresia. Type B variety, upper fistula. Type C variety, there is lower fistula, but the atresia is still maintained. In type D variety, it is going to have both upper as well as lower. The trachea is fine. There is no problem with the trachea per se. The division is also fine. These are your tracheal rings which are going to be aligned here. All these are fine. This, you see, there is an atresia which is formed here, and there is an atresia which is formed here as well. And this continues into stomach. Nobody is going to stop it. And then the atresia, right? So there is an atresia. There are two fistulas, both upper and the lower communicating fistula. This is your type D variety. Next comes is our H variety. Now in the H variety, you would notice that this is going to be the trachea that is present. Trachea is absolutely fine. There is no issue with the trachea. It continues to branch out into the left and the right main bronchus. This time, for my surprise, the esophagus is also fine. There is no issue, but you will see there is a small communication between these two. It channelizes, and then this is your stomach, right? So in the H variety, if you notice, there is no atresia, there is only fistula. So H variety is a pure fistula type. It is going to be a pure fistula type, right? What are the role of these varieties? When you have a different component, the presentation is going to vary, right? But you should know these are the possibilities that you have. Now, when you talk about it, remember the type A variety is what we call it as there's only esophageal atresia. There is only esophageal atresia. अगर आप पूछ रहे हो कि इन वैराइटीज का क्या यूज है, अभी आपको क्लिनिकल फीचर्स बताएंगे, तब आपको एकदम क्लियर हो जाएगा कि भाई वैराइटीज का क्या यूज है. Type B variety, this is the upper esophageal segment, this is the lower esophageal segment. So here there is presence of esophageal atresia. This presence of esophageal atresia with upper esophageal segment fistula. So it is the upper esophagus that is participating in the fistula development. That is a type B variety. Type C में क्या है? Type C में भी same है. You can see the upper esophageal segment is fine. This is the lower esophageal segment which is having a fistulary communication, and there is atresia, right? Atresia is no communication. So here also there is presence of esophageal atresia. there is presence of esophageal atresia with lower esophageal segment fistula. So there is a lower esophageal segment fistula is present. Type D variety, you will see the fistula is present in the upper esophageal segment as well as the lower esophageal segment. So there are a fistula communication between these two. Again, the atresia existed. So here there is presence of esophageal atresia. Then esophageal atresia with both upper esophageal segment and the lower esophageal segment fistula is formed. So it is an esophageal atresia with both upper and the lower esophageal segment fistulas are formed. This is what we call it as the type D variety. The H variety, it is only tracheoesophageal fistula. It is only the tracheoesophageal fistula, right? So here it is a pure fistula form. You will see only the fistulous presentation. There is no atresia. When the baby is going to drink milk, the milk is going to go straight down, right? The milk is going to go straight down. The milk is going to go straight down. So there is no atresia per se. Okay? So clinically talking, remember by incidence, the most common type. The most common type of the tracheoesophageal fistula is a type C variety. It is going to be a type C variety, right? So we discussed the pathophysiology of it. Then we discussed the various varieties of the tracheoesophageal fistula that is going to be found. Now we'll talk about the clinical features, right? So here when we talk about the clinical features, we'll talk about the clinical features of type C tracheoesophageal fistula. TOF stands for tracheoesophageal fistula, right? Now you need to understand that every patient who is going to present to you with tracheoesophageal fistula will have a very predictive component, right? Now when you look at this, the first one is the age of presentation. At what age would you expect these babies? Now in the GIT, the concept is very simple. If there is a frank obstruction, what are the examples of frank obstruction? It could be an atresia. It could be, a frank obstruction basically means there is an absolute cutoff of passage. The best examples are like atresias. But if there are relative obstruction like narrowing of stenosis, example like CHPS, congenital hypertrophic pyloric stenosis, in those conditions, there will be a delayed presentation. If a baby has an absolute obstruction, a frank obstruction like atresias, the presentation will be on day 0 or day 1 of life. It is going to be day 0 or day 1 of life. It is going to be on day 0 or day 1 of life. So all babies who are going to have atresial segments or frank obstructional presenters, day 0 or day 1 of life, right? So at what is the sex which is more likely to be affected? Slightly it is more common in male babies when compared to female babies. Whenever you have a doubt now in any congenital disorders, the best answer to pick will be a male baby because female baby have better survival. So their anomalous component or probability of having anomalies are much lower when compared to male babies, right? Now, so you have a baby who's on day 0, day 1, right? Day 0, day 1, day 0 is the day of the baby is born. The next day is called as day 1 of life. It is more likely to be a male baby. So what will be the presentation? Now, in order to understand the presentation, you have to envision what we're talking about, right? So talking about a type C variety. In a type C variety, you have the trachea, which is here. This is where there will be a fistulous communication present. The upper esophageal segment remains in atresia. The lower esophageal segment is going to communicate with that of the stomach. So what is the clinical presentation that is going to happen? Now, as soon as the baby is born, right? तो जैसे बेबी पैदा होगा तो क्या बोलोगे? मुबारक हो, आपको बच्चा हुआ है, ठीक है? तो obviously the mother and the father like ये बच्चा हुआ है, good. अब बारी है कि ठीक है बच्चा पैदा तो हो गया, अब तो जिम्मेदारी संभालो, बच्चे को भूख लग रही है, तो भूख लगेगी तो क्या करोगे? खाना खिलाओगे, खाना इसको खिला नहीं सकते तो क्या करोगे? दूध पिलाओगे. So the minute the mother starts to feed, तो क्या होगा? The milk will go into the esophagus. अब आगे जाने का रास्ता नहीं है तो क्या होगा? The milk will start pooling in the esophagus. पूरा भर गया तो अब क्या होगा? अब जगह जाने के लिए नहीं है तो क्या होगा? तो वापस पीछे फेंकना पड़ेगा. And that is what is going to happen. Every time the baby is fed, the milk goes into the esophagus. Esophagus में आगे जाने की जगह नहीं है तो वापस बाहर pull in करेगा. And that वापस बाहर pull in करने को क्या बोलते हैं? You call it as repeated We call it as repeated regurgitation. There is repeated regurgitation of all feeds. Now all feeds का मतलब ये नहीं है कि मैं बेबी को यहाँ पे चिकन बिरयानी खिला रहा हूँ, ठीक है. All feeds का मतलब है कि every single time the baby is fed, there is no way that it can go anything further. तो ये बाहर आएगा. तो पहला बोलेगी अयो जब भी पिला रही हूँ, अरे ये तो पूरा दूध वहां पे निकाल दे रहा है. तो फर्स्ट कंसर्न. नाउ अनदर वेरी इंटरेस्टिंग थिंग इज, क्योंकि बेबी अभी बॉर्न है तो ऑब्वियसली नियोटोलॉजिस्ट इज गोइंग टू कम लुक एट इट. तो दो तीन चीजें और देखने को मिलेगी. देखो, बेबीज प्रोड्यूस मोर अमाउंट ऑफ सलाइवा पर यूनिट सरफेस एरिया व्हेन कंपेयर्ड टू एडल्ट. तो ऑल दैट सलाइवा व्हाट इज गोइंग टू हैपन, जो भी सलाइवा बनेगा ना, नॉर्मली दैट सलाइवा शुड हैव गॉन इनटू द इसोफेगस, फ्रॉम द इसोफेगस वुड हैव गॉन इनटू द स्टमक, इट वुड हैव रिवर्टेड आउट. लेकिन अब यहाँ जगह ही नहीं है तो क्या होगा, पूरा सलाइवा फ्रॉथ करते हुए बाहर निकलना शुरू होगा. So you'll now notice that because there is no other space for the saliva to go in, it will start drooling out of the mouth. तो ये बेबी को जब आप देखोगे ना तो ऐसा लगेगा कि बेबी आपको देख के लाल टपका रहा है, आपको देख के नहीं टपका रहा है. बेबी को आगे सलाइवा जाने की जगह नहीं है इसलिए बाहर आ रहा है. तो there is repeated region of all feet के साथ there is continuous drooling of saliva. ठीक है. तो दो प्रॉब्लम्स हो गए. एक आपका हो गया रिपीटेड रिजेक्शन ऑफ ऑल फीड्स एंड देयर इज कॉन्टिन्यूस ड्रूलिंग ऑफ सलाइवा. अब देखो, अब सलाइवा जब वापस आ रहा है, इट इज नॉट नेसेसरी दैट इट विल ओनली कम इनटू द माउथ. सम अमाउंट ऑफ सलाइवा और सम अमाउंट ऑफ फूड जो भी हुआ होगा can also go into the trachea. Now as it goes into the trachea, it will irritate the trachea. That is nothing but aspiration. जब tracheal irritation होगा तो क्या होगा, there will be coughing and cyanosis. This baby will have frequent coughing and cyanosis, and this worsens on feeding. This worsens on feeding क्योंकि फीड करने के बाद देखो सलाइवा से ज्यादा इरिटेंट तो दूध होगा, और वो मिल्क जब वापस आके ट्रेकियल सरफेस पे गिरेगा, इट विल कॉज मोर इरिटेशन एंड दैट इरिटेशन विल कॉज कॉफिंग एंड साइनोसिस ड्यूरिंग फीडिंग. अब मम्मी बोलती है बेटे को कुछ प्रॉब्लम है, डॉक्टर साहब को बुलाओ, डॉक्टर साहब को बुलाओ, और डॉक्टर साहब आ गए. ठीक है. अब डॉक्टर साहब बोलेंगे ठीक है काम करते हैं, देख लेते हैं. ठीक है. तो एक तो हो गया रिपीटेड रिजेक्शन ऑफ ऑल फीड्स है, कॉन्टिन्यूस ड्रूलिंग ऑफ सलाइवा है, कॉफिंग एंड साइनोसिस ड्यूरिंग फीडिंग है. तो ये तीनों चीजें मुझे क्या बता रही हैं, ये बता रही हैं कि दी पैसेज आगे जा, देखो ना ही सलाइवा जा पा रहा है ना ही दूध जा पा रहा है, तो कुछ तो जाने का रास्ता ब्लॉक पड़ा हुआ है. ठीक है. नाउ व्हाट आई एम गोइंग टू डू, as soon as you have a day 0 day 1 baby where there is repeated region of all feeds, continuous drooling of saliva, coughing and cyanosis during feeding, ऐसे बेबी के लिए the first step that you are going to do, it is going to put a infant feeding tube. I'm going to put an infant feeding tube, or also called as the Ryle's tube, or also called as the nasogastric tube. ठीक है. तीनों के एक ही नाम है. तो आप पहले इन्फेंट फीडिंग ट्यूब डालोगे. आप बोलोगे सर फीडिंग ट्यूब क्यों डालना है, फीड थोड़ा ना करना है. सही बात है, फीड थोड़ा ना करना है. क्या करना है, यू हैव टू मेक श्योर ऑल दैट सलाइवा दैट इज गेटिंग पूल्ड इन, नो यू हैव टू सक इट आउट. ठीक है. आप उसके अंदर को छोड़ना नहीं चाह रहे. क्यों, यही एस्पिरेशन का कॉज है. आगे चल के बेबी ना इसकी वजह से नहीं मरेगा, ही विल डाई बिकॉज ऑफ एस्पिरेशन न्यूमोनाइटिस. ठीक है. लंग कॉम्प्लिकेशंस, आई डोंट वांट दैट टू हैपन. तो द मिनट आई एम थिंकिंग देयर इज सम प्रॉब्लम, तो पहले तो मैं ये ट्यूब डालूंगा एंड आई कनेक्टेड. सो इन्फेंट फीडिंग ट्यूब इज पुट एंड connected to a negative suction. Connected to negative suction. अच्छा, अब जैसे ही आपने इसको नेगेटिव सक्शन का कनेक्ट किया, यू विल सी दैट ऑल दैट सलाइवा विल बी कंटिन्यूअसली सक्ड आउट ऑफ इट. नाउ माय बेबी इज सेफ. मेरा बेबी नहीं है, जिसका भी बेबी है वो सेफ है. क्यों सेफ है, बिकॉज देयर इज नो फर्दर रिस्क फॉर एस्पिरेशन. इसका मतलब ये तो नहीं कि डायग्नोसिस बना लिया. तो डायग्नोसिस बनाने के लिए क्या करोगे नाउ, क्योंकि अभी ट्यूब तो डाली दी है, तो इन्वेस्टिगेशन के लिए ले जाते हैं. तो पहला इन्वेस्टिगेशन क्या करोगे, देखो अभी ट्यूब अंदर है, सो यू वांट टू गेट एन एक्सरे डन. ठीक है. तो कॉफिंग है, साइनोसिस हो रहा है, रीजर्टेशन हो रहा है, तो एक बार एक्सरे करा के देख ही लेते हैं. ठीक है. द फर्स्ट थिंग वो रेडली अवेलेबल है. तो फर्स्ट थिंग इट इज गोइंग टू बी एक्सरे ऑफ द बेबी. तो एक्सरे में आप देखोगे जो राइल्स ट्यूब आपने डाला था ना, वो राइल्स ट्यूब यहाँ जाएगा एंड देन आगे जाने का जगह नहीं है, तो राइल्स ट्यूब ऐसे कॉइल हो जाएगा. राइट. जैसे अब राइल्स ट्यूब होगा, राइल्स ट्यूब अंदर जाएगा और ये गोल 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 अंदर घूम जाएगा. एक्सरे में राइल्स ट्यूब दिखती है. राइल्स ट्यूब इज बेसिकली हैविंग अ लाइन. अगर आपने राइल्स ट्यूब देखा होगा ना, एक ऑरेंज कलर की लाइन या ग्रीन कलर की लाइन देखने को मिलेगी. वो लाइन क्या, वो रेडियो ओपेक लाइन है जो आपको रेडियोग्राफ में दिखेगी. देन यू विल सी ऑन एन एक्सरे देयर विल बी प्रेजेंस ऑफ कॉइलिंग ऑफ, देयर इज कॉइलिंग ऑफ नेसोगैस्ट्रिक ट्यूब. जैसी कॉइलिंग, अब मुझे पता है कि देखो इसोफेगस में अट्रीसिया है. ठीक है. गली गली में शोर है इसोफेगस में अट्रीसिया है. कैसे पता चला, बाय लुकिंग एट दिस कॉइलिंग ऑफ द नेसोगैस्ट्रिक ट्यूब. जैसी कॉइलिंग का मुझे कंफर्म करना है. कैसे कंफर्म करोगे, आई एम गोइंग टू यूज अ कॉन्ट्रास्ट इमेजिंग. अब ये कॉन्ट्रास्ट इमेजिंग क्या होता है? देखो कॉन्ट्रास्ट इमेजिंग के लिए ना आप बोलोगे कि इस बेबी को रेडियोलॉजिस्ट के पास भेज दोगे, रेडियोलॉजिस्ट एक छोटा सा सिरिंज लेगा 10 cc का, उसमें एक कॉन्ट्रास्ट डालेगा, थोड़ा सा डाइल्यूट करेगा और कॉन्ट्रास्ट बेबी के मुंह में डाल देगा और एक्सरे ले लेगा, और जैसे ही लेगा देखोगे कॉन्ट्रास्ट आगे जा ही नहीं रहा, वो तो पुल अप हो गया, एंड दैट पुलिंग ऑफ द कॉन्ट्रास्ट इज गोइंग टू गिव यू अ डायग्नोसिस, एंड दिस कॉन्ट्रास्ट इमेजिंग इज डन. तो अगर कौन सा सेफेस्ट कॉन्ट्रास्ट टू पुट इन अ बेबी, द सेफेस्ट कॉन्ट्रास्ट टू पुट इन द बेबी इज गोइंग टू बी आयोहेक्सोल. ठीक है, आयोहेक्सोल जो है ये वाटर सॉल्युबल कॉन्ट्रास्ट है. अब जैसे ही मैंने आयोहेक्सोल कॉन्ट्रास्ट डाला अब तो कंफर्म ही हो गया. ठीक है ना, कॉन्ट्रास्ट डालने में क्या होगा कि ये जो जैसे ही आप कॉन्ट्रास्ट डालोगे ना, व्हाट इज गोइंग टू हैपन, द मिनट यू पुट इन द कॉन्ट्रास्ट इन द ओरल कैविटी यू विल नोटिस कि वो कॉन्ट्रास्ट जाके यहाँ पे अटक जाएगा, एंड दिस फिलिंग ऑफ द कॉन्ट्रास्ट एंड अनेबल फॉर द कॉन्ट्रास्ट टू मूव एनी फर्दर. ठीक है, दैट पूलिंग ऑफ द कॉन्ट्रास्ट एक जगह पे रुक गया, इसका डायग्नोसिस हो गया कि इसोफेजियल एट्रीसिया है. तो हम बोलते हैं एज अ नोट पॉइंट याद रखना, हर उस बच्चे को जिसको एट्रीसिया उसको फिस्टुला भी होगा. दैट इज एवरी चाइल्ड हु इज नोन टू हैव एन इसोफेजियल एट्रीसिया इज कंसीडर्ड टू हैव अ ट्रेकियोएसोफेजियल फिस्टुला until unless proven otherwise. ठीक है, तो ये मान के ही चलना है कि बेटा कि इस बच्चे को फिस्टुला है ही. ठीक है, नाउ एक तो मैंने डायग्नोस कर लिया, ठीक है, बधाई हो, डायग्नोसिस मिल गया. अब बारी आती है कि मैनेजमेंट की, क्या मैनेज करोगे. लेकिन मैनेज करने से पहले ना एवरी बेबी हु हैज अ ट्रेकियोएसोफेजियल फिस्टुला मस्ट बी इवैल्यूएटेड बिकॉज दे आर नोन टू हैव अदर कॉन्जेनाइटल कंडीशंस. सो अदर कॉन्जेनाइटल डिसऑर्डर्स, other congenital disorders, other congenital disorders associated with tracheoesophageal fistula, right? So what are the other congenital disorders? What are the other congenital disorders associated with tracheoesophageal fistula? तो इसके लिए ना हमारे पास एक निमोनिक है. निमोनिक का नाम क्या है? इसको हम बोलते हैं वैक्ट्रल. सो वैक्ट्रल से याद रख लेना, जब भी कोई बेबी टॉफ का आएगा ट्रेकियोएसोफेजियल फिस्टुला का, आपको ये चीजें इवैल्यूएट करनी है. तो इस इवैल्यूएशन में क्या क्या है? V stands for vertebral body defect. It is going to be the vertebral body defect. A stands for anal atresia. The anal opening is missing. C stands for cardiovascular abnormality. अब जब भी CVS, that is cardiovascular abnormality बोलोगे, it can be your that is okay. We have PDA, that is patent ductus arteriosus, or it can have ventricular septal defect. ठीक है, usually PDA और VSD होता है. PDA stands for patent ductus arteriosus, VSD stands for ventricular septal defect. ठीक है, and then you have TE. तो इतना है, T से याद रखना ट्रेकियो esophageal fistula, and E stands for esophageal atresia. So as I told you, every patient who has a tracheoesophageal atresia will be associated with tracheoesophageal fistula as well. R stands for your renal, वैक्ट्रल है ना, L कहाँ चला गया, L भूल गए. ठीक है, R stands for renal abnormalities. In renal abnormality में this baby can be associated with horseshoe kidney or also associated with renal agenesis, कि किडनी बनी ही नहीं है. ठीक है, L stands for limb abnormality. लिम्ब एबनॉर्मैलिटी में मोस्ट कॉमनली बेबी का हाथ छोटा मिलेगा, दैट इज अ रेडियल हाइपोप्लेसिया. दैट इज गोइंग टू बी द रेडियल हाइपोप्लेसिया. ठीक है, सो दिस इज हाउ द वेरियस डिसऑर्डर्स आर टू बी इवैल्यूएटेड. अच्छा, इन्वेस्टिगेशन में एक और याद रख लेना, H टाइप वैरायटी में ना, क्योंकि H टाइप में जब आप डालोगे यू विल सी द कॉन्ट्रास्ट विल गो इनटू द स्टमक, सम अमाउंट ऑफ कॉन्ट्रास्ट विल आल्सो गो इनटू द ट्रेकिया आल्सो. तो H टाइप में कभी कभार ना देयर इज अ पॉसिबिलिटी यू कैन मिक्स और यू कैन मिस आउट. तो यहां पे इन H टाइप वैरायटी ब्रोंकोस्कोपी with contrast, that is GI contrast imaging. सो बेबी को सेडेट करेंगे, ब्रोंकोस्कोप डालेंगे, मुंह में कॉन्ट्रास्ट डालेंगे एंड देन विल वेट। तो स्कोप में देखेंगे कि कहीं से निकल रहा है कि नहीं निकल रहा है। इफ इट कम्स इनटू द ट्रेकिया इट इज अ कॉन्फर्मेटरी फॉर एच टाइप वैरायटी। ठीक है, तो ये आपका ट्रेकियोएसोफेजियल फिस्टुला के क्लिनिकल फीचर्स हो गए, इन्वेस्टिगेशन हो गया, अदर एसोसिएटेड कॉन्जेनाइटल डिसऑर्डर्स हो गया। अब बारी आती है मैनेजमेंट की, कैसे मैनेज करोगे। सो मैनेजमेंट ऑफ द ट्रेकियोएसोफेजियल फिस्टुला हैज टू बी सर्जरी। ठीक है, तो जब भी आप सर्जरी के लिए बोलोगे, नंबर वन कि सर्जरी इस बेबी के लिए कौन से पोजीशन में करोगे, द पोजीशन दैट हैज टू बी गिवन फॉर दिस बेबी। देखो ईसोफेगस को एक्सेस करने के लिए बेस्ट राइट साइड होता है, क्योंकि लेफ्ट साइड में आपका आयोटा आएगा। ठीक है, तो राइट से आना ज्यादा बेटर है, तो पेशेंट को आप लेफ्ट साइड में टिल्ट करके रखोगे। तो पोजीशन ऑफ दिस बेबी इज गोइंग टू बी लेफ्ट लैटरल डिक्यूबिटस। ठीक है, अब कौन सा इंसिशन दोगे, द इंसिशन दैट इज गोइंग टू बी पुट इज गोइंग टू बी राइट पोस्टेरोलैटरल थोरोकॉटमी। ठीक है, तो इस बेबी को आप लैटरली लेटाओगे। सो दिस इज अ बेबी, लेट्स से द बेबी इज गोइंग टू बी पुट on the lateral side and the baby is going to put on the left lateral side, exposing the right side. So this is the baby, तो ये बेबी को हमने ऐसे रखा हुआ है। ठीक है, so this is how the baby is put on the lateral side. तो बेबी को ऐसे साइड में लेटाया हुआ है। ठीक है, अब आप बोलोगे पोस्टेरोलैटरल थोरकोटमी कौन सी है। मान लीजिए कि ये डायाफ्राम है बेबी का, ये मिड एक्सिलरी लाइन है, जस्ट फॉर द सेक ऑफ अंडरस्टैंडिंग। पोस्टेरोलैटरल थोरकोटमी में द इंसिशन वुड बी लाइक दिस। ठीक है, सो द इंसिशन वुड स्टार्ट लाइक दिस, दिस इज द इंसिशन, दिस इज ऑन द लैटरल साइड। तो यहां से यहां तक इस इंसिशन को बोलते हैं पोस्टेरोलैटरल थोरकोटमी। ठीक है, तो पोजीशन हो गया लेफ्ट लैटरल, इंसिशन हो गया राइट पोस्टेरोलैटरल थोरकोटमी। सो इन द सर्जरी, in the surgery it is going to be resection, or we're going to do a ligation of tracheoesophageal fistula with primary anastomosis, of esophagus over नेसोगैस्ट्रिक ट्यूब। इसका मतलब क्या है, मतलब बड़ा सिंपल सा है। आई एम सेइंग कि अभी जो हमारे पास पेशेंट आया है, ये आपका ट्रेकिया है, यहाँ पे फिस्टुला बना हुआ है, सो दिस इज द ट्रेकिया दैट इज प्रेजेंट, दिस इज द atricial esophagus, this is where the fistula is formed and this is where the stomach is present. ठीक है, तो what we are saying is we have to ligate the tracheoesophageal fistula and do a primary anastomosis. इसका concept बड़ा simple है। I'm going to put a ligature here, that means I'm going to put a tie here. ठीक है, tie डालने के बाद I'm going to excise this end. Once I'm done tying, I'm going to excise this end. Now I have the esophagus which has been excised from this side. ठीक है, तो अभी we have the esophagus which is here. ठीक है, excise करके यहाँ रखा हुआ, right? Now what I'm going to do is I'm going to take a nasogastric tube, pass into the upper esophagus, और इस esophagus के upper end पे will create a small opening. ठीक है, equal, मतलब opening जो है it should be equal to the same size of the lumen here. Now once you open the lumen, I will pass the nasogastric tube and then I will put the nasogastric tube into the stomach. Once you have done this, now I am going to create an anastomosis here, right? So once you have done this, I'm going to create the anastomosis here, and this is where you will notice. Once the anastomosis between these two ends is done, I will leave it here. So that is what it is. Ligation of the tracheoesophageal fistula with primary anastomosis of the esophagus over the nasogastric tube. Why over the nasogastric tube? Because I want this baby to be fed post operatively. अगर ट्यूब नहीं होगा तो कैसे फीड करोगे, क्योंकि एनास्टोमोटिक साइट तो ऑलरेडी एडिमेटिस होगा, अभी तो इंजरी हुई है ना. In your wound repair or your see anywhere there's an injury there will be an inflammation. Repairing an anastomosis done with sutures, needles and all, obviously there'll be injury, there'll be edema. तो बेबी को immediate post operative में डायरेक्ट फीड नहीं कर सकता, तो I'll be feeding with nasogastric tube, right? So this is how you're going to manage your kids or your babies with tracheoesophageal fistula and atresia. Now, one thing, if you want to impress your examiner, if there is an inadequate length, right? If there is a long distance atresia. Now, what do you mean by a long distance atresia is, if there is a long distance atresia. अब ये long distance atresia का मतलब क्या होता है? In a long distance atresia, you will say the upper esophageal segment and the lower esophageal segment after excising the fistula has a distance which is going to be more than 2 vertebral body distance. So this distance, if it is measured, if it is more than 2 vertebral body defect, if it is more than 2 vertebral body, if there is more than 2 vertebral body distance, it's a long distance atresia. Here, I cannot pull and make an anastomosis. It will be under a lot of tension. So in this, what should be done? I will do a feeding jejunostomy. I will do a feeding jejunostomy. And after doing the feeding jejunostomy, after 6 months, if there is an adequate length, I can go with primary anastomosis. Or I can answer primary, I'll go with anastomosis. I will go ahead with anastomosis, or I will go with interposition surgery. Now, ये interposition surgery क्या होता है? Interposition surgery, because you do not have adequate length, I can take some end of the bowel. कोई दूसरा bowel का loop लेके आके, I can keep in between them and then make the continuity. ये जो नया segment आपने डाला हुआ ना, जो नया आपने replacement किया हुआ है, इसको आप बोलते हो, that is your interposition surgery. Now, for the interposition surgery, what all can I use? Number 1, I can use stomach. Number 2, I can use jejunum. And number 3, I can use colon. जब भी colon होगा, left will be preferred over right. Left will be preferred over right. So stomach, jejunum and colon. So there will be, all these are preferred. We are doing an interposition surgery. Okay? So this is how you're supposed to, answer your questions on tracheoesophageal fistula and atresia. Clear है यहाँ तक? ठीक है? Sorted? Quick feedback. तो हमारा पहला सवाल खत्म हुआ, right? So the first question was tracheoesophageal fistula, and we have discussed each and every single point that has to be written in your exam paper. सही है? Clear? Can you move on? So the next topic, that is going to be about GRD. So the next question that you have is going to be about GRD. GRD stands for gastroesophageal reflux disease. That is a gastroesophageal reflux disease. Please inform the team to upload your handwritten notes in the app like other faculty. They're not doing it. Huh? Okay. Med student, I have taken the note from it. I'll just, after the class, we'll try to give them the same context. ठीक है? अगर नहीं हुआ होगा तो आज तीनों लेक्चर्स के करा देंगे, जो हमने फ्राइडे लिया था, सैटरडे लिया था, आज संडे ले रहे हैं. ठीक है? So GRD stands for gastroesophageal reflux disease. Now, जैसे मैंने आपको बताया था, the first thing will always be the definition. Now, the definition of GRD is, it is defined as pathological reflux. If it is a pathological reflux of gastric content, into the esophagus, ड्यू टू डिक्रीज्ड और लॉस ऑफ टोन of lower esophageal sphincter. Right? So it's a pathological reflux of the gastric content into the esophagus due to decrease or loss of tone of the lower esophageal sphincter is what we call it as GERD. Okay. Now, when you talk about what happens and what is the reason why there's a decrease in the tone of lower esophageal your tone or the lower esophageal sphincter. So when you talk about the causes in general. So when we talk about the cause, so I'm going to divide the cause into two important components. In the cause, one that decreases, one that reduces, or the risk factor for decreasing the lower esophageal sphincter tone, and then risk factor directly for GERD. Right. So all these factors, see, ultimately, when there's decrease in the tone of lower esophageal sphincter, the patient will develop a GERD, but we'll try to divide it into two subsets. One is one that decreases the tone of LES and one that is going to cause GERD. Okay. So how do you remember it? Now, the one that decreases the tone of LES, the most important risk factor is going to be smoking. ठीक है, तो कभी भी आपने ऑब्जर्व किया होगा कि अगर कोई स्मोक कर रहा है ना, तो एक हाथ में सिगरेट है और दूसरे हाथ में ऑब्वियसली चाय या कॉफी है. ठीक है, तो अकेला स्मोकिंग नहीं करेगा ना, चाय सुट्टा तो लगता ही है. ठीक है, सुट्टे के साथ चाय, अगर इंडिया में हो, बाहर जाओगे तो कॉफी होगा, तो कॉफी में क्या मिलेगा आपको? कैफीन मिलेगा. ठीक है, अब जैसे कैफीन is also going to decrease the tone of LES. अब देखो, you have had coffee, ठीक है, सुट्टा भी मार लिया, अब घर वापस जाना है, मम्मी को पता नहीं चलना चाहिए. ठीक है, मम्मी से छुपाओगे कैसे? तो you will eat something to hide that smell. Usually कुछ मीठा खा लोगे ताकि अच्छा भी लगे, तो that is going to be chocolates. So the chocolates which are going to decrease the tone of LES further. अब पूरा दिन पढ़ाई, लाइफ, मेडिकल कॉलेज, एग्जाम, तो यार इंसान इतना भी मतलब इतना मारोगे तो टूटेगा ही ना. तो एक ही चीज जोड़ के रखेगी, क्या है? ठीक है, तो स्मोक भी कर लिया, कैफीन भी होगी, चॉकलेट भी हो गया, पूरा दिन थके हारे हो, तो रात को रिलैक्स करना है. एंड द बेस्ट वे टू रिलैक्स इज व्हाट? द बेस्ट वे टू रिलैक्स, आई एम नॉट प्रमोटिंग इट, बट दी यूजुअली व्हाट पेशेंट्स डू इज गोइंग टू बी अल्कोहल. तो स्मोकिंग हो गया, कैफीन हो गया, चॉकलेट हो गया, अल्कोहल हो गया, दारू पी ली, तो कल सुबह क्या होगा? हैंगओवर होगा तो सर दर्द होगा. अब सर दर्द से बचने के लिए क्या करोगे? यू स्टार्ट टेकिंग सर्टेन ड्रग्स, medications. Drugs that decrease the tone of LES can be remembered as A, B, C, D. A stands for anticholinergic. B stands for barbiturates. C stands for calcium channel blocker. D stands for diazepam. Right? So anticholinergic, barbiturates, calcium channel blocker and diazepam is the one that decreases the tone of LES. ठीक है, इसके साथ साथ अगर आप प्योरली रिस्क फैक्टर बोलोगे GERD की, दी प्योर रिस्क फैक्टर्स ऑफ GERD इज गोइंग टू बी ओबेसिटी. ओबेस पीपल में लोअर स्फिंक्टर का टोन अपने आप खराब हो जाता है. देन इज प्रेगनेंसी. प्रेगनेंसी में ऐसा क्या जादू होता है कि पेशेंट को GERD होने लगता है? प्रेगनेंसी इज गोइंग टू बी अ प्रोजेस्टेरॉन ड्रिवन स्टेटस एंड प्रोजेस्टेरॉन का कॉन्सेंट्रेशन ज्यादा होगा. व्हाट इज द इफेक्ट ऑफ प्रोजेस्टेरॉन ऑन द स्मूथ मसल? इट कॉजेस स्मूथ मसल रिलैक्सेशन. लोअर इसोफेजियल स्फिंक्टर जो है वो स्मूथ मसल है, सो अंडर द इन्फ्लुएंस ऑफ your progesterone it relaxes, तो GERD होगा. Same reason है उनको, they have incontinence in the bladder, the same reason they have easy passage of flatus and stools. All that happens because of progesterone. ठीक है, तो obesity हो गया, pregnancy हो गया, systemic एक connective tissue disorder ना, that is going to be scleroderma. So there is obesity, there is pregnancy, and there is associated with scleroderma. All these are going to be an attributed risk factors. तो अभी तो मैंने बताया drugs, these are the one that decrease the tone of lower esophageal sphincter. ठीक है, इतना मिनिमम आपको याद रखना है. क्लियर है? ठीक है, सॉर्टेड है, राइट? Now these are the causes of GERD per se. Now, how would a patient of GRD is going to present to you? So, talk about the clinical features. We're going to talk about the clinical features of GRD. So, when you look at the clinical features of GRD, उसको समझने के लिए let's understand the basic objective. ये आपका esophagus है, ये आपका stomach है, ठीक है? Clear है? This is going to be your diaphragm, ठीक है? फिर आप देखोगे ये जो लोअर पार्ट है, दिस इज व्हाट इज योर लोअर esophageal sphincter, ठीक है? नाउ लोअर esophageal sphincter इज बेसिकली एन एनाटॉमी, इट्स अ फिजियोलॉजिकल स्फिंक्टर, ठीक है? तो esophagus में दो स्फिंक्टर्स हैं, सबको पता है, अपर esophageal sphincter, लोअर esophageal sphincter. अपर esophageal sphincter is going to be your anatomical sphincter, लोअर esophageal sphincter is going to be your physiological sphincter. फर्क क्या है? एनाटॉमिकल स्फिंक्टर में एक्चुअली एक स्ट्रक्चर है जो स्फिंक्टर की तरह बिहेव करता है, फिजियोलॉजिकल में कुछ नहीं है, ल्यूमन खाली है, लेकिन सब इसको दबा के रख रहे हैं, एंड बिकॉज ये दबा हुआ है, इसको खोलने के लिए कुछ प्रेशर लगेगा, अगर जब तक प्रेशर नहीं दोगे खुलेगा नहीं, एंड दैट कोलैप्स सेगमेंट व्हिच रिक्वायर्स सर्टेन अमाउंट ऑफ प्रेशर टू ओपन इज गोइंग टू बिहेव एज स्फिंक्टर. तो ये एरिया स्फिंक्टर की तरह बिहेव करता है. क्या क्या रीजंस हैं? एक तो आपका डायाफ्राम, ये देखो डायाफ्राम जाएगा, इसको जकड़ के रखेगा. इट इज द डायाफ्रामेटिक मसल, वी कॉल इट एज द क्रस ऑफ द डायाफ्राम, द क्रस ऑफ द डायाफ्राम व्हिच इज गोइंग टू, इट इज द डायाफ्रामेटिक क्रस व्हिच इज गोइंग टू होल्ड द esophagus. तो esophagus को ये जो डायाफ्रामेटिक क्रस है दबा के रखता है, ठीक है? तो एक तो ये हो गया, डायाफ्रामेटिक मसल्स हो गया. दूसरा क्या हो गया? सेकेंड थिंग दैट यू विल नोटिस, the second thing that you will notice is going to be the intra-abdominal length of the esophagus. देखो नॉर्मली जो esophagus है ना 25 सेंटीमीटर का होता है. The entire esophagus your 25 centimeters. This is what we call it as the intra-abdominal esophagus. अब जो intra-abdominal esophagus है that is going to be approximately 4 to 5 centimeters. Now इससे objective क्या? The objective here is in the thorax there is negative pressure, and we all know negative pressure का मतलब होता है pulling pressure, और abdomen में क्या है? positive pressure. तो यहाँ पे esophagus खिंच रहा है और positive pressure से esophagus दब रहा है, तो obviously this part of the esophagus is going to get compressed, and that compression is going to result in sphincter like mechanism. तो एक तो आपका हो गया crus of the diaphragm, दूसरा intra-abdominal length of the esophagus. तीसरा क्या होगा? You will notice that this particular angle where you can see the esophagus is going in and then the stomach is taking out, ठीक है? ये जो esophagus और stomach के बीच का एंगल है, esophagus और stomach के बीच का एंगल है, इसको बोलते हैं एंगल ऑफ हिस. ये बहुत एक्यूट है, तो इट इज गोइंग टू कंप्रेस द esophagus. फिर आप देखोगे देयर आर दीज मसल फाइबर्स व्हिच आर प्रेजेंट व्हिच आर गोइंग टू बी अ स्लिंग मसल फाइबर्स. ये फंडस के मसल फाइबर्स हैं जो लोअर पार्ट ऑफ द esophagus के साथ एनसर्कल कर रहे हैं, ठीक है? So all the sling muscle fibers, no, they're arching around the lower part of the esophagus. तो जब ये contract करेगा ना तो इसको दबाएगा. So it's like a sling-like action, like a rubber band action. तो इसको दबा के रखेगा. That is going to behave as sphincter. तो एक तो crus of the diaphragm हो गया, intra-abdominal length of the esophagus हो गया, angle of His हो गया, your fundus, that is going to be your muscles which are going to sling muscle fibers. Then you have hypertrophied circular muscles in this area, increased tone in the lower part of the esophagus. All these are going to predict or attribute to that of the lower esophageal sphincter. हमारा ऑब्जेक्टिव कि स्फिंक्टर समझने का नहीं है, हमारा ऑब्जेक्टिव है कि ये देखने के लिए कि जीआरडी में हो क्या है. अब जीआरडी में ये पूरे स्फिंक्टर मैकेनिज्म की ना वाट लग जाती है. हियर द एंटायर स्फिंक्टर मैकेनिज्म इज लॉस्ट, or I can say it has become weakened. Now what is going to happen if the sphincter mechanism is going to be weakened? There is nobody who is going to stop the content from going from the stomach into the esophagus. तो क्या होगा अगर चला भी गया? ठीक है? So you need to understand. Okay. You need to understand that the entire esophagus is lined by the squamous epithelial cell. The entire esophagus is lined by the squamous epithelial cell. The last 2 centimeters of the esophagus, the last 2 centimeters of the esophagus is lined by columnar epithelial cell. और यहाँ से आप देखोगे that it is the entire GIT all the way to the dentate line of the anal canal. It is going to be lined by your columnar epithelial cells. Problem columnar epithelial cell का नहीं है. I mean, in fact, the columnar epithelial cells is what it protects the stomach from getting burnt from the acid that is going to be released. That is your hydrochloric acid. Stomach में hydrochloric acid release होता है. इसी के वजह से stomach का pH is going to be 1.5 to 2. है ना? Now, what is going to happen is this, whichever columnar cells which are present, they are going to have mucus producing cells, and that mucus producing cells is going to produce mucus, and that mucus secretion is going to act as a thick membrane like barrier. ठीक है, तो इन cells के ऊपर ना, these are mucus producing cells are there, these mucus producing cells produces mucus. Now this mucus is going to act as a mechanical barrier, और इसके साथ साथ एक और बहुत इंपॉर्टेंट प्रॉपर्टी है इस म्यूकस की, दिस म्यूकस इज रिच इन बाइकार्बोनेट. ठीक है, अब क्या होगा, यू विल सी दैट इन द स्टमक वी हैव द स्पेशलाइज्ड सेल्स, एंड दीस स्पेशलाइज्ड सेल्स आर व्हाट वी कॉल इट एज parietal cells. These parietal cells are going to secrete hydrochloric acid. अब ये जो hydrochloric acid है वो आके stomach के surface पे गिरेगा. Now when the hydrochloric acid falls onto the surface of the stomach, एक तो barrier है तो underlying cells damage नहीं होते, दूसरा क्या है, bicarbonate is a base, no acid और base neutralize हो जाएगा. ठीक है, तो it won't allow the acid to penetrate deeper. And that's why, you know, stomach के अंदर even though there is secretion of acid, it does not cause any damage to the any epithelial surface because of this mechanism which is present. लेकिन जैसे ही टोन कम होगा, what will happen, you will see now the acid will start to reflux. ठीक है, इनिशियली वो लास्ट 2 सेंटीमीटर ऑफ द इसोफेगस पे गिरेगा, जहां पे ऑलरेडी कॉलमनर एपिथेलियम है, वहां पे कोई प्रॉब्लम नहीं होगी. लेकिन एज द रिफ्लक्स बिकम्स प्रोग्रेसिव, दिस इज नाउ गोइंग टू गो एंड फॉल ऑन टू द स्क्वामस एपिथेलियल सेल. ठीक है, तो आप देखोगे ये पूरा जो है हमारा इसोफेगस इज लाइंड बाय द स्क्वामस एपिथेलियल सेल्स. ठीक है, अब ये जो स्क्वामस एपिथेलियल सेल्स है, इनके पास तो म्यूकस प्रोड्यूसिंग सेल्स है नहीं, दे कैन नॉट प्रोड्यूस म्यूकस. इफ दे कैन नॉट प्रोड्यूस म्यूकस, इनको बचाएगा कौन, इनको कोई नहीं बचाएगा. जब एसिड आके इस पे गिरेगा, व्हाट इज गोइंग टू हैपन, द मिनट द एसिड इज गोइंग टू कम एंड फॉल ऑन इट, यू विल सी दैट दीज सेल्स विल बी बर्न्ट. तो ये जल जाएंगे. ठीक है, यहाँ से धुआं निकल रहा है. ठीक है, जस्ट फॉर दिस आर्टिस्टिक सेटिस्फैक्शन आप देखोगे कि यहाँ पे जल के इन सेल्स में से धुआं निकल रहा है. अब यही बर्निंग सेंसेशन, आपका पेशेंट भाग के दौड़ के आएगा, डॉक्टर साहब जल रहा है. क्या जल रहा है? सो द फर्स्ट कंप्लेंट दैट द पेशेंट इज गोइंग टू प्रेजेंट टू यू इज गोइंग टू बी अ रेट्रोस्टर्नल हार्टबर्न. इट इज गोइंग टू बी योर रेट्रोस्टर्नल हार्टबर्न. अब ये जो रेट्रोस्टर्नल हार्टबर्न है, इट इज व्हाट दे डिस्क्राइब्ड एज दिल जले. सच में दिल जल, इसका सच में जल रहा है यार, वो तो अलग कॉन्टेक्स्ट में बोल रहे हो कि दिल जल रहा है, इसका तो सच में जल रहा है, बर्न हो रहा है इसलिए तो आ रहा है बेचारा. सो इज रेट्रोस्टर्नल हार्टबर्न इज प्रेजेंट. नाउ अलोंग विद एंड ये जो रेट्रोस्टर्नल हार्टबर्न है, इट विल बी सडन एंड सिवियर इन ऑनसेट. दिस इज गोइंग टू बी सडन एंड सिवियर इन ऑनसेट. कभी कभार तो ऐसे भी लगता है ना, पेशेंट को एंजाइना लेके अटैक आ गया, इतना दर्द होता है. ठीक है, सो रेट्रोस्टर्नल हार्टबर्न, इट इज बिकॉज इट इज गोइंग टू हैव अ सडन सिवियर ऑनसेट, दैट इज बिकॉज ऑफ बर्निंग ऑफ द स्क्वामस एपिथेलियल सेल. नाउ बिकॉज द टोन इज बिकमिंग लेस, अब टोन अगर छूटने लगा, टोन कम हो गया, तो ऑब्वियसली द कंटेंट ऑफ द स्टमक विल कम इनटू द एसोफेगस फ्रॉम देयर इनटू द माउथ एंड देन आउट. सो विल बी regurgitation. There will be regurgitation of food particles. There will be regurgitation of food particles. Now, because there is a damage in the esophagus, and that damage in the esophagus is nothing but damage in the foregut. जितना भी आपका foregut derivatives है, उसका जो referred pain होगा वो epigastric region में होगा. Midgut is going to be periumbilical region, hindgut is going to be in the pelvic region. तो यहाँ पे दर्द कहाँ पे होगा, जल यहाँ पे रहा है, दर्द सेंटर में होगा. There will be presence of epigastric pain as well. There will be presence of epigastric pain. So a sudden severe onset of retrosternal heartburn, there will be regurgitation of food particles, they are going to have an epigastric pain. A patient continues to ignore. What is going to happen? The next stop is going to be, as the reflux becomes more and more progressive, अब ये आके patient के जीभ पे गिरेगी. So now you will see this acid as it continues to reflux. One fine day it will fall onto the tongue, and once it falls onto the tongue, right, पेशेंट बी एबल टू टेस्ट द एसिड. और जैसे ही एसिड को टेस्ट करेगा, अच्छा थोड़ा लगता है यार, एसिड का टेस्ट खट्टा खट्टा सा होता है, तो इसी को वो बोलता है कि सर कुछ खट्टा लग रहा है, एंड दैट इज गोइंग टू बी अ सार ब्रश. ठीक है, सो दिस इज गोइंग टू बी एसोसिएटेड विद सार ब्रश. सो रेट्रोस्टर्नल पेन, regurgitation of food particles, epigastric pain, sour brush is there. इसके साथ साथ what else can you see? ठीक है, तो ये सब तो GI फीचर्स हो गए. रेट्रोस्टर्नल हार्टबर्न, regurgitation of food particles, epigastric pain, sour brush is what you see the GI features. इसके साथ साथ ना, to impress your examiners, you can also write the extra GI manifestations. This is going to be an extra GI manifestation. Now all that acid that is going to reflux, right, Now that reflux is going into the mouth, that is into the tongue, no? In between you have pharynx also, right? So it is going to be associated with laryngitis. It is going to be associated with pharyngitis. This will also be associated because जैसी acid is going to go into aspiration. When it is going up, no, it can revert back into the trachea also, right? As an aspiration. When it goes, it is going to cause tracheal irritation, and that will cause damage in the trachea. And that damage in the trachea, and then into then the content goes into your smaller your airways, that is your alveoli and all. That is going to result like asthma-like features. Now, damage of the lungs will also be associated with pulmonary fibrosis. So this is associated with laryngitis, is associated with pharyngitis, asthma, pulmonary fibrosis. And because another very interesting thing, no, as the acid reflux into the mouth, it is going to hit the teeth. Now on the teeth, on the surface of the teeth, you have a protective cover called as enamel. This whitish layer that is called as enamel. Enamel was acid sensitive. Enamel is extremely acid sensitive. The minute acid comes and falls onto the enamel, it will disrupt the enamel. Disruption of the enamel will result in yellowing of teeth. This will result in yellowing of the teeth. So there is laryngitis, pharyngitis, asthma, pulmonary fibrosis, and yellowing of the teeth are the extra GI manifestations of the GERD. Okay, so GERD mein both your GI and extra GI manifestations you have spoken about. Okay, now what are the complications which are associated with GERD? Complications associated with GERD. Complications associated with GERD. Okay. So what are the complications that are associated with GERD? Now, the first thing, as the esophagus is getting repeatedly abused and damaged, so there will be inflammation, and that will result in esophagitis. This will result in esophagitis, right? Now, this esophagitis, which is going to be occurring secondary to GERD, there's a very important finding that you have radiographically. That is what we call it as the feline esophagus. Now, feline esophagus is nothing but an esophagus with stacked mucosal ring-like appearance. So, feline esophagus, it will have stacked mucosal ring appearance. Other conditions where you will see feline esophagus. Feline esophagus is also seen in eosinophilic esophagitis. Also seen in eosinophilic esophagitis. It is also seen in eosinophilic esophagitis. Okay? So this is one of the common complications. Now, as the acid refluxes, it causes injury to the esophageal mucosa. That injury to the esophageal mucosa will heal by inflammation. That is called as esophagitis, right? Now, repeated inflammation anywhere in the body is going to heal by fibrosis. The GERD is not treated. This esophagitis will occur repeatedly. Repeated esophageal inflammation. Repeated inflammation healed by fibrosis, and that fibrosis will result in esophageal stricture. This is going to result in esophageal stricture. Now, whenever there is a stricture, stricture is because of fibrosis. In fibrosis, tissue condenses. Condensation of the tissue, the esophagus is this lengthy, because there is an inflammation, this fibrosis, the esophagus is going to condense. This condensation of the esophagus will result in shortening. This is going to result in shortening in the length of the esophagus. In the length of the esophagus. This will result in shortening in the length of the esophagus. So there is esophagitis, there is esophageal stricture, shortening in the length of the esophagus. Now, whenever the esophageal length gets shortened, there is something very interesting that you need to understand, that if this is the esophagus, this is the stomach that you have. We have just discussed that some amount of the esophagus is going to be below the level of diaphragm. This is called as the intra-abdominal esophagus, and this is your gastroesophageal junction. Now, if there is a stricture which is present in the esophagus, if there is a stricture that is going to be present in the esophagus, this stricture is going to heal by fibrosis. Now, because of fibrosis, you will see this tissue is going to condense. Now, as the tissue condenses, you will notice that this, that is your gastroesophageal junction which is present here, will now migrate. And if they migrate above the level of diaphragm, if they migrate above the level of diaphragm, this migration of the gastroesophageal junction from intra-abdominal space into intrathoracic space over the diaphragm is what we call it as sliding hiatal hernia. This is what we call it as the sliding hiatal hernia. This is what we call it as the sliding hiatal hernia, right? So esophagitis, esophageal stricture, esophagitis, esophageal stricture. Just give me 1 second, guys. Okay, sorry. Yeah. So I think esophagitis, esophageal stricture, shortening in the length of the esophagus, sliding hiatal hernia. Along with that, there's a condition which is called as the Barrett's esophagus. It is called as the Barrett's esophagus. So Barrett's esophagus is a short note exam question also. So what is this Barrett's esophagus? Right. So first, what is the cause for the Barrett's esophagus? The cause, it is because of long standing. It occurs due to long standing untreated GRD. The long standing untreated GRD. What is the pathophysiology behind it? The pathophysiology behind the Barrett's esophagus. The pathophysiology behind the Barrett's esophagus is, normally you see that the squamous epithelial cells are going to be sensitive. So if you take this as the representation of the esophagus, right? If you take this as a representation of the esophagus, we have the squamous epithelial cells which are present here. And then you had a columnar epithelial cells which are present. We all know that the columnar epithelial cells are protective from acid because of their ability to secrete mucus. Because of the ability to secrete mucus. So what is going to happen, that every time the acid is going to come and fall, here there is no impact for the acid. But when the acid comes and falls onto the squamous epithelial cells, it is actually causing the damage in this area. So body says there is a repeated damage in the squamous epithelial cells. How do I overcome it? तो अभी तो बाजू में देख रहा है ना, he's drawing the inspiration. कॉलमनार है तो कोई दिक्कत हो ही नहीं रही है, स्क्वामस हो रहा है तो बैंड बज रहा है, तो बॉडी बोलते काम करते हैं, स्क्वामस को कॉलमनार में बदल देते हैं. And now this is where the body says I am going to transform myself, and this transformation is the squamous epithelial cells are now going to get converted. The squamous epithelial cells are now going to get converted into your columnar epithelial cells. But as they do so, they take additionally one more thing. Now, what is that one more thing additionally? They secrete or they present to you with the goblet cells. So they start producing some specialized cells which are called as goblet cells. Now, goblet cells kya karte hain? They produce mucin. Okay? Now, what has happened is, in order to survive this entire battle, we have noticed that these squamous epithelial cells, the squamous cells have now transformed into columnar epithelial cells. But along with columnar epithelial cells, they also have presence of goblet cells. Now, goblet cells usually body में कहाँ मिलेंगे? वो intestine में मिलेंगे, ठीक है? Now you see squamous is converting to columnar. It is called as metaplasia, ठीक है? और metaplasia goblet cell के साथ हो रहा है, तो intestinal type of, क्योंकि goblet cells are present in intestinal mucosa, it appears to be like an intestinal mucosa. Hence, this whole phenomena is what we call it as intestinal type of metaplasia. This is what we call as intestinal type of metaplasia. This is what we call it as the intestinal type of metaplasia, right? So the squamous epithelial cells is converting into the columnar epithelial cells along with the goblet cells, and this whole conversion is what we call it as the intestinal type of metaplasia. Remember, dysplasia is irreversible, metaplasia is usually reversible. Metaplasia is usually reversible, right? Now, how would a patient present to you? The clinical features of Barrett's esophagus. The clinical features. The clinical features of Barrett's esophagus. The clinical features of Barrett's esophagus, nothing spectacular about it. It is going to be same as GERD. This is going to present as same as GERD because Barrett's is not a disease. It's a complication of an untreated GERD. Okay? So whenever a patient has a long-term GERD, I would like to investigate this. So when you're trying to talk about investigation. So when you're trying to investigate the GERD, the investigation. So we'll talk about the investigation of GERD first, and then we'll talk about the investigation of Barrett's esophagus. So in the investigation of GERD, whenever you're suspecting a patient with GERD, the first investigation will be a 24 hours pH monitoring. There will be a 24 hours pH monitoring. The first thing that you're going to do is going to be a 24 hours pH monitoring. Okay? Now, once you have done with 24 hours pH monitoring, the other ones that you have is a 48 hours ambulatory pH monitoring. So, we have more data. You have 48 hours ambulatory pH monitoring. So, you have 24 hours pH monitoring, 48 hours ambulatory pH monitoring. Along with that, you can also do that is called as impedance pH monitoring. So when you do an impedance pH monitoring, or you can say the ambulatory impedance pH monitoring, we measure something called as the D-Meester score. Okay? So itna yaad rakhna, whenever we're talking about a D-Meester score, if a D-Meester score is more than or equal to 14.7, it is confirmatory of GERD. Itna hi likhna hai. Okay? So 24 hours pH monitoring, 48 hours ambulatory pH, impedance pH monitoring. Along with that, I will do an upper GI endoscopy. Now, in the upper GI endoscopy, it is very important because जब आप upper GI endoscopy करोगे, इतना याद रखना, in an upper GI endoscopy, if you find there is presence of red velvety mucosa, if there is presence of red velvety mucosa, it points towards Barrett's esophagus. It points towards Barrett's esophagus. So whenever there's a red velvety mucosa present, remember in this upper GI endoscopy, with biopsy should be performed. With biopsy should be performed. The reason why you want to do biopsy is, remember, in Barrett's esophagus increases the risk for adenocarcinoma of the stomach. It increases the risk for adenocarcinoma of the stomach. To rule out the adenocarcinoma of the esophagus, not the stomach. It increases the risk for adenocarcinoma of the esophagus. Now, to rule out the malignancy, you should always perform biopsy. Now, on a biopsy, once you've done the biopsy, if it is positive for Barrett's, esophagus, here the management for Barrett's esophagus, it is to treat GERD. So as I told you, Barrett's esophagus is not a disease, it's a presentation of an underlying disease. So even if you diagnose this as Barrett's, the management will still refer it to the treatment of GERD only. Okay? So we started with the clinical, what is GERD? What are the causes for GERD? What are the clinical features that you can see? What are the extra GI manifestations? What are the complications associated with GERD? How would you like to investigate it? How would you see as a Barrett's esophagus? And all these can be taken care of. Now comes the workhorse, that is the management of GERD. So when you talk about the management of GRD, when we talk about the management of GRD, in the management of GRD, the first line management, it is going to be medical management. The first line management, it is going to be a medical management. So in the medical management, what are you going to give? Number one, I'm going to prescribe the patient with proton pump inhibitors. Now the PPI should be given. Along with proton pump inhibitors, I will advise for lifestyle modification. Now in the lifestyle modification, I would ask the patient to reduce weight, quit smoking, no alcohol and all that, and then regulate the diet also. In the regulating the diet, I will advise the patient to take small frequent feeds, not to load the stomach, right? So it is going to be your proton pump inhibitors, lifestyle modifications, as well as small frequent feeds. All these should be taken as medical management. Now, if the medical management phase, that means patient is still symptomatic, then you would go down to the second line management. Now, the second line management, it is going to be surgery. So how would you actually make a decision for surgery? So what are the current indications for surgery? Now the current indication for surgery, number one, not responding to medical management. Not responding to medical management. That means even after starting proton pump inhibitors, even after starting the proton pump inhibitors and lifestyle modification, patient is still symptomatic, consider for surgery. Number two, if there is development of Barrett's esophagus, if there is development of Barrett's esophagus, if there is esophageal stricture, if there is an esophageal stricture, if it develops into hiatal hernia, that is a sliding hiatal hernia, right? So not responding to medical management, Barrett's esophagus, presence of stricture, or any evidence of hiatus hernia, this is where you have to go with surgery. Now, in the surgery, what surgery are you going to prefer? It is going to be an anti-reflux surgery. So in an anti-reflux surgery, it is usually done as fundoplication. It is performed as fundoplication. So in the fundoplication, what are we going to do? So what you're going to do is, if this is the esophagus, I have to strengthen the sphincter. So this is the stomach that is present. So we will wrap the stomach. So this is stomach that you have. So I've taken the fundus of the stomach and I have pulled it, right? I've taken this fundus of the stomach, I have rotated around the esophagus, and then I am at stomach again. Okay, I'm just going to suture at this end, right? Now this surgery where you're taking the fundus of the stomach, this is the fundus of the stomach, and this is encircling the esophagus. This is the fundus of the stomach. It is encircling the esophagus, and once it is there, I'm going to suture this at this end. I'm going to suture the esophagus to stomach, and this surgery is what we call it as Nissen's Fundoplication. This is what we call it as Nissen's Fundoplication. Nissen's Fundoplication. When you look at this, it is going from behind, so it is a posterior. It is encircling the entire circle completely, so it is called as complete. It is a posterior complete fundoplication. It's a posterior complete fundoplication, right? So this is your Nissen's fundoplication. बेटा आदित्य इसमें कोई मतलब यू डोंट नीड टू लर्न बिकॉज व्हेन यू सी द पेशेंट ऑन अ डेली बेसिस, इतनी बातें होती हैं पेशेंट से, इतनी चीजें बताता है, एज अ क्यूरियस सोल नो, एज अ सर्जन, एज अ डॉक्टर, एज अ क्लिनिशियन नो, जब भी आपके पास कोई पेशेंट आके कुछ बताता है तो यू नीड टू फाइंड द आंसर कि क्यों हो रहा है, and once you understand it, no, उसका it sticks to your head. So this entire thing that I've told you, no, it's about my patients. ठीक है, जब पेशेंट को आप देखोगे तो बेचारा क्या कंप्लेन लेके आएगा, पेशेंट आपके पास आएगा कि डॉक्टर साहब ये सब प्रॉब्लम हो रही है। जब ये प्रॉब्लम हो रही है तो आपको पता है कि अगर ज्यादा दिनों से हो गई तो ये भी हो सकता है, अगर ये हुआ तो कॉम्प्लिकेशन में ये देखने को मिलता है, अगर ये कॉम्प्लिकेशन होगा तो आप कैसे इन्वेस्टिगेट करोगे, आपको आपका प्रोटोकॉल पता होना चाहिए, इन्वेस्टिगेशन में फाइंडिंग क्या मिलेगी, फाइंडिंग के हिसाब से मैनेजमेंट क्या करनी है, मैनेजमेंट में सर्जरी करनी है, सर्जन अगर सर्जरी नहीं करेगा तो क्या करेगा। ठीक है भाई, ये सब तो मतलब दिस इज लाइक योर लव यार, ये पैशन है। ठीक है, तो इसमें कोई याद रखने वाली बात नहीं होती है, जिस चीज से प्यार होता है वो अपने आप याद रहती है, टेंशन नहीं लेना। ठीक है, सो आई जस्ट वांट यू टू अंडरस्टैंड, सो दैट इज व्हाई इफ यू अंडरस्टैंड, इफ यू रियली डिग इनटू द कॉन्सेप्ट्स ऑफ मेडिसिन, नो देयर इज नथिंग लाइक इट, मतलब उसका नशा ही अलग है। चलो, सो नीसेस फंडोप्लाइकेशन में क्या होगा, आप स्टमक को पीछे से लेके आ रहे हो, सो इट इज अ पोस्टीरियर कंप्लीट फंडोप्लाइकेशन। व्हाट आर द अदर एग्जांपल्स और अदर फंडोप्लाइकेशंस दैट यू हैव? The other examples of the fundoplication that you have, it is going to be DOR, then there is Topet, and there's DOR fundoplication, there's Topet, there's Watson, right? So different fundoplications are present. ठीक है, just for the name से कितना याद रख लो, more than important है। अच्छा, फिर अगर आपके एग्जामिनर को इम्प्रेस करना है, what are the new techniques or the new methods? New methods में number one, you can go with RFA, that is radio frequent ablation. Number two, there is a device called as the Lynx device. Lynx is a magnetic bead. It's a magnetic bead device. Then you have Esofix. Esofix is an endo-GI stapler. ठीक है, सो रेडियो फ्रीक्वेंट एब्लेशन यू कैन डू इट, यू कैन डू अ लिंक्स व्हिच इज अ मैग्नेटिक बीड, तो मतलब वो मैग्नेट का बीड का जो रिम होता है ना, वो इसोफेगस के ऐसे लगाते हैं, राइट? सो इट इज गोइंग टू होल्ड द इसोफेगस टाइट, सो एवरी टाइम यू swallow, because the magnet attract with each other, they compress the esophagus. That is going to be a links device. Esophagus is an endo-GI stapler. You take and you staple the fundus with the posterior wall of the esophagus so that it adheres and again increase the tone. So all this concludes in that particular context. ठीक है, so this is how you're going to talk about your entire GRD. Clear है? Sorted? ठीक है, so did we cover all the questions? Let's look at the quick component here. कहाँ गया अपना सवाल? तो हमने कवर कर लिया है जी, GRD कर लिया है, Barrett's esophagus भी कर लिया है। ठीक है, now coming to another very very important topic, that is going to be esophageal virus. तो तीनों एक ही में कवर कर लेंगे, esophageal viruses, tips और upper GI bleed and its management. ठीक है, clear? So far any questions? कोई सवाल, कोई शक, कोई डाउट? क्विक फीडबैक। कोई सवाल, कोई शक, कोई प्रॉब्लम? गोइंग गुड? समझ में आ रहा है? आई होप सो। चलो, so we'll talk about the upper GI bleeds and we'll talk about esophagus. पेज खत्म हो गया क्या? कोई ऐड कर लें? चलो, so we'll talk about the upper GI bleed. So the next question is going to be upper GI bleed. So in order to conclude what you're talking about, GI bleeds का जो classification है, so we talk about the GI bleed. GI bleed is categorized into the upper and the lower GI bleed. ठीक है, so they classified into two components. We have the upper GI bleed
and then you have the lower GI bleed. You have the upper GI bleed and the lower GI bleed. Okay. So how do you know what is an upper and what is a lower GI bleed? Any bleed in the GI lumen, above the ligament of teats, is what we call it as an upper GI bleed. Same thing validates for lower GI bleed. Any bleed in the GI lumen, below the ligament of teats. As a hepatoduodenal ligament, below the ligament of teats is what we call as lower GI bleed. Okay. So when we talk about the GI bleeds, we categorize them. The causes for the upper GI bleed, we can categorize them into two major causes, right? Talk about the cause for upper GI bleed. So we're going to talk in two different categories. One we call it as the variceal bleeding, another one is your non-variceal bleeding. One we call it as the variceal bleeding. Another one is non-variceal bleeding. Now, why I'm differentiating into two different categories is variceal bleeding is of significant quantity, right? Whereas the other ones can be of different context as well. So when talk about the variceal bleeding ka jo cause it is because of esophageal varices, right? So this occurs because of esophageal varices. So we'll talk about the reasons for esophageal varices. For now, it is this. Now, what is more interesting is going to be your non-variceal bleeding. Now, in a non-variceal bleeding, there's a huge spectrum of the disorders that we should be knowing it. So, in a non-variceal bleeding, one of the most, repeatedly formed questions that you will see, it is going to be associated with erosive gastritis. It can be seen secondary to erosive gastritis. It can be seen secondary to peptic ulcer disease. It can be seen secondary to gastric cancer. It can be seen to secondary to gastric carcinoma. Then you have other causes like Mallory Weister. It is associated with Mallory Weister. It is associated with that of the Mallory Weister. Mallory Weister. It is associated with condition like GAVE, that is your gastric antral vascular ectasia. Gastric antral vascular ectasia. Also, sir, Delofoy's gastric lesion is also associated with Delofoy's gastric lesion. Right. So these are the various causes for your variceal as well as non-variceal bleeding. Okay. Now, we're talking about the esophageal varices first, and then we'll go into the non-variceal bleeding causes as well. Okay. Now, the first one is going to be your esophageal varices. So the question that we're going to discuss here is going to be about esophageal varices. So the esophageal varices, when you talk about it, the cause for the esophageal varices is going to be portal hypertension.
So when we talk about what is an esophageal varices, esophageal varices is described as these are dilated submucosal, dilated submucosal vascular plexus due to portal hypertension. So the dilated submucosal vascular plexus due to portal hypertension resulting in significant upper GI bleed. ठीक है. So dilated submucosal vascular plexus due to a portal hypertension resulting in significant upper GI bleed. Now, to understand the whole concept, you need to understand what is portal hypertension. Now, to understand the whole concept of portal hypertension, remember the normal portal pressure. The normal portal pressure, it is going to be 1 to 5 millimeters of mercury. Then there's something called as pre-portal hypertension. That is going to be 6 to 9 millimeters of mercury. Now after pre-portal, then you have portal hypertension. Portal hypertension is described as pressure of more than or equal to 10 millimeters of mercury. So when would you have bleeding in esophageal varices? So bleeding in varices occurs when there is more than or equal to 12 millimeters of mercury pressure, right? So these are the pressures that you remember. The normal portal pressure is 1 to 5, pre-portal is 6 to 9, portal hypertension is more than or equal to 10. Bleeding in the varices occur when there is more than or equal to 12 millimeters of mercury. So what are the causes for portal hypertension? So the next thing that you need to know is the causes of portal hypertension. Now, when we talk about the causes for the portal hypertension, now the causes for the portal hypertension is divided into various components, right? So when we talk about the various components, let's have a quick recap on that as well. Now take this as the representation of the liver. So when you take this as the representation of the liver, you will notice that this is the portal vein. You have the right portal vein and then the left portal vein. So this is your the right portal vein, the left portal vein, together they form the common portal vein. Now this portal vein per se is formed by the splenic vein and the superior mesenteric vein. The splenic vein will be combined with your inferior mesenteric vein, and all this blood is now going to flow into the portal vein. Apart from that, you will see that the inferior vena cava, which is going to run behind the liver. So this is the side where you see the IVC is present. Apart from that, you'll also notice that the left hepatic vein, the middle hepatic vein, and the right hepatic vein, they all drain into inferior vena cava. This is the basic concept that you have, right? So if I simply label every single thing that we have drawn here, this becomes your splenic vein. This becomes your inferior mesenteric vein. This forms your inferior mesenteric vein. This is your superior mesenteric vein. This happens to be your portal vein. This happens to be your inferior vena cava. These are your hepatic veins. This is your right hepatic vein. This happens to be your middle hepatic vein. And this happens to be your left hepatic vein. So the blood from the splenic vein, from the inferior mesenteric vein, they all flow from the superior mesenteric vein, they all flow into the portal vein. From the portal vein, the blood goes into the liver. Now from the hepatic veins, the blood is going to be now ejected into the inferior vena cava. from the inferior vena cava, it is now going to go into the it is now going to go into the systemic circulation. Which is better, MCH neurosurgery or MCH GI surgery? Please, anyone respond. Beta, you are in a UG class. You are asking about MCH. So I'm thinking that you have done with your MS general surgery. Now, if you're either doing your MS general surgery or you're into your MS general surgery and you're thinking about which one to pick, whether to take a neuro or a gastro, they're two different spectrums altogether. Now, neuro has a different line of work, GI has a different line of work, neuro is more with emergencies, GI is, there are emergencies, but less emergencies are there, the line of work, the handling of tissue, everything matters and differs, right? So, see, choosing a super specialty branch is something is going to be very personal. You need to go see that department, work there for a few months and see which suits you better. Like, do you have a better, orientation and a better acumen towards GI? Go with GI. If not, if you feel, see, don't go with the hype, that the neuro surgery and then you enter it. No, if you really love neuro, go, right? So a lot of things that are associated, like the morbidity and the mortality in neuro is high, the morbidity and mortality in GI is relatively less. You'll have, your patients are much more happier when it is on a GI spectrum, and the morbidity on the neuro part is much more longer. And if you're able to deal with that, why not? Okay? So all that is going to be taken into consideration. Clear? Now, when we talk about the cause of portal hypertension, we're talking about the pressure in the portal vein is going to increase, right? So when you talk about the pressure in the portal vein is going to increase, you need to know where exactly the cause is. So this is going to be the liver, right? This is your left portal vein, the right portal vein, the common portal vein, superior mesenteric vein, splenic vein, inferior mesenteric vein, and it continues off. This happens to be your inferior vena cava, right? What we do is, we are now going to segregate the causes into three spectral components. One, before entering into the liver, we'll be calling it as pre-hepatic cause. We'll see what are the causes which are present in the liver. We call it as the hepatic cause. And the causes that is going to be after exiting the liver, that is a post-hepatic cause. Good evening, sir. I'm in third year. I mean, just second year ended. I'm your huge fan of the Bailey series, and then hoping something great again, like Shushita batch for the third year. Right, thank you so much for such a kind word. We will continue Bailey in Love series, बेटा BLS हम तब तक चलाएंगे जब तक हम अपनी Bailey खत्म नहीं कर देते, ठीक है? So that's a promise. So we will continue to do Bailey. Bailey रोकने का सवाल ही नहीं होता, ठीक है? In between, you will have series like Farre. We'll also do, a private, that Shushita batch 4th year का live batch भी start हो जाएगा. We'll do all that. That all is going to be into consideration. But Bailey नहीं रुकेगी, ठीक है? BLS is something that I want to do it for myself, because I see a huge potential for, medical students all across the world. And I'm telling you again and again, the single best source for surgery, if you want to read, it is going to be BLS, ठीक है? हम उसको ऐसा बना ही देंगे कि कल को लाइफ में अपग्रेड भी हो जाए और कभी कोई सर्जरी में डाउट हुआ ना, तो BLS में आपको उसका जवाब मिल जाएगा. That's a promise, ठीक है? तो BLS is going to be an evergreen series. We will do it. We are not going to halt it at any single cost. करके ही रहेंगे, ठीक है? चलो. Now, let's talk about the causes of the portal hypertension. So I'm just continuing on the same spectrum. Talking about the causes of the portal hypertension. So as I've divided them into three distinctive components. So जो भी cause इस line में होगा, it is what we call it as the pre-hepatic cause. So here it is going to be pre-hepatic cause. This will be the hepatic cause. And here it is going to be the post-hepatic cause. Right? So you have the pre-hepatic cause, the hepatic cause, and the post-hepatic cause. Now, prehepatic cause. In a prehepatic cause, what are the components that you have? In a prehepatic, see, the whole concept here is when you talk about portal hypertension, due to XYZ जो भी reason होगा, portal vein में pressure बढ़ रहा है, ठीक है? अब किसी भी वेसल में प्रेशर क्यों बढ़ेगा? सिंपल सा कॉन्सेप्ट है कि अगर यहाँ पे ब्लड ज्यादा पूल होने लगा, सो द होल आइडिया दैट वी आर ट्राइंग टू बिल्ड अप हियर कि ये पता करने के लिए कि इस वाले वेसल में ना प्रेशर क्यों बढ़ रहा है. किसी भी वेसल में प्रेशर दो ही चीजों से बढ़ता है, या तो वॉल्यूम ज्यादा हो रहा है या तो वेसल छोटा हो रहा है. दैट्स इट. Either the volume in the vessel is increasing or the size of the vessel is decreasing, and that is where a pressure inside a vessel would increase, resulting in portal hypertension or any hypertension per se. तो अब हमको ये देखना है कि ऐसी कौन कौन सी चीजें जो यहाँ पे आपकी प्रेशर बढ़ा सकती हैं by either increasing the volume of the blood, or either it is going to increase the volume of the blood, or it is going to result in decreasing the size of the volume, right here. So number one is going to be portal vein thrombosis. Imagine karo if a patient is having a portal vein thrombosis. If there is a portal vein thrombosis. So when we talk about the portal vein thrombosis, simple sa concept kya portal vein thrombosis mein, if there is a thrombus that is going to be formed in the portal vein, if there is a thrombus that is going to be drawn, present in the portal vein, the size of the portal vein is getting smaller, so obviously the pressure is going to increase. Okay? Along with portal vein thrombosis, imagine if there is any tumor that is going to encircle, right? That is what we call it as the malignant occlusion. If there is malignant occlusion of the portal vein, if there is a malignant occlusion of the portal vein. So either there is presence of portal vein thrombosis, or there is a malignant occlusion of portal vein. In a malignant occlusion of portal vein, you can see a tumor that is going to grow and it is going to encircle the portal vein. Like अगर portal vein को पूरा encase ही कर देता है, encasing the portal vein and compressing the portal vein, and that encasing or compression of the portal vein will increase the pressure in the portal vein. ठीक है, तो दबा दिया. So एक हो गया portal vein thrombosis, एक हो गया malignant occlusion of the portal vein. Along with that, it can also result from a parasitic condition called as schistosomiasis. Schistosomiasis mein you will see there is this parasite which is going to go sit in the portal vein. Now when it sits into the portal vein, it causes an inflammation, chronic inflammation banta hai. And because of that chronic inflammation, there will be fibrosis or there will be edematous component here, not allowing the blood to go into this vein. तो क्या होगा, ज़्यादा पूरा blood यहीं पे पूरने लगा. अब blood जा ही नहीं पा रहा, blood is not able to go into this vein. What is going to happen? जो भी जाएगा इधर जाएगा, rest of the blood will start pooling into the portal vein, resulting in back pressure, and that is going to result in portal hypertension. So portal vein thrombosis, malignant occlusion, schistosomiasis. Another condition, if I just want to complete the list, that is secondary to your congenital hepatic fibrosis. Congenital hepatic fibrosis. All these will result in prehepatic cause for resulting or development of portal hypertension. It is going to be a portal hypertension, right? Now, when you talk about the hepatic cause, now in the hepatic cause, it is secondary to liver cirrhosis. Let it be any reason for liver cirrhosis, XYZ. Ultimately, it is going to result from liver cirrhosis. Ab liver cirrhosis, the concept is quite simple. If the liver is going to get damaged, now imagine if the liver is getting damaged, what is going to happen? The blood that is going to come from the portal vein has to go into the liver. Ab liver damaged, तो blood कहाँ जाएगा? जा ही नहीं पा रहा. Blood बोल रहा जाऊँगा, liver बोल रहा है मैं ठीक नहीं हूँ, मैं लूँगा ही नहीं blood. तो all that blood will start pooling back into the portal vein, resulting in back pressure, resulting in portal hypertension. Next comes is your post-hepatic cause. In the post-hepatic cause, you have a veno-occlusive disorder, example like Budd-Chiari syndrome. So Budd-Chiari syndrome में there is blockage of hepatic vein. अगर hepatic vein block हो गया तो blood liver से बाहर जा ही नहीं पाएगा. अगर blood बाहर नहीं जा पाएगा तो blood will start pooling inside the liver, back pressure, then into the portal vein, resulting in portal hypertension. So not only Budd-Chiari syndrome, any other form of veno-occlusive disorder. Any other form of veno-occlusive disorder. So Budd-Chiari syndrome and the veno-occlusive disorders are the post-hepatic cause. Okay? So these are the causes that results in portal hypertension. 3 different segments of pre-hepatic, hepatic and the post-hepatic causes for portal hypertension. Okay? Now once you know the causes, Let's understand that how does the varices are formed, the pathophysiology of varices. Pathophysiology of varices. So the varices are formed because of development of porto-systemic collateral. So the magic word to remember here is it is due to the development. It is due to the development of porto-systemic collateral circulation. It is because of porto-systemic collateral circulation. It is because of porto-systemic collateral circulation. सर आप क्या सर्जरी करना सिखाओगे? बेटा जिस दिन आप जनरल सर्जरी कर लोगे आ जाना मेरे पास, बिल्कुल सिखा देंगे, ठीक है. यू नीड टू बी क्वालिफाइड इनफ टू लर्न सर्जरी बेटा, ठीक है. ऐसे ही थोड़ा सर्जरी सिखा देंगे. सर व्हाट इज द डिफरेंस बिटवीन पेप्सिन एंड ट्रिप्सिन? हाय काश मैं आपको ये डिफरेंस बता पाता कि पेप्सिन और ट्रिप्सिन में फ़र्क क्या होता है. देखो ये चीज़ें आपको आपका बायोकेमिस्ट्री और मेडिसिन वाले ज़्यादा बता पाएंगे. देखो हम सर्जन ना बड़े सिंपल होते हैं यार, ठीक है. एज अ सर्जन ना हमारा इतना दिमाग चलता नहीं है. अगर इतना दिमाग होता तो मेडिसिन लेके हम भी मेडिसिन कर रहे होते हैं. सर्जरी वालों को इतना ही पता है कि बेटा बेसिक ये पैरामीटर्स हैं और ये एनाटमी है, यहाँ पे प्रॉब्लम है, ये काटा वो जोड़ा, अपना काम खत्म, ठीक है. सो पेप्सिन ट्रिप्सिन लाइपेस यार ये सब आपको अपने बायोकेमिस्ट्री वाले सर हैं, मेडिसिन वाले हैं, उनसे आराम से पूछिए यार. हमसे पूछिए कि सर जीजे क्या होता है, पूछिए कि सर रूएनवाई क्या होता है, ठीक है. जो मर्जी पूछे बताएंगे सर, ठीक है. चलो अभी तो पैथोफिजियोलॉजी ऑफ वायरसेस सुनिए सर. वायरसेस बन कैसे रहे हैं, फूट कैसे रहे हैं, ब्लीड कैसे हो रहा है, ये बताएंगे आपको. सो इन द पैथोफिजियोलॉजी ऑफ वायरसेस नाउ यू टेक दिस एज ए रिप्रेजेंटेशन ऑफ द एब्डोमिनल वॉल मान लेते हैं, ठीक है. So let's say this happens to be the esophagus, this happens to be the stomach, this happens to be the duodenum, let's say this happens to be the jejunum goes into ileum, the ileum goes into appendix, into cecum, ascending colon, transverse colon, descending colon, ठीक है. So we have the ascending colon, transverse colon, descending colon, sigmoid colon, rectum, rectosigmoid, and then to the anal canal, ठीक है. अच्छा. Then you have this area which is guarded by diaphragm, which is here. Then let's say this is the liver that we have. So ये हमारा liver की territory होगी, ठीक है. This is the liver that you have. Just for sake of understanding, let's say this happens to be the umbilicus. पीछे vertebra मान लीजिए, ठीक है. These are the vertebrae that are present. So these are your lumbar vertebrae. Just for the sake of discussion, these are your lumbar vertebrae, ठीक है. The cover that is going to be present throughout is what we call it as the peritoneal cover. So this is the peritoneum, which is separating the intra-abdominal content from the other one. So this is the peritoneal cover that is present, ठीक है. Now portal hypertension में there will be porto-systemic collaterals which are going to be formed. Let's say this happens to be the portal vein that we're talking about. So जब प्रेशर बढ़ने लगता है ना, when the pressure will start increasing inside the portal vein receives the blood from multiple sides, ठीक है. तो अब क्योंकि ब्लड लिवर में जा नहीं पा रहा पोर्टल वेन से, तो पोर्टल वेन विल ट्राई टू फाइंड ऑल्टरनेट रूट्स सो दैट इट कैन सेंड द ब्लड बैक इनटू द सर्कुलेशन. तो पहला ऑल्टरनेट रूट वो बनाएगा आपके ईसोफेगस के साथ. तो ईसोफेगस में जब ब्लड पूल होने लगेगा तो इसमें यहाँ पे वायरसेस विल स्टार्ट टू फॉर्म. So the first is going to be the first portosystemic collateral is formed with the esophageal veins. It is formed with the esophageal vein. The second portosystemic collateral will be formed with the bare area of the liver. तो liver के पीछे ही एक area होता है where there is no capsule. This is called as the bare area of the liver. तीसरा वो बनाएगा आपके umbilicus के around. So you will see that multiple blood vessels are found dilated around the umbilicus. And this dilated blood vessel around the umbilicus is what we call it as caput medusae. So the third portosystemic collateral is here. The fourth portosystemic collateral you will see, देखिए इसके ऊपर ना on the greater curvature of the stomach you have this layer and this is what we call it as the omentum. So this is the omentum that is arising from the greater curvature of the stomach. This is from the greater curvature of the stomach. So you will see that these portosystemic collaterals will be formed with the omental veins. So you will see there will be omental veins पे एक और portosystemic collateral बना हुआ है, ठीक है. So how many do you have? The first one is this, the second one is here, third one is here, fourth one is there. The fifth portosystemic collateral will be found behind the peritoneal surface. So in the retroperitoneal veins, you have the fifth portosystemic collateral. So this is your retroperitoneal vein. Then you will also see that it is going to be formed. You'll say it is also going to be formed with your lumbar vein. So it goes here. So with the lumbar veins also, it is going to develop into portosystemic collateral. So in the lumbar veins also, you have the portosystemic collateral. This is the sixth one. And the last one, which is quite important, this is going to be with the anal canal. So when it forms with the anal canal, it is going to result into internal hemorrhoids. Right, so 7th portosystemic collateral is going to be with the hemorrhoidal veins. Okay. So there are 7 portosystemic collaterals which are formed. I'll just quickly label them also. The first one that we said is going to be your esophageal veins. It is going to be your esophageal vein. Second one is going to be in the bare area of liver. It's going to be in bare area of the liver. The third one is going to be with the periumbilical veins. It is going to be in the periumbilical veins. The fourth one is going to be with the omental vein. The fourth one is going to be the omental vein. The fifth is going to be retroperitoneal veins. It is going to be the retroperitoneal vein. Sixth one, it is going to be with the lumbar vein. And the last one that you have is going to be with the hemorrhoidal vein. So when the portal vein is going to get blocked and the blood is not able to go any further, you will find that there are 7 different sites from where the blood can be given back into the systemic circulation, and this is what we call it as the portosystemic collaterals. Now, even though there are 7 different sites, to be very honest, you only have 3 sites which are going to produce symptoms, right? The 3 sites which are going to produce symptoms are going to be your esophageal veins, the periumbilical veins, and the hemorrhoidal veins. Your esophageal veins is going to present to you as bleeding esophageal varices. They're going to present to you as bleeding esophageal varices. Okay? Periumbilical vein will present to you with dilated veins, and this is what we call it as the caput medusae. The caput medusa is nothing but it, around the umbilicus there's all dilated veins. So medusa ke hair ki tarah you will see all that is going to present. That is called as caput medusae. And in the hemorrhoidal veins, it is going to present to you as bleeding internal hemorrhoids. It's going to present to us bleeding internal hemorrhoids. It is going to present to you as bleeding internal hemorrhoids. So you have the bleeding esophageal varices, you have the caput medusae, and the bleeding internal hemorrhoids. Clear? So these are the one. If they ask, what is the, just to mention it, remember the most common clinical presentation. The most common clinical presentation of bleeding of portal hypertension is going to be bleeding esophageal varices. It is going to be the bleeding esophageal varices. This is going to be a bleeding esophageal varices. The most common clinical presentation for the portal hypertension, it is going to be your bleeding esophageal varices. Clear? Clear? Now everybody is clear with how the upper GI bleed is classified. What are the causes? How does the esophageal varices formed? What is the concept of portal hypertension? What are the causes of portal hypertension? Then what is the pathophysiology of varices formation by developing into a portosystemic collateral? What are the different sites for the portosystemic collaterals, right? Now let's talk about the management of the bleeding esophageal varices. management of bleeding esophageal varices. Now, we talk about the management of the bleeding esophageal varices. It's a protocol-based approach, so we'll try to keep it in the same context. ठीक है बेटा, डायरेक्टली बीटा ब्लॉकर नहीं देना ना, पहले आपको सोचना है, देखना है, एसेस करना है. हर अपर जीआई ब्लीड आपका पोर्टल हाइपरटेंशन से नहीं होता ना, so just let's have some common sense about it. So any patient who is going to have bleeding esophageal varices, he is going to present to us with upper GI bleed. So patient की जो presentation होगी, it is going to be with upper GI bleed. ठीक है? Now here's an interesting thing that you need to understand. I've seen a lot of patients with portal hypertension, with esophageal varices, when they come, when they start throwing up blood, when there is a lot of, hematemesis that is going to occur, it is not going to be in a small kidney tray or a small ball. You give a bucket because that's how the extensive the vomiting would be. मैंने काफी patients देखे हैं, especially coming from a rural background, no, उनके attendants को पता नहीं होता करना क्या, they would have stuffed their mouth with the entire towel. जैसे towel निकालोगे, it is drenched in blood. ठीक है? तो ऐसे patient जो upper GI bleed के साथ आपके पास land हुआ ना, तो मेरा यहाँ पे ऑब्जेक्टिव ये नहीं है कि डायग्नोसिस बनाना है, मुझे स्टेबलाइज करना है. सो द फर्स्ट स्टेप, सो द स्टेप नंबर 1, इट इज टू सिक्योर 2 large IV cannula. It is to secure 2 large IV cannula. Start the patient on IV fluids, usually starting with ringer lactate. Start the patient on ringer lactate. Right, so secure 2 large IV cannula, start the patient on IV fluids, maintain the systolic blood pressure should be more than 80 millimeters of mercury. Systolic blood pressure should be of more than 80 millimeters of mercury, and then you can give vasoactive drugs also, right? You can give vasoactive drugs. So as an initial shot of vasoactive drug, you can have somatostatins and all that. Right, so you give 2 large IV cannulas, start the patient on ringer lactate, give more than 80 maintain the systolic blood pressure more than 80 millimeters of mercury, and if required, give vasoactive drugs also. Once you started to give fluids and resuscitate, you will notice whether the bleeding is persistent or not. So once you have done this, you have to see whether the bleeding. So we'll try to assess the status of bleeding, whether it is present or absent. So you'll notice the status of bleeding if it is present, or if the status of bleeding if it is absent. Right? If it is absent, good. If bleeding is still present, if the bleeding is still present, I have to stop the bleeding. Right? So in order to secure and try to stop the bleeding, so I've started with the IV fluids, I have gone with the resuscitative protocol, and the bleeding continues to happen. If the bleeding continues to happen, I can consider here for blood transfusion, and at the same time I can also consider for the drugs which are going to stop. Right, so here I can okay, when you talk about, there are a lot of if and but that what drug should be given. The somatostatin that you have given here is your octreotide. So somatostatin analog, that is octreotide. So here if the bleeding continues to happen, you can repeat the injections of octreotide. Injections of octreotide. You can also give terlipressin. You can also give drugs like terlipressin in order to control the bleeding. Now, even after doing these two, right, you have tried blood transfusion as well as terlipressin. If bleeding continues to happen, then you have to go with a protocol which is called as a balloon tamponade. You have to go ahead with balloon tamponade. Now, what is this balloon tamponade is? It is basically to exert pressure and stop the bleed, right? So how are you going to achieve this, right? So there is a balloon which is called as a Sangaskian-Blakemore tube. I'm going to insert the Sangaskian-Blakemore tube into your stomach, right? So if this is the esophagus here, now this is the SBT tube that goes in, And this Sangaskin Blakemore tube has two balloons. One is called as the esophageal balloon, which are going to inflate here. Another one is the gastric balloon, which are going to inflate here. Now, because the varices which are going to be arising, they're going to arise from the lateral wall. So when these balloons are, inflated, they exert pressure onto the lateral wall. And when they exert pressure onto the lateral wall, the bleeding will stop. It's as simple as that. So balloon tamponade can be tried in order to, for controlling the bleed. And this is done with the help of a tube that is called as the Sangaskin Blakemore tube. Now, in the Sangaskin Blakemore tube, you can see there are two balloons. This is your esophageal balloon. Now, the esophageal balloon, when you are going to inflate, the esophageal balloon, it is going to be inflated with air, and this is going to be inflated with 40 millimeters of mercury pressure. This is what we call it as the gastric balloon. So when you talk about the gastric balloon, it is also inflated with air, but this time it is going to be inflated with 300 ml. So the volume of air which is going to be pumped in here, right? So balloon tamponade will be tried in order to stop the bleeding, right? Now by hook or crook, once the balloon tamponade is done, I would be able to achieve that the bleeding is going to come to a halt. Here we are going to see that the bleeding is going to come to a halt, right? Now when the bleeding controls, right, if the bleeding controls, so after balloon tamponade, again there are two components. Either the bleeding will continue to happen, or if the bleeding continues, or stops. If bleeding continues to happen or persistent or rebleed is there, here the only thing that is going to be your surgical intervention. We'll talk about it. What is the surgical intervention? If it continues to bleed, then you have to bypass, shunt create करके blood को देखना पड़ेगा. Now, if bleeding stops, I would now want to know that why did it bleed in the first place. So we have done two-step method. No, the step one is going to be this, and if the bleeding continues, this is your step 2 protocol. Okay. Now we are moving to step 3. Step 3 is evaluation. So in step 3, I want to know that where did it bleed from, right? So in order to know this, I'm going to perform an upper GI bleed. Okay. So upper GI endoscopy. I'm going to do an upper GI endoscopy to know from where the bleeding was occurring. As simple as that. Now, जैसे मैंने upper GI endoscopy किया, I'll be able to find that there is presence of esophageal varices. ठीक है? So once you do an upper GI endoscopy, remember before doing an upper GI endoscopy, remember you have to perform a gastric lavage. This gastric lavage should be done with normal saline, right? Now this lavage should be done with a room temperature normal saline, because if you use warm, it will cause vasodilation and bleed, and if you use cold, it causes platelet dysfunction. So gastric lavage should be performed at room temperature normal saline, and then do an upper GI endoscopy. Now once you have done an upper GI endoscopy, you will identify the source, that is going to be your esophageal varices. The step 4 is what we call it as, it is going to be your EVL. EVL stands for endoscopic variceal ligation. It is your endoscopic variceal ligation. It is going to be an endoscopic variceal ligation. That means it's nothing but banding. So the EVL endoscopic variceal ligation, this is also known as variceal banding. This is also known as variceal banding. Okay. Now, if it reoccurs even after banding, so if it rebleeds after EVL, then you have to go ahead with surgical intervention. So this is an indication that you have to take the patient for intervention. So in an intervention, the ideal intervention that we have as of today is what we call it as TIPS. Now, TIPS stands for transjugular. It is transjugular intrahepatic. It is a transjugular intrahepatic Porto-Systemic shunt. Porto-Systemic shunt. It is a transjugular intrahepatic porto-systemic shunt, and that is what we call it as TIPS, right? Now, what do you do by TIPS? So the basic objective of the TIPS is you take this as a representation of the heart, right? It is divided into 4 chambers. Take this as a representation of liver, and here where the problem is portal hypertension is happening, right? So what you're going to do is, this is your left portal vein, this happens to be your right portal vein, and this continues here. On the other hand, this is going to be your left hepatic, right hepatic vein, the middle hepatic vein, and the left hepatic vein. Together, they all combine together to form inferior vena cava. So this is the IVC which is going here. It opens onto the right side of the heart, right? So this is what is happening. Now, here it is your superior vena cava which is here. It is going to be into the right and the left jugular vein. So this is the right jugular vein. This happens to be your left jugular vein, right? So this is the whole objective. So this happens to be your right atria. This is your right ventricle. This is your inferior vena cava. This happens to be your right hepatic vein, and this happens to be your right portal vein. In the TIPS, I'm going to go ahead with right jugular vein. So what we do is, we take a guide wire. We cannulate the right jugular vein. I'm going to go into the right atria. From the right atria, I'll go into the IVC. From the IVC, I'll go into right hepatic vein. From the right hepatic vein, I'll go into right portal vein. Once I reach to the desired site, now I'm going to deploy my stent, and the stent will be placed between the right portal vein and the right hepatic vein. This is where you have deployed the stent. So this is where I have deployed the stent, right? So the minute I deploy the stent, what is going to happen? The blood that is flowing into the portal vein, with the help of stent will now directly go. With the help of stent will directly go into the hepatic vein, from there into the IVC, and then into the right atria, right? So you're bypassing it. Now, obviously, when you bypass it, the volume of blood in the portal vein will decrease, and the portal pressure will also reduce, and this is what we call it as TIPS. So what are the points that you have to write with respect to TIPS? Number 1, in the TIPS, right, it is the right jugular vein. The right jugular vein is cannulated. It is cannulated with Roche needle. Okay. So the needle's name is important. So we have cannulated with Roche needle. Now once it is cannulated, the shunt is placed. It is placed between the right hepatic vein and the right portal vein. The right hepatic vein and the right portal vein, right? This is the concept of the TIPS that we have. Now, once you have linked, what is the problem? Now, we all know that the portal blood is rich in ammonia. It converts into urea in liver, it goes. But now what is going to happen? This ammonia rich blood is going to go. It is not going to liver, it is directly going into the circulation. So ammonia rich blood reaches into the circulation, resulting in encephalopathy. So the most common complication that is associated with TIPS, is going to be encephalopathy. It is going to be your encephalopathy, right? Hi Vishal, thank you. Right, so this is the component of TIPS that you have. Now, what are the other indications for TIPS? Where would you like to do? Other indication. The other indication for TIPS. Now talk about what are the other indications for TIPS. Number 1, it is what we have discussed it now. That is your refractory variceal bleeding. That means we tried everything, all medical management, it didn't work. Then you'll go with TIPS. Second, if there is presence of acute variceal bleeding, you can go to the algorithm. I have mentioned it there also. Acute variceal bleeding. There also you'll go ahead with TIPS. Then you have refractory ascites. Then you have the refractory ascites. Hepatic hydrothorax. hepatic hydrothorax, hepatorenal syndrome, hepatorenal syndrome, portal hypertensive gastropathy, portal hypertensive gastropathy, portal hypertensive gastropathy, Budd-Chiari syndrome. All these are the current indication for TIPS, right? So what are the other indication of TIPS? Remember all these points. Refractory varicose bleed, acute varicose bleed, refractory ascites, hepatic hydrothorax, hepatorenal syndrome, portal hypertensive gastropathy, Budd-Chiari syndrome. All these are the indications for TIPS. Okay. Now what are the indication बता दो, contraindication भी बताना चाहिए. What are the contraindication for TIPS? What are the contraindication for TIPS? What are the contraindication for TIPS? ठीक है. Currently when you talk about the contraindication for TIPS, क्या क्या है हमारे पास? Number one, if there is a right-sided heart failure, obviously no. अगर राइट साइड का हार्ट काम नहीं करा ढंग से और आप ज्यादा ब्लड दोगे तो ज्यादा लोड दे रहे हो राइट साइड पे, तो पेशेंट हार्ट बोलेगा मेरे से नहीं होगा. ठीक है. सो राइट साइडेड हार्ट फेलियर, the right-sided heart failure, pulmonary hypertension, hepatopulmonary syndrome. देखो हेपाटोरीनल सिंड्रोम के लिए इट्स एन इंडिकेशन, हेपाटोपल्मोनरी सिंड्रोम के लिए इट इज कॉन्ट्राइंडिकेशन, क्योंकि हेपाटोपल्मोनरी सिंड्रोम विल रिजल्ट इन पल्मोनरी हाइपरटेंशन. पॉलीसिस्टिक लिवर डिजीज, polycystic liver disease, polycystic liver disease, encephalopathy, portal vein thrombosis. Now already if there's a portal vein thrombosis, no, and you do if you put a shunt, what is going to happen? That thrombus is going to migrate, result in your embolism, right? It will result in pulmonary embolism. You don't want that to happen. So portal vein thrombosis or any hypervascular liver tumor. If any one of them is present, it is a contraindication for TIPS. If you want to know even more, I can say the first 4 is an absolute contraindication. And the next 3 is your relative contraindication. Your relative contraindication.